Yes, ma'am.
Okay, so
I have
good
not
morning.
displayed my CV here purposefully because we were supposed not to present our CV, not to waste time. So I have not included for this paper. So is it okay? Do you have it?
Okay. So I welcome Dr. Sneha. And
Sir, just a second, sir. Just a second. Let me just start the hall. I'll just tell you, sir.
Yeah.
So good morning, everyone. I welcome all of you to this West Zone Yuva Fogsi, hosted by the Navasari OBGYN Society. Yesterday we had a wonderful program, well attended by many delegates. So today we hope to have a similar session, and of course the hard work and the dedication was totally shown by the Navasari OBGYN Society, and it was a wonderful program yesterday, and today also I'm sure we'll repeat the feat. We had an attendance of a tune of almost 900 people yesterday, which is wonderful considering this COVID times. So welcome all of you today morning. So I would like to introduce the chairpersons for this session, Dr. Mahendra Soni sir. So sir is the founder, president of the Himmatnagar OBGYN Society. He hosted the SOGO conference in 1994, a very senior faculty. So welcome sir to this platform. And with him to chair this session, we have Dr. Mili Dodia ma'am. She is a senior consultant OBGYN practicing in Jamnagar. Being the professor and HOD at the Sri MP Shah Medical College in Jamnagar. So welcome, ma'am. So now I would request the chairpersons to take over the platform and please introduce our first speaker, Dr. Sneha Buyar, ma'am.
Yes. Priyansu, is there CV of Sneha? Meenakshi Ben?
Yes, sir.
Is there CV of Sneha Ben?
Sneha Madam is a breast committee chairperson current at present in Fogsi, sir.
Okay. And
she is a very good surgeon and her area of interest is high risk obstetrics and breast cancer.
Right.
Yeah.
So I request Dr. Sneha to start her.
Good morning, Dr. Soni, sir, and Dr. Mili. Thank you for that kind introduction, sir. Just for our introduction, I repeat, I'm chairperson, breast committee, Fogsi, and I'm a governing council member, ICOG as well. I'm national adolescent trainer, and at present, I'm national coordinator for UNICEF as well. So with the short introduction, just to know each other, I start with my today's talk, and that is on shoulder dystocia. I have been practicing as a high-risk obstetrician since last 29 years in the city of Yavatmal, and it's my pleasure to talk on this topic. So, as you all know, birth is intensely emotional for the mother as well as for the baby. And of course, it is intensely physical as far as the obstetrician and the laboring woman is concerned. As we all know, second stage is very, very unpredictable. And we all wish it was very easy as it is shown in the movies, just 3 pushes and the baby is out and everybody is smiling. But this is not so. We have parthographs to monitor during the first stage of labor, and we have up to management of third stage of labor for the third stage. But there are no definite guidelines as far as the second stage is concerned. May it be the duration of second stage, may it be just the duration of delivery from head to rest of the body. And that is why we are so much, less guided or less sure about this second stage complications. So when the baby's head is delivered, suppose we talk about the cephalic presentation, when the baby's head is delivered, the time taken from delivery of head to rest of the fetal body, the duration should be approximately 24 seconds. We can stretch it max up to 60 seconds. If it goes beyond 60 seconds, it is due to impaction of the anterior shoulder behind the symphysis pubis. This is according to the Williams obstetrics, and use of any other maneuver to release the shoulder after gentle downward traction has failed. Normally, we need to give downward traction. If that has failed and if it requires some additional maneuver to release the shoulder, then it is labeled as shoulder dystocia. That is according to RCOG 2005. The incidence of shoulder dystocia is 6.14. It is so less than. Why is it so important? Yes, it is very important because it's an obstetric emergency, and I'm sure it is a nightmare for obstetricians, those who have faced so many complications. Maternal morbidity is very high, maybe even mortality because of the associated postpartum hemorrhage. Increased fetal morbidity and mortality, of course, is associated. So, what are the maternal impacts? Postpartum hemorrhage to the tune of 11%. May it be atonic, may it be traumatic. The trauma can be so severe that it may require some major operative interventions because of third and fourth degree tears. Symphyseal diathesis and uterine rupture, they are rare, though can happen. Fetal impact, fetal injury, and fetal hypoxia, these are the two major concerns. Brachial plexus injury to the tune of 4 to 16%. Fractures of clavicle and humerus because of handling and traction on the upper arm. Fetal hypoxia leading to neurological damage and even death can happen. Brachial plexus injury is the most important fetal effect. It is observed to the extent of 4 to 6%. And this is, as I've said, because of the downward traction which we give on the fetal neck. This is independent of the operator's experience. But the good news here is that it is reversible within first 6 to 13 months. So that is how not much to worry. But yes, definitely sometimes you can land up into litigations because of these issues. Because it is such a dreaded emergency, you may lose the baby. Sometimes you may lose the mother as well. And that's the very reason prediction, prevention, and preparedness, all these things which are necessary for obstetric emergency are required. Here, as you can see here, shoulder dystocia is not always predictable. Even an average size baby may land up into shoulder dystocia. That is why it is not totally predictable, not totally preventable, but yes, there is definitely some room as far as prediction or anticipation is concerned. And for that, we should know what are the antepartum risk factors. Diabetes mellitus, obesity, postpartum pregnancy, past history of shoulder dystocia, and excessive baby weight. These are all the antepartum factors which can predict you that yes, she may go for a shoulder dystocia and you have to be ready. There are certain intrapartum factors. Suppose you have a patient with labor dysfunctions, various abnormalities of the labor, the uterine contractions are asymmetrical, they're not very well coordinated, they're not very effective, leading to progressive cervical dilatation. So you have prolonged or protracted first stage of labor, prolonged second stage of labor, and maybe you need to augment the labor sometimes by oxytocin. So you get very good contraction, effective pushing by the mother, so the head just escapes, but the shoulder gets stuck. Sometimes you feel that she will deliver and you try and attempt mid-pelvic instrumentation, ventouse or forceps. I think nowadays nobody is practicing this, but yes, some people are still practicing and they may land up into shoulder dystocia. So prediction and prevention is out of question. Only thing what you remains in your hand is preparedness. So you have to anticipate and be ready. Educate the patient, involve the family that yes, sometimes maybe there is a possibility that she may land up into shoulder dystocia. So a senior obstetrician has to handle this case. And of course, anesthetists and neonatologists should be around. We have to just empty the bladder, stay calm and act fast. We have to use the mnemonics helper. How? We're going to have it in detail. Now, how do we recognize that shoulder dystocia is happening? Because if we can detect it at the earliest, we can manage it effectively. You find that this she's getting good uterine contractions, she's fully dilated, fully fixed, she's pushing as well, very well, but the crowning is little slow. You need to retract the perineum to see the face of the baby. Cheeks are fatty, and the head is, it is drawn tightly against the perineum. The restitution is very, very slow, or maybe it doesn't occur. The usual downward traction which we give on the fetal neck just for the delivery of the anterior shoulder doesn't happen, and the face starts becoming congested. This is how you recognize that yes, you are heading towards shoulder dystocia. But what are the things you are supposed to do? You're not supposed to ask the patient to push or your assistant to push or give fundal pressure. You are not supposed to pull the baby. Do not panic, but act fast. And this is the mnemonic helper. Call for help, evaluate for episiotomy, legs, suprapubic pressure, enter the rotational maneuvers, remove the posterior arm, and roll over the patient. So this is all the mnemonic. Now we will be talking about the details of this. Call for help. You have to call for help, all your staff, your assistant doctors, neonatologist and anesthetist. But of course, for preparedness of your staff, definitely you need to conduct the shoulder dystocia drills, who will hold the legs up and who will give suprapubic pressure. So all these kinds of drills have to be performed regularly so that your staff is also ready to help you effectively. Episiotomy, though there are lots of debates going on as far as the need of the episiotomy and the litigation as well. We need not go into the details because here for this patient, we are going to perform the maneuvers and we require to give episiotomy. So episiotomy, which should be a generous episiotomy because we want to perform the maneuvers. And each step, every maneuver has to take at the most 30 to 60 seconds. For a total of 3 to 5 minutes, we can give for these maneuvers and the baby should be out. There's no indication that one maneuver is superior over the other. They just represent a valuable tool to help the clinician to take effective steps to relieve impacted shoulder. Now we come to the L part of this, that is legs, the macroburst maneuver. Now, when the first diagram shows the normal supine position or maybe just the lithotomy position where the symphysis pubis, it is diagonally oriented. But the moment you ask the patient to hyperflex the thighs on the abdomen, the pelvis is tilted up and the symphysis pubis, it is directed more horizontally. So it facilitates the shoulder delivery. So that's a very reason just taking up the thighs on abdomen will give you roomy space and the shoulder slips and gets delivered. So macroburst maneuver is very, very effective. Of course, it can be helped more by the suprapubic pressure. Ask your assistant to give suprapubic pressure. Now, how to give this suprapubic pressure? There are two ways. One is Musanti and the other is Rubin. For Musanti, your assistant just makes a fist of your one hand and just give a direct posterior push on the anterior shoulder, which is impacted there. So it slips and comes beneath the symphysis pubis and gets delivered. In Rubin's, your assistant gives a lateral pressure on the posterior aspect of the anterior shoulder. There is no difference in the efficacy as far as is concerned. But yes, definitely, whether you give continuous pressure or you give intermittent pressure, it's going to help anyway. This is just a picture. I have not included video purposefully to avoid the technical hassles, but I have included diagrams which are self-explanatory. Here you can see the assistant is doing two things with one hand, making the macroburst position as well as giving suprapubic pressure on the anterior shoulder, that is by Musanti method. We come to the next part, that is the enter. internal maneuvers. Whatever maneuvers you have to do with your internal hand, you have to put your hand in vagina and do these maneuvers, Rubin's and wood screw. Rubin's again has two maneuvers, rocking the fetus from shoulder side to side. The fetus you just rock from side to side so that you can easily disimpact the shoulder and deliver the baby. If it doesn't help, then you put your hand inside, reach the easily accessible shoulder and try to push it forward. I'm showing you here in this picture. This is the right hand of the operator reaching the easily accessible shoulder and just rotating it forward. If that also doesn't help, then we go for wood screw methods. We have to put your hand inside posteriorly, reach the posterior shoulder, and then you turn the posterior shoulder anteriorly with this movement of 180 degrees. So you can easily rotate it. If you have tried it, you can get it. On the other hand, this is the picture I'm trying to show. The posterior shoulder here with this is rotated anteriorly. If this also doesn't help, you can try the reverse corkscrew. That is posterior shoulder from behind, or you can pull the anterior shoulder posteriorly, and then you can
1 minute to go.
Yeah. So this is just you insert your hand, you try to flex the elbow here, just sweep the hand over the chest and deliver the posterior arm. If this also doesn't help, then you can use this all fours. You ask the mother to rotate, roll over on all fours. Gravity and the movement itself helps. This position improves the obstetric conjugate by 1.5 centimeter. If everything fails, then of course, deliberate clavicular fractures, Havanelli's maneuver, symphysiotomy, clitotomy, abdominal surgery, yes, all these things. So just to conclude that no single approach is very clearly effective or safer over the other. The initial choice of the order of progression is at the provider's discretion. Begin with the least invasive approach and do all the maneuvers fast. Whichever maneuver helps you to deliver the shoulder, disimpact the shoulder is the best. Of course, some experts suggest beginning with the delivery of the posterior arm as we have seen it as the last procedure. Because the success rates are high, they can definitely help you. This is what I have already covered. Just to the last slide, the take-home messages is always predict, prevent, and be ready. Don't panic, be calm, but act fast. That is how you can deal with shoulder dystocia very effectively. So let us pledge to make birthing safe. Thank you so much once again for the invitation. I thank all the organizers for giving me this opportunity, and thank you all the attendees for listening to me patiently. Thank you so much.
Thank you, Dr. Sneha, for our very good subject and particularly important for a young gynecologist and for elaborating very well. Thank you. Thank you very much.
Thank you so
Thank
much,
you.
Chairperson.
Thank you so very much, Mahendra sir and Sneha ma'am, for the wonderful talk as usual. It's wonderfully done. It was a beautiful beginning to the program with these beautiful demonstrations of shoulder dystocia. So thank you, ma'am, for that. So next, we move on to the next talk by Dr. Meenakshi Ben Patel on fluid therapy in obstetric hemorrhage. And I would request Dr. Mili Dodia ma'am to kindly introduce her. Mili ma'am, requesting you to unmute yourself, please. Mili ma'am, requesting you to unmute yourself, please. You're on mute, ma'am.
Is it okay, sir?
Yes, ma'am, you're audible now. Please go on, ma'am.
Yes. Extending a very warm welcome to Director and Consultant of Sunshine Global and Baroda Hospital, Dr. Meenakshi Patel, having 29 years of experience, especially in the field of laparoscopic surgeries. Over to you, Dr. Meenakshi.
Thank you, madam. there is a need of fluid therapy in obstetric hemorrhage. In India, 20 to 30% death occurs due to obstetric hemorrhage. Hemorrhage can be revealed or concealed, likely to endanger the life. Bleeding in a pregnancy occurs after 24 weeks after 24 weeks or during labor or after the childbirth, can be concealed or revealed, is called as hemorrhage. High risk women losing more than 1 liter of the blood should be advised to deliver in a setup with an ICU and blood transfusion facilities are available. Now, in obstetric hemorrhage, the blood is demanded depending on the amount of the lost blood volume. And in a class 1, severity of the shock and loss of the blood less than 750 ml, no need to transfuse unless the volume loss is superimposed on a pre-existing anemia or patients with a severe cardiac or respiratory diseases. In class 2, 800 to 1500 ml of the blood loss, there is a need to transfuse the crystalloids or synthetic prolloids. Need for RBC transfusion in a patient with a pre-existing anemia or continuing blood loss. Now, coming to the class 3 and class 4. In class 3, when loss is 1.5 to 2 liters, young healthy woman can still be treated with a crystalloids therapy, but transfusion is also recommended. In class 4, there is a rapid volume replacement is required, including along with that, PCV and blood component transfusion is also be demanded. You have to look for the shock index also. Shock index is heart rate divided by systolic blood pressure. Now, coming to the pathophysiology of the hemorrhage, in pregnancy, total body water slowly increase up to 6 to 8 liters due to retention of sodium 500 to 900 milliequivalent. That leads to rise in the plasma volume in first, second, and early third trimester. And at term, plasma volume rise up to 50%, cardiac output up to 30 to 50%, and heart rate by 10 to 15 per minute. Plasma and colloidal oncotic pressure fall throughout the gestation. There is increase in capillary hydrostatic pressure. Increased capillary hydrostatic pressure and decreased plasma COP may overcome the delicate balance and favor the edema in later pregnancy. After delivery, further fall in the plasma COP returns within 24 hours. Now, delayed or inadequate resuscitation with a continuous blood loss, secondary changes occur into the microcirculation. Initially, interstitial fluid enters into the capillary bed. Then that leads to damage to the capillary endothelial cell, increased permeability, and leakage of the fluid back into the interstitial space. Finally, organ ischemia and cell death results. Normally, vital signs do not necessarily denote the presence of significant blood loss, and all these factors leads to delay in diagnosis associated with delay in therapy. In early hemorrhage, vascular tone has to increase, like heart rate, and myocardium contractility increases to improve the oxygen delivery to the tissue. Cardiac output is redistributed selectively to maintain the perfusion of the adrenals, brains, and heart at an expense of inner organs like uterus. If it occurs before delivery, it can lead to fetal hypoxia, fetal distress, and demise can also occur. So, fluid therapy is an integral part of a treatment of obstetric hemorrhage, require early, balanced, and focused fluid replacement in the early stage. Now, for selection of the fluid, as OCIG has also recommended, crystalloid solutions commonly used for the initial resuscitation. RL is the first choice. Second is the sodium NS, that is due to potential for the hyperchloremic acidosis, so it is on second choice. Crystalloids distributed primarily throughout the extracellular space, expand both intravascular and interstitial compartment, and effective in restoring preload cardiac output, but contributes to the hemodilution. Hey, 1 liter of the RL, if you give, that 200 will go into the vascular compartment and 700 will enter into the interstitial compartment. So 3 liters of the crystal will be 1 liter of the loss. Studies, so for the hypertonic saline with a smaller volume, it can gain the all oxygen delivery and tissue consumption, but due to hypernatremia and hyperosmolarity not used in the obstetric hemorrhage. In severe hemorrhage, the goal for restoring oxygen delivery to the tissue is achieved by initial intravascular volume replacement, and that improves the perfusion. But significant blood loss results in decreased oxygen carrying capacity and need transfusion for improving the perfusion of the tissue and cardiac output. Isotonic saline. Severe hemorrhage, PCV and blood component therapy is used to prevent the consumptive coagulopathy and has largely eliminated the use of whole blood in a hypovolemic shock. Isotonic crystallizer is the first choice for the resuscitation until the blood and blood products are available. Now, colloids with a larger molecular weight, distribution is limited to the intravascular space. Intravascular volume is expanded with a little increase in the interstitial volume, but no advantage over the crystalline. Dextran and hetastat. In hetastat, amylase is increased for 24 hours and high chances of renal injury. And side effects all of a sudden that increases the bleeding time. 5% albumin and 25% albumin also used for the volume expansion. 1 gram increased plasma volume by 18 ml and half-life is 16 hours. In patients with shock, it increases COP for 2 days. And adverse effect increases APTT. Volume expanders may be given to prevent or treatment of the shock caused by the fluid loss. Now, coming to the goal, if you compare, volume expands but costlier effects. Anaphylaxis 0.4%. It impairs clot formation and increases the blood loss, decreases the GFR, UOP, and high chances of ARF with use. Delay in diuresis of excess of fluid. Crystalloids also needs in a larger volume for the expansion effect lasts for a less period of the time, good in preserving renal function better than the colloids. For the whole blood, half-life is less than 7 days, platelets factor 5, factor 7 and 11 becomes inactive. After 24 hours, only RBC cannot be used for the massive transfusion. You have to separate whole blood into different components. One unit can save several patients. And PCV is the choice for the treatment of hypovolemic hemorrhagic shock. One PCV can increase hemoglobin by 1 gram. Aim for the fluid therapy is to improve the cardiac output and tissue perfusion, to provide the electrolytes, correct the acid-base disorders and artificial nutrition. And one important point, effort should be made to control the blood loss. And aim is systolic should be 90, output, urine output 0.5 to 1 ml per kilogram, and normal mental stress should be maintained, avoid overzealous replacement. Coming to the complications of the fluid therapy, dilutional aggressive therapy can lead to dilution of the coagulation factor and viscosity, leads to high hemorrhage, shock, and leads to poor maternal outcome. Dysnatremia and electrolyte abnormality for the saline, excessive chloride, metabolic acidosis, excess of crystalloids, acidosis, coagulopathy, and impairment of the microcirculation can occur. Uncontrolled shock, hemorrhagic leads to hypothermia, acidic, and coagulopathy. For diagnosing fluid overload, bounding pulse, pulmonary crepitations, peripheral edema, dyspnea, hypertension, and jugular vein distension. Current guidelines, systolic should be 90, diastolic more than 50, and heart rate less than 120. Resuscitation of the fluid should be twice the amount of the blood loss. Sodium, NS or RL, 2 liters should be administered fast. Or if you are administering crystals, then 1.2 to 1.5. Blood loss is 500 to 750 ml. For fluid replacement, 1 times of the blood loss. Loss is 1000 ml, it should be 1.5 to 2 times. If it is more than 1500 ml, then it is to be considered under the massive hemorrhage protocol. Rule of 30. Hello. Fall in systolic blood pressure by 30, heart rate increase by 30, and respiratory increase by 30, and UOP less than 30, it is called 30%. Shock index, heart rate divided by systolic blood pressure, can be an accurate indicator for the compensatory changes in the cardiovascular system due to blood loss. Crystalloids used for maintaining the tissue perfusion. For recognizing massive PPH, rule of 30 plus shock index more than 1, fall in hematocrit by more than 30% and base more than 6. Rule of 50 and more than 50% blood volume loss without replacement will be fatal. So if no replacement will be given, organ cell damage occur. Hemoglobin less than 5 grams despite fluid replacement can cause organ failure or death also. Organ cell damage will not occur if 100% blood volume loss is replaced with the fluid replacement. So give fluid to save the life. Massive transfusion, as all of us are knowing the definition, aim for the massive transfusion, temperature should be normal, acid-base status pH more than 7.2, base excess less than -6, and lactate less than 4. Ionized calcium more than 1. Hemoglobin should not be used alone as a transfusion trigger. It should be interpreted in context with the hemodynamic status, organ and tissue perfusion. platelets should be more than 50,000, PTA-PTT less than 1.5, fibrinogen more than 1 gram. After doing all these things, when goal in obstetric patient when to stop, hemoglobin should be more than 8, platelet more than 75,000, PTINR less than 1.5, fibrinogen more than 1 gram. And according to RCOG 2015, RBC FFP and platelet ratio should be 6:4:1, and plasma RBC and platelet ratio according to RCOG should be 1:1:1. Coming to the whole blood, acute loss more than 25% at that time it is indicated unless emergency and non-availability of the components. Massive transfusion of stored whole blood can lead to dilutional thrombocytopenia, coagulation factor depletion, acidosis, and hypothermia. And per liter of the transfusion, 10% 10 ml calcium gluconate should be given. Component therapy helps to correct the specific deficiency of the patient. Avoid use of unnecessary component which could be contraindicated in patient. RCOG guidelines for the massive transfusion and hypovolemic hemorrhagic shock. Each unit should have their own protocol for massive obstetric hemorrhage, and all staff should be given training for that. Place the patient in a tenable position. Take a 2 wide bore needles. Start initial resuscitation with a replacement of the fluid if it's crystalloid 3 ml per ml of the blood loss, and restore the blood volume colloid 1 ml per ml. Monitor RBC replacement with a hematocrit and initial packed cell transfusion to restore the oxygen delivery to the tissue. Rapidly use the coagulation screen to guide and monitor the use of blood components, and repeat serial estimations every 4 hourly or more often after the component therapy. Fresh frozen plasma component therapy. Its dose should be 10 to 15 ml per kilogram. You can give A plasma to A and O, B to B and O patient, O to O patient, and AB to anyone. Plasma never used for fluid replacement. It increases the factors by 15 to 20% level. Coming to the cryo, dose should be 1 to 2 units per 10 kilogram, and goal should be 100 milligram per deciliter. Patients on massive transfusion protocol receiving more than 10 FFP generally not required any additional cryo because they have received adequate bolus of the fibrinogen in large quantity of the FFP. No NTD prophylaxis for Rh negative mother who receives positive. Coming to the platelet and guidelines for the platelet therapy. If it is more than 40,000, you may give, you may not give. 20 to 40,000, if major bleeding or in any invasive procedure, give. 5,000 to 20,000, febrile condition and minor bleeding, coagulopathy or minor procedure is to be taken, give. Less than 5,000, always give platelets. Time and rate for the transfusion, whole blood and RBC, PCV, in less than 30 minutes after removing from the refrigerator, you should finish it with less than 4 hours, and whole blood rate should be 150 to 200 ml per hour and PCV 100 to 150. Platelet and various blood components immediately as soon as you remove it from the refrigerator, you should complete it within 30 minutes and 150 to 300 ml per hour. Things to remember, blood transfusion is needed during obstetric hemorrhage, but along with blood transfusion, fluid management is equally important to avoid the overload complications. Never use any solution in excess. Excess of crystalloids can lead to anemia, shock, and coagulopathy. Non-oxygen carrying solutions are used to restore the intravascular volume in mild and moderate hemorrhage cases, but in severe hemorrhage cases, crystalloids, colloids, plus blood and blood components are required. Thank you. It doesn't matter how you get there. Please get there anyway. You can save the life of a woman with a fluid and a blood. Thank you very much.
Thank you, Dr. Meenakshi. You have really elaborated the topic very well, a topic which is often ignored and due to ignorance. Anyway, thank you so much.
Thank you, ma'am, and Meenakshi ma'am, for the wonderful talk. It was indeed very nicely discussed about the various components of fluid therapy and obstetric management. So thank you, ma'am, for that. I will now request Dr. Mahendra Soni sir to kindly introduce our next speaker, Dr. Preeti Kumar, and she's going to talk to us about management of severe preeclampsia.
Dr.
Meenakshi ma'am, I would request you to
Meenakshi,
kindly
stop sharing.
Yeah.
So, Priyanshu, is there a CV of Dr.
So I have sent it to you on your personal WhatsApp, sir.
Should I start my presentation, Soni
Yes,
sir?
I welcome Dr. P.T. Kumar and to civil just is the chairman of Safe Motherhood Committee, Fogsi, very well-known gynecologist of our country, and I request her to speak about preeclampsia.
Thank you so much, Dr. Mahin sir. I bring greetings from the Safe Motherhood Committee in, of course, Lucknow, where I belong to. And I'm really thankful to Dr. Naren Gajjar sir and Vipul Kapadia and the team of West Zone Yuva Foxy for inviting me to deliver the talk on the management of severe preeclampsia. So with due permission of the chairperson, Dr. Soni and Dr. Millie, I would like to start my presentation.
Please.
Hypertension is in pregnancy is on the rise and contributes significantly to perinatal mortality and morbidity, and it leads to lifetime cardiovascular abnormality in mother and also in the fetus, and there are long-term complications of non-communicable disease both in mother as well as fetus. It is also very important to understand that when we talk about the preeclampsia, we talk about the gestosis. Gestosis is the spectrum of disorders which affects the pregnant women suffering from hypertension, because hypertension is just the tip of the iceberg, and there is much more brewing under surface which needs a prudent approach. So first and foremost, I would like to point the attention on what are the diagnostic criteria of severe preeclampsia. The severe preeclampsia is defined as a systolic blood pressure of more than 160 or 110, and it should be taken at a short interval of time, and a timely intervention should be done along with the proteinuria, that is 300 milligram in 24 hours, and you need to do a quantification with protein creatinine ratio. The normal, what we do is we do a simple dipstick of more than 2 plus that gives a significant proteinuria. But if there is an absence of proteinuria, a new onset hypertension with new onset of any of the following should be considered as a severe feature in preeclampsia. So a thrombocytopenia, which is less than 1 lakh, renal insufficiency, impaired renal function, pulmonary edema, and new onset headache, which is unresponsive to the medication and not accounted for any other differential diagnosis. Now, coming a word about the proteinuria, it has been mentioned in the practice bulletins of ACOG that following the initial documentation of proteinuria, proteinuria may or may not be present. It is not a diagnostic criteria. It may be present with hypertension, and if proteinuria is absent, then we have to consider the features that I have just now elaborated. So following the initial documentation of proteinuria and the establishment of the diagnosis of preeclampsia, additional quantification of proteinuria are no longer necessary. So these are the recent recommendation of ACOG, but I must tell you that RCOG has amended that you need to do a quantification in these patients. So once you detect proteinuria, you should also do quantification. And quantification can be done by protein creatinine ratio, or in other words, we can say we can be more specific, albumin creatinine ratio. Although the amount of proteinuria is expected to increase over time with expected management, this change is not predictive of the perinatal outcome and should not influence the management of preeclampsia. So complications of preeclampsia with severe features. Again, I would like to emphasize here that now the preeclampsia is classified as preeclampsia with severe features or without severe features. And there can be maternal complications we all aware of, right from the stroke to pulmonary edema to acute respiratory distress, coagulopathies, renal failure, or retinal injuries. And these complications are more likely to occur in presence of pre-existing medical disorders. Now, these are the specific warning signs and symptoms we quite often explain to the patient, pregnant women, when they have preeclampsia. And we also teach our healthcare workers regarding these signs and symptoms, because these are very critical of developing severe features. So any visual disturbance or persistent headaches or epigastric or right upper abdominal pain, or increasing edema or feeling of unwell or swelling over hands and feet or reduced fetal movements, these are warning signs, and these pregnant patients should immediately report to the consultant. Now, this is a very basic chart which I have made, a very simple one, that if a preeclampsia has severe feature, a pregnant woman with preeclampsia have a severe feature, if she's beyond 34 weeks, stabilize and deliver. If she is below 34 weeks, the period of gestation is less than 34 weeks, stabilize, monitor, and try to extend the period of gestation depending on the fetal and the maternal complications. Now, what should be the further line of action in these patients? You have to admit every pregnant woman with preeclampsia with severe features have to be admitted. The consent needs to be taken, investigations to be done, management of hypertension should be done, magnesium sulfate for seizure prophylaxis, and this also gives a neuroprotection, maternal and fetal monitoring and delivery if period of gestation is more than 34 weeks. Now, there are certain conditions which preclude expectant management. That means these are the conditions where you should not do expectant management. Here are the maternal complications like uncontrolled severe range of blood pressure existing between 160 to 110, persistent headaches which are refractory to the treatment, epigastric pain or visual disturbances, any of the maternal complications where the target organs are involved like stroke or myocardial infarction or acute respiratory distress. So oxygen saturation is again very important. If it is falling, again, it is a critical sign. Pulmonary edema, of course, development of eclampsia. These are all the indications where you should not do expectant management. Now, in the fetal conditions, if you see there is any fetal distress, like in the form of abnormal fetal testing or fetal death, when you expect that the fetus is not going to survive, persistent reverse and diastolic flow in the umbilical arteries, again, these are the indications for termination of the pregnancy. You should not continue with the expectant management. Now, coming to the lab investigations, I have already told urine albumin is again very important for the diagnosis. You can do quantification, you may not do. Further continuation of urine albumin every time is not mandated. Complete blood count is important, platelet count is important. Coming to anemia assessment, it is very important to understand that these patients may have hemolysis. So once they have hemolysis, the hemoglobin should drop. But many of the times that is not depicted in the hemoglobin because of the hemo concentration. So the hemolysis should be judged by LDH, not by the hemoglobin level. Then liver enzymes are again important. You have to do liver enzymes, serum creatinine, uric acid, and coagulation profile is recommended only when the platelet count is less than 1 lakh. But as a routine package, we all send the coagulation profile when we have a patient of preeclampsia. Serum electrolytes ideally should be done in all the severe cases. Now, whenever you have to decide about the delivery of the mother, you have to take the maternal and the fetal components together. Whenever there is uncontrolled hypertension or the pregnant mother develops eclampsia, or there is a labor or premature rupture of membrane, or oliguria, or they are deteriorating liver functions, the low falling platelet, just one value of platelet is not sufficient to have an indication for termination. If the platelet levels are gradually falling, neurological complications are occurring, or the mother is landing up in HELLP syndrome. These are all indications for termination of pregnancy. And in the fetal, if there is any fetal jeopardy like absent end diastolic flow or reverse end diastolic flow, loss of fetal movements, biophysical score less than 4, or there's a severe IUGR or severe oligohydramnios, or she has already crossed 34 weeks in severe preeclampsia, you need to terminate all these pregnancies. Now, coming to the emergency part, hypertensive emergency, this we quite commonly face in our clinical practice. It is very important that when we diagnose a blood pressure of more than 160, 110, it should be repeated within 15 minutes and the management should be started as early as possible. So there are a number of antihypertensives that we use in our practice. The best line of management is with labetalol, or the most commonly used is nifedipine. But whenever we do some kinds of eclampsia drill, we quite often find that in many of the government sectors, hydralazine is also a drug of choice. So these are the chart which shows what is the mode of action and what is the peak. and labetalol is the best drug that we should use. So this is a beautiful algorithm which has been put in by ACOG, that whenever you have a patient, pregnant woman with a hypertension of more than 160, 110, it's a severe hypertension, you should give 20 milligram of IV labetalol, repeat a blood pressure after 10 minutes. If it is not falling, double the dose. That is, if you're given 20, make it 40, repeat after 10 minutes, and again check for the blood pressure. If it is not falling, then double the dose, make it 80. Now, beyond 80 milligram of labetalol, if again the blood pressure is not falling, it is advisable to add another second antihypertensive. Though the maximum dose of labetalol is 220 milligram, but these are the recommendations by ACOG that you should know how to titrate the antihypertensives. So after 80 milligram, it is always advisable to add the second antihypertensive, that is hydralazine, and then check the blood pressure. And once the threshold is maintained, check every 10 minutes for 1 hour, then every 15 minutes for 1 hour, then every 30 minutes for 1 hour. And once the blood pressure is controlled, then 4-hourly monitoring should be done. Labetalol should not be given if the pulse is less than 60, and I've already told the maximum dose is 220, but beyond 80, the second dose should be added. And avoid labetalol because it is alpha beta blocker in any of the asthma, congestive heart failure, or heart disease. Now, coming to the hydralazine, some of the centers, the public sectors are using hydralazine. I have yet to see any private sector which is using hydralazine. Most commonly drug used is labetalol and nifedipine in our practice. Hydralazine, the maximum dose is again 25 milligram. It should be given 5 to 10 milligram. Again, repeat after 10 to 20 minutes. If the blood pressure is not dropping, then you can just double the dose, make it 20 milligram of hydralazine. Again, if the blood pressure is not controlled, the second drug of choice is labetalol. You should add labetalol after the 2 doses of hydralazine. And again, the monitoring remains the same. Hydralazine, the maximum dose is 25. The only concern is the maternal hypertension that we quite often see. And this is the commonest, I think, drug which is used in a day-to-day practice. The only thing is sublingual should not be given. The only caution that we need to take is whenever you give a oral nifedipine, it should be given to the conscious patient, not to unconscious patient. And then the blood pressure should be repeated after 30 minutes, not as early as 15 minutes, what we do in labetalol after giving IV labetalol. After giving nifedipine, it should be checked only after 30 minutes because only then the effect will come. The maximum dose of nifedipine that can be repeated is 80 milligram. And once the blood pressure is not controlled, then you have to add labetalol. So the point here is the oral nifedipine has been associated with increased risk of maternal heart rate and may overshoot hypotension. So what I want to emphasize here is that the titration of antihypertensives is very, very important. You start with low dose. Even if you are managing a case of preeclampsia, even if you are giving an oral medication, start with low dose, make it medium dose. And if the blood pressure is not controlled, it is always advisable to add the second dose. These are ACOG recommendation. Add the second dose after medium dose. So once the labetalol has crossed 200 milligram TID or QID, then it is always better to add the second dose. Then comes the role of magnesium sulfate. All severe preeclampsia should be given magnesium sulfate. Not going into much of the detail, we all know Pritchard regime, 4 gram IV stat, and then followed 5 gram in each buttocks, followed by every 4 hourly 5 gram. And you have to be cautious about the side effects of magnesium sulfate. Again, want to emphasize magnesium levels are not indicated because hardly patients get magnesium toxicity except for those patients who have renal impairment or renal dysfunction. So patellar reflex, urinary output, respiratory rate, these are things to be monitored. We are all aware of. And if there is any of these, if the respiratory rate is falling or urine output is less, again, many of the times we run these patients dry, the fluids are restricted. So many of the times, since the input is not good, the output is not good. So it is very important in these patients to check the input also before stopping magnesium sulfate. Calcium gluconate is a drug of choice. How we give it, it has to be given in diluted dose. Never give calcium gluconate in a bolus form. And whenever there is any problem, it is always advisable to do ECG. Now, role of steroid comes when any pregnant woman develops preeclampsia less than 34 weeks of gestation, because after 34 weeks, we should not wait for steroid completion. We should deliver those patients. And if a pregnant woman is less than 34 weeks of gestation, definitely dexamethasone or beta-methasone, whatever you are feasible or comfortable with, but dexamethasone is a drug of choice. Now, this is a chart, last 2-3 slides. If the period of gestation more than 34 weeks, deliver, stabilize and deliver. That is a rule. If the period of gestation is less than 34 weeks with severe preeclampsia, observe for 24 to 48 hours, give her steroids, give her magnesium sulfate prophylaxis, antihypertensives as I told, monitor for the symptoms and fetal conditions. It is very important to do cardiotocography or NST at the first visit. You should do ultrasonography and all the lab tests should be should be sent, what I have mentioned. The contraindications to continued expectant management, I've already told. If there is eclampsia or pulmonary edema or DIC or uncontrolled hypertension, even if you are controlling on 3 drugs, those are the conditions you should not continue with the expectant hypertension. So if they are managed on the high doses of antihypertensive, they should be terminated, delivery should be conducted. So the second one is, if there are any additional expectant complications like health syndrome or severe IUGR or oligohydramnios and any of the fetal complications, then again steroids and deliver after 48 hours. Now, this is again the expectant management if the fetal and the maternal conditions are okay. Suppose if the patient presents with severe hypertension only and the proteinuria and the blood pressure is controlled, this pregnancy can be continued up to 34 weeks with vigilant monitoring of the mother and the fetus. So you have to admit these patients, do a constant monitoring of maternal assessment of vital signs, fluid intake, symptoms for severe preeclampsia, again if they are occurring, rupture of membranes or pain or abruption, that is very, very important because abruption happens quite often. Then you have to test CBC, LFT, KFT, if not daily, at least alternate days. Fetal assessment, again, kick count is important. NST has to be done daily. And if you are prolonging the pregnancy, depending on the growth profile, you have to repeat the Doppler parameters and then deliver at 34 weeks of gestation. So mode of delivery, again, vaginal versus cesarean, that all has to be individualized. If the pregnant woman the baby is premature, definitely induction is a problem. Then go ahead with the vaginal, the cesarean section. Again, many factors are to be looked in. It is very important again to check the fluid because we should not overload with fluid, and the monitoring of the blood pressure is again very, very critical in these patients because they can throw fit anytime. Post-delivery care is again very important. You have to closely observe the blood pressure for 48 hours because postpartum eclampsia is very, very common. Initially, it was said that NaCID should not be used in these patients, but ACOG has given a recommendation in 2020 that they can be safely used. Antihypertensive therapy should be recommended if the blood pressure is beyond 150, 100. Blood pressure should be measured at least 4 times, and if it is stable, then you can gradually taper down the monitoring and consider reducing antihypertensive therapy if the blood pressure falls below 140/90. Again, a point of caution here, these are the recommendations by ACOG that reduce antihypertensive if the blood pressure falls below 140/90, but RCOG has recently given a recommendation that if the blood pressure is below 130/80, then only you stop tapering down the antihypertensives. So again, very important thing is you have to repeat the biochemical markers after 48 to 72 hours. If they become normal, need not to repeat it. But again, if they persist for more than 4 days after delivery, then you need to have a special opinion from the physician. Then postpartum care is again very important. You need to follow these patients. They are not only prone for hypertension, they are prone for lot many non-communicable diseases. It's same like gestational diabetes. So these patients should be kept on monitoring for hypertension and non-communicable diseases. Contraception should be advocated, and preferred contraception is IUCD. Again, preconception counseling is again important in the subsequent pregnancy. So just 3 take-home or quality messages from this presentation is 160, 110 is alarming. Quickly diagnose, repeat within 15 minutes, establish the diagnosis of severe hypertension, and start antihypertensive. Delivery is recommended when gestational age is more than 34 weeks. Stabilize the mother and deliver. Do not wait. Delivery should not be delayed for the administration of steroids in the late preterm period. But if you want to plan expectant management, then strict and critical monitoring of mother and fetus is very, very essential. And you can extend the period of gestation up to 34 weeks. And expectant management is not advised when neonatal survival is not anticipated. During expectant management, delivery is recommended at any time in case of deterioration of maternal or fetal conditions. So thank you so much for patient hearing, and it was a pleasure being here. And I would like to have, if there are any questions, I would be happy to answer those. So thank you so much, Naren sir and Vipul sir, for inviting me for this platform.
Thank you so very much, ma'am. Yeah. Yes, sir. Please go on, sir.
Yeah, thank you, Dr. Pradeep Kumar. And a very important message that expectant management, yes, but you should be very careful. And even you should go for cesarean section, I will say from my side of experience, that the results are always better, because if you go late, then you may lose the child also. Thank you very much.
Thank you so much, sir.
Thank you so very much, sir, for chairing the session, and Preeti ma'am for the wonderful talk as usual. So beautifully explained the various management options of severe preeclampsia. Thank you, ma'am, for that. So now I would invite Dr. Mili Dodia ma'am to kindly introduce our next speaker, Dr. Prakash Bhatt sir. And sir is going to talk to us about sudden obstetric collapse. Mili ma'am, kindly unmute yourself.
Yes, well, now I invite the last speaker of this session, Dr. Prakash Bhatt, known and loved by all, one of the senior most faculty from Surat, having obstetrics very close to his heart. Welcome, sir. Yes, Dr. Prakash Bhai, welcome.
Thank you very much. I'm trying to share my screen. Unfortunately, I'm not able to.
Your screen is visible, sir. Kindly just open the presentation. Your screen is visible to us, sir.
Okay. So that is the presentation.
Yeah, perfect, sir.
The patient has delivered, the newborn is crying lustily, and the cakes are cut, and there is joy and delight everywhere. And then suddenly something goes wrong. And Dr. Narendra Bhai and Dr. Vipul Bhai asked me whether this sudden was really sudden or we have missed something. Whether this sudden is really sudden or something could have been done. Let us see. Otherwise, we define it as a pathology which leads to hemodynamic instabilities, resulting into dysfunction of heart, brain, or lungs. But just I said, perhaps we have missed something. And therefore, let us prepare and prevent rather than repent and repair later on. People have recognized several scoring systems to warn the obstetrician. There are acute physiological and chronic health evaluation scoring, sequential organ function assessments. Somebody talked about shock index. Then there were disease-specific risk predictions in preeclampsia, in sepsis, and in obstetric hemorrhages. And now, last but not the least, is obstetrically modified quick SOFA score, or what we call as OMQ SOFA. This is all made to just warn us beforehand that nothing goes wrong, or we are able to find out that something is going wrong. But unfortunately, something goes wrong if it has to go wrong, and that is the Murphy's Law. And therefore, let us have some final decision about what can go wrong. There may be few pre-existing diseases. And remember, we are going to now get patients who might have corrected Fallot's tetralogy, who might have got corrected systemic right ventricle, even post-heart transplant. And then we might have, following COVID, post-lung transplant patients delivering under us. And several such diseases can deteriorate during pregnancy. And there may be some diseases which can deteriorate de novo because of pregnancy. There may be acute kidney injury, and of course, infections. We all are passing through the phase of incidental infections. Whether pregnancy makes any difference to it or not, we don't know. There may be hematological diseases like DIC, hemolytic uremic syndrome, thrombocytopenic purpurias. There may be endocrinal disorders, and so on and so forth. We have understood already what goes wrong during COVID. And such multi-organ defects are available. 89% of our patients can have lung diseases, not simply during corona epidemic, but even otherwise. There may be cardiovascular system disorders, renal disorders, DICs.
I think we have lost sir's connectivity.
Yes, Dr. Bhatt, I think lost connectivity.
Yeah, so will you just give him a call, Dr. Ms. Alak? I mean, just ask him if he's free joining us.
Okay.
Yeah.
Sir has joined, but he needs to unmute.
Dr. Bhatt, you are muted.
Okay, can you hear me now? Hello?
Yes, sir. Yes, sir. We can hear you, sir. So, but we can't see your screen yet, sir. So, if you can just share the screen, please.
I don't know what has happened.
Yes, Prakash bhai, we can hear you.
Yes, yes. Did you hear it up till now? Am I audible now?
Yes,
sir. Yes, sir. You're audible, sir. Please go on, sir.
Last 2 minutes we could not listen you.
Should I go back or will do?
No. For fetal monitoring.
Okay, I move with fetal monitoring. Okay. So the fetal monitoring has got one or two important components. One need not wait for a classical academic detailed fetal monitoring. What we accept as good as anything is biophysical profile. Just remember that if the delivery is imminent, give a loading dose of magnesium sulfate. It is supposed to protect the fetal brain. Whether you have to deliver abdominally or vaginally has to be decided how quick or how fast you want the delivery to take place. If you are dealing with an obstetric cause, of course, you would like to deliver as early as possible. If the cause is some different, we might take the delivery at a little leisurely pace. I am going to talk about some unusual presentations of cases which we usually find in our consulting rooms and labor rooms. Remember late postpartum eclampsia. Dr. Preeti Kumar was talking about 48 hours postpartum, but there have been at least 17% of eclampsia which were found after 48 hours postpartum. And out of that, only 12 had got antecedent history of preeclampsia. Rest were absolutely de novo, and that puts us into real perplexing situation whether this is eclampsia or this is something else. And of course, sepsis. Don't think that sepsis was a thing of past. Sepsis is still with us, probably going to remain with us for a long time. Here is one patient. He was a primate after non-eventful pregnancy and a spontaneous onset of labor. She delivered and then went home. After 2 weeks, she came back. She had diarrhea and vomiting. When she came, she was absolutely shocked and she had huge amount of fluid in her peritoneal cavity. So it was suspected that she has an abdominal viscous perforation. She was operated upon, 2 liters of peritoneal fluid was found and a completely gangrenous uterus. A subtotal hysterectomy was carried out, but we were too late. Before we can resuscitate her any further, she lost her life. Similarly, there can be an antepartum sepsis, which we so many times overlook. There is an entity known as antepartum chorioamnionitis, which can take place after even our own favorite and so often done without any indication osteitinings. We have introduced the infection and now we have to pay for it somewhere. This is a patient who came early morning at 6 o'clock. She had an irritable uterus, history of fever for 2-3 days. She had undergone osteitis about at 22 weeks, that is about a month back. And when we examined her, WBC count was nearly 40,000 and SGPT 230, platelets going down 96,000 and LDH was raised. She was having a sepsis-induced HELP syndrome. And this we all know. We have been talking about the systemic inflammatory response and using varieties of drug with reason, without reason for last 1.5 years in our corona pandemic. But let me remind you again, puerperal sepsis is not a disease of past, and we need to exercise proper infection control practices and indicated prophylactic antibiotics. Here is another case patient. She was moderately hypertensive, received amlodipine 10 milligram twice daily, admitted with history of bleeding. PV was found to have abruptio placentae. She delivered vaginally fresh stillbirth, never crossed 140/90 limits, but after 15 minutes, she had a vomiting and gradually she stepped down the ladder of her consciousness and became comatose. Nobody knew what happened. We got an MRI done. There was a huge cerebral hematoma in her brain. And in those days, I'm talking about some 20 years back, the neurosurgeons never drained those hematomas. Nowadays, the neurosurgeons have taken to the practice of draining some hematomas, and it has been found that these things give us better results. And this is a patient who had a thromboembolism, absolutely unusual. She was admitted 48 hours of uneventful delivery. She had a painful leg and a little pyrexia. She stayed in the hospital for 3 days, went home. And on 19th day, the relative came running saying that she had gone into the bathroom for a shower and fell dead. She was brought there and she was dead on arrival. Did we miss out the deep vein thrombosis at the first time? Did we took it as a thrombophlebitis? Should we have taken more care and put her on anticoagulants? These are the problems. Here is a cardiac problem, which came to us in an absolutely unusual situation. Early morning. Why the emergencies come always in the early morning, I have still failed to understand. Her pulse rate was 184, blood pressure was 60/40. She was in severe respiratory distress. And when the physicians saw her, it was found that she had extremely tight mitral stenosis. She was immediately shifted to the cardiac cath lab, and our cardiologist carried out a rescue balloon mitral valvotomy. And the fun was, or the tragedy was, that the cardiac hospital refused to keep her in their ICU, saying that if she delivers, we don't have anything available for delivering her. So she was moved to a simple ICU, and believe me, she delivered there vaginally within next 6 hours, an absolutely normal 10/10 Apgar score child. And of course, the situation with which we all are worried and literally scared of are amniotic fluid embolisms. But they do not present as the textbooks write to us, present to us usually. There can be varieties of different presentations. And here is one of them, which is unusual. A patient underwent cesarean section in the morning at 6:30. And at 10 o'clock, I got the call that patient is having dyspnea and her blood pressure has fallen. When I went there and saw there was something wrong in her abdomen, the bedside USG revealed 1.5 liters around of fluid, mostly blood, in the peritoneal cavity. My natural response was to go ahead, open the abdomen and find out the bleeding point and close it because she was dying. I opened the wound. There was oozing from all sides in the parietes. Fortunately, the uterine incision was absolutely well stitched. There was no spurter and no bleeding from one side. There was only generalized oozing. And believe me, there was no intrauterine hemorrhage, no bleeding per vagina. And then the investigation revealed that she had DIC. This is what we call as anaphylactic syndrome of pregnancy. It is never ever a mechanical obstruction. It is an anaphylactic response to the presence of something in the amniotic fluid or its content. And this is the sentence which I want to re-emphasize, that amniotomy and oxytocin administration do not influence the risk of developing amniotic fluid embolism, as believed up till now. The clinical presentations may be anything: shock, ARDS, coagulopathy, left ventricular failure, or sudden death on labor table. So even if you have only coagulopathy, it can be because of a amniotic fluid embolism. So in this situation, how do you manage? People have talked
1
about
minute left.
Yes, rapid evaluation and resuscitation. Monitor now CBA, circulation, breathing, and airway. So monitor the oxygen saturation, cardiac output, intra-arterial pressure, CVP. These are the things which have to be done in an intensive care unit. And don't forget to resuscitate her hematologically, because the situation of shock and the pathology itself can produce a lot of hematological changes and lead to some form of coagulation disorder. And then what is left is hemorrhage and sequential system organ dysfunctions, eclampsia, preeclampsia and related syndromes, and thromboembolism and corresponding organ dysfunction. They have to be specifically treated. But the first management is always get help first and never last. I wish all a very collapse-free time. Thank you.
Thank you, sir. Wonderful talk. I would request Millie ma'am to kindly conclude. Millie ma'am, requesting you to unmute yourself, please. We
Yes.
can't hear you.
Thank you, sir. Thank you, sir. It was very elaborate and we enjoyed. Right, sir. Any questions?
I don't see any questions in
Any
the Q&A
questions
box,
to Dr.
ma'am.
Prakash Bhai?
I don't see any questions in the Q&A
Okay.
box.
I
Then
would
we
just
conclude
like
this
to say that the starting was so good in this
Okay.
COVID-19 period. Dr. Prakash starting with "Ye hasta hua karava na jane." Chala
That is the Nightingale speaking.
I was not able
Absolutely.
to recognize you for some time, you know, looking so different.
Thank you. That's the story everywhere.
So thank you so very much. I would like to, we come to the end of the first session of today's morning. I'd like to thank the chairperson, Dr. Mahendra Soni sir and Dr. Mili Dodia ma'am for sharing it so wonderfully, and for the wonderful talks of Dr. Sneha Bhuyar ma'am, Meenakshi Patel ma'am, Preeti Kumar ma'am, and Dr. Prakash Bhatt sir. So wonderful session. Thank you so much for all the information that you have given us. Thank you so much for that. So next we move on to the second session of today's morning. I would like to invite the chairpersons for this session, Dr. Mahesh Gupta sir and Dr. Sheila Mane ma'am. So Dr. Mahesh Gupta sir, he has worked a lot in the field of PPH and high-risk obstetrics. He has even patented a suture material for PPH surgery. He runs a 50-bedded multi-specialty hospital in Ahmedabad. He was the president of the Ahmedabad OBGYN Society and was a recipient of the Times of India Health Icon Award. So welcome, sir, to this platform. I would request Dr. Jitendra sir to mute himself. Yeah, please. Thank you. So next, I would like to invite our next chairperson, Dr. Sheila Mane ma'am. So again, ma'am is a senior consultant OBGYN at the Anugrah Nursing Home, Bangalore. She was the organizing secretary of the wonderfully conducted AICOG, which we thoroughly enjoyed in 2019. She was the vice president of Fogsi in 2014 and was the chairperson of the Safe Motherhood Committee, Fogsi. So welcome, ma'am, to this platform, and she's also to mention the ICOG Governing Council member. So welcome, ma'am, to this platform. So I would first of all like to invite Dr. Mahesh Gupta sir to kindly invite our first speaker, Dr. Nalini Anand ma'am, and ma'am is going to talk to us about lower genital tract trauma in obstetrics.
Thank you, Priyankur, for kind words. Now let me invite Dr. Nalini Anand. She is a good friend, professor and HOD of obstetrics and gynecology at Anpisha Medical College, Jamnagar, and faculty at AICOG from 2013 to 2019. And being a HOD, she has a vast experience of tackling all obstetric emergencies because I know that at Jamnagar Medical College, the obstetric work is too huge. So nothing to more say about Dr. Nalini Anand, that we straight away go to the topic, that is a lower genital tract trauma, which is very interesting to hear from Dr. Nalini Anand. So over to you, Dr. Nalini, please.
Thank you, sir, for your kind words. Without wasting any time, I think we shall start this Sunday morning. I'm starting with the obstetrician's nightmare. Yes, lower genital tract trauma in obstetrics. Uh, as we all know, as we all know that As we all know that maternal injuries following childbirth are quite common and contribute significantly to maternal morbidity and even to morbidity, mortality, both. Prevention, early detection, and effective management not only minimizes the morbidity but prevents many gynecological problems from developing later in the life. These issues, these lower genital tract injuries, could be cervical and vaginal lacerations, perineal tears. Cervical and vaginal lacerations, we all know, we have encountered day in and day out. Vaginal lacerations, most of the times, do not require much issues. We can suture them. Sometimes when they are edematous, definitely we need to require pressure application as well. Except when there is colporesis, when the vault is also involved. In those cases, and when the uterine vessels are torn, we may require a laparotomy to tackle these lacerations. And in laparotomy, if the vessels are already retracted, we may require to go bilateral or unilateral internal iliac ligation as well. Cervical lacerations, we all know, and cervical tears, we all know how to suture them with the help of ring forceps. We suture them. The smaller tears can be taken care of. And sometimes we really astonished that the tears which actually look really nasty after 4 to 6 weeks postpartum, when we see them, they do not, as if they never existed there. Sometimes the cervix is so thinned out that it is really difficult to suture it effectively. In those cases, if the patient is not bleeding profusely, we can even wait for 12 to 24 hours, and later on when the cervix is retracted, we can take the sutures from there to prevent from the delayed complications to occur. Then perineal tears, first degree, second degree, and third degree. Thankfully, first and second degree tears are the commonest ones, in which along with the skin, the superficial muscles, all the whole of the perineal muscles are torn, which we suture similarly as episiotomy. The third degree perineal tears, definitely they require some attention, and here we need to be very careful in the primary suturing. If we are in a PHC setting or the birth is being attended by a trained birth attendant, then it is highly suggested that these patients be referred to a higher center, because the primary closure is very important. The postpartum period after the tear repair is also to be taken care of, that the constipation should not occur, proper antibiotics must be given, and if we take care of these things, we can prevent the dreaded complication of psychovaginal fistulas. The episiotomy is the commonest type of injury which we all encounter. In fact, we all give. But yes, sometimes the episiotomies, they get extended. And these are the cases which we need to carefully suture and take care of. In the further slides, we shall discuss episiotomy in a little detail. The periurethral tears can bleed profusely, and we all know how to suture them. And most of the times, they are not a big issue to tackle. Vulval hematomas, yes, we deliver the patient is shifted to the ward, and at times it happens that when we go to the ward for the rounds, the patients complain to us about pain in the perineum, or we find hypotension in the patient, or there is tachycardia, and when we take the patient inside, we examine, there is bluish discoloration. Yes, we are dealing with vulval hematomas. We need to drain them. Most of the times they can be taken care of vaginally, but sometimes again, if we are patient is very low hemodynamically and it is difficult to suture them, we need a laparotomy to take care of vulval hematomas. Vesicovaginal fistulas and rectovaginal fistulas are serious morbidities and consequence of lower genital tract injuries. The causes of injury. Yes, the anticipation is the key to the success, key to the prevention. So macrosomia, whenever we encounter, we are delivering a patient vaginally and the birth weight of the baby, expected weight is more than 3.5 or 4 kgs. We need to be very careful, especially in providing the pressure, in providing the support and maintaining the flexion attitude of the baby. Instrumental delivery, we need to be careful so that we do not apply instruments clumsily and do not end up with some injuries, especially while application of ventures on an undilated cervix. We need to be very, very careful because these are the conditions where most of the times this type of traumas are encountered. Then first vaginal births are very important to take care due to the rigid perineum, and especially if the cervix is little undilated or something, we need to be careful. The deliveries should not be unattended because unattended deliveries, again, lower genital tract injuries are most common. Shoulder dystocia predisposes to lower genital tract injuries. The deliveries done by trained personnel are improper technique, and instrumental deliveries. I would like to mention here that there are two types of tears in perineal tear, that is central tear or complete posterior vaginal tear, which are rarely encountered in modern day obstetrics, thankfully. But if we need to anticipate, if we anticipate them, we will definitely not cause them. The points which we should not miss is that institutional place of delivery is very important, and there have been lots of studies about institutional place of delivery versus the delivery outside the hospital or by untrained, inexperienced person, where the genital tract injuries are more. The primiparity versus multiparity has been widely studied, and it is found that in primipara, the incidence of vaginal lacerations is more. In multipara, I'll have a study later on. Then those delivered spontaneously versus assisted delivery. Assisted deliveries, especially if we are extracting the fetus by instrumental or breech extraction, and it is cervix is not properly dilated, the pressure needs to be carefully applied. And we have to definitely not forget to maintain the attitude of flexion. If the birth weight is more than 4 kg, definitely it is again a difficult situation. So from the multiple studies, we have concluded that historically it was believed that episiotomy reduces spontaneous perineal injuries or anal sphincter tears by controlling the direction and the extent of the tissue damage. Currently, there has been a trend of restricted use of episiotomy, which has led to increase in the incidence of the genital tract trauma, especially first and second degree perineal tears. Most of the studies which were conducted in India show that majority of the patients belong to the age group of 20 to 30 years, which definitely corresponds to the peak of obstetric career, especially in the nulliparous and the birth weight of more than 4 kgs. Among the lower genital tract injuries in the nulliparous females, periurethral tears, cervical lacerations, and second degree perineal tears accounted for the majority of the injuries, as much as 48%, followed by vaginal lacerations and fourth degree perineal tears, accounting for 11%. Complications of the lower genital tract injuries were higher among the women who delivered outside the hospital. These women sustained serious lower genital tract injuries due to delayed presentation at the hospital, delivery by unskilled person in unhygienic conditions, inability to procure the antibiotics, or the failure on the part of the patient to take because of any reasons, again account for these complications later on. Complications post genital tract trauma, the commonest one is the anemia. Many times we all know that even vaginal and cervical laceration have happened. Still, the patient needs blood transfusion to be given. And traumatic PPH, we all know, accounts for 40% of total postpartum hemorrhage, and hence it needs to be taken care of very properly. Long-term treatment of chronic anemia, again in these type of patients, is also required. Genital tract infections, especially deep vein thrombosis, sometimes cellulitis, also can be an issue if antibiotic either they do not act, or there is a failure on the part of the patient or to give. Less common complications are retention of urine or incontinence, which may lead to disruption of social life, especially marital disharmony, etc. is also encountered in these type of cases. Second trimester recurrent pregnancy loss, especially when the patient has had cervical lacerations. dyspareunia and discomfort due to chronic pain. Here I would, in recurrent pregnancy loss, I would like to add that annular tears generally do not cause, but the bucket handle tears definitely many times, if left unattended or they have gone unrepaired, may cause these type of complications. And they also encounter and account for 2% of cervicovaginal fistulas. Here, there is a study in which the pattern and maternal outcome of lower genital tract injuries among the women with vaginal deliveries in Calabar, state of Nigeria, was studied. The conclusion was the associated morbidity and mortality following lower genital tract injuries in this study were high, mostly among the unbooked women who delivered outside the hospital, which can definitely be reduced, as I am being telling right from the beginning, by health education, uptake of antenatal care, and presence of skilled birth attendant in the labor. Then there is this study in which the timing of cesarean section and its impact on labor duration and genital tract trauma at a subsequent vaginal birth was studied, and it was found that compared to primiparous women having the vaginal birth, women having their first vaginal birth after a cesarean section have a shorter first stage of labor, especially when the cesarean section was performed in advanced first stage of labor, a higher risk of sustaining cervical lacerations and perineal trauma. However, there was no difference in the risk of sustaining obstetric anal sphincter injuries between the two study groups. Then there is one study about broad ligament hematoma, and it's a case report, spontaneous broad ligament hematoma following a normal vaginal delivery, and was concluded that it's a serious maternal morbidity and can even lead to maternal death if timely diagnosis is not made. Its non-specific clinical signs and symptom ranges from mild pain to severe hemodynamic instability. It can be silent and not cause any obvious vaginal bleeding. A high degree of clinical suspicion is must for this. Selective episiotomy versus implementation of a non-episiotomy protocol, a randomized clinical trial. The selective episiotomy, yes or no? In women where no instrumental deliveries is intended, selective episiotomy policies result in fewer women with severe perineal oblique vaginal trauma. Other findings, both in short or long term, provide no clear evidence that selective episiotomy policies result in any harm to the mother or to the baby. The ACOG practice bulletin advised that data shows no immediate or long-term maternal benefit of routine episiotomy in perineal laceration severity, pelvic floor dysfunction, or pelvic organ prolapse, compared with restrictive use of episiotomy. ACOG also notes that episiotomy is associated with increased risk of postpartum anal continence. The NICE and RCOG, they have published similar guidelines against the routine use and advocate the mediolateral episiotomy to be used whenever clinically indicated. In 2015, RCOG recommended that data supports protective effect of episiotomy is conflicting, and mediolateral episiotomy should be the one considered in instrumental deliveries. That is whenever we need to consider. So I would like to summarize that prevention of lower genital tract trauma, it is required a multifactorial approach. There are randomized trials which have documented that prenatal pelvic floor relaxation exercises also help a lot. Antenatal perineal massage during the last trimester of pregnancy may reduce likelihood of perineal trauma and postpartum pain. Then warm compression has also been studied with good promising results. Alternate birthing positions has also been tried, and it is seen that lateral position with delayed pushing is most likely to end up in delivery with intact perineum. Strong opinions but sparse data exist regarding the role of hand maneuvering by the birth attendant and the perineal management and the birth of the baby. The delivery of infant's head in between the contractions definitely affects a lot. So the good pelvic support at the time of by the doctor or the trained birth attendant, whosoever is attending the delivery, and maintaining the flexion attitude will go a long way. So genital tract trauma, we all have seen, is a common complication of vaginal birth, but improvement in the quality of obstetric care combined with heightened level of utilization along with the education and economic empowerment of the women will help us in preventing this type of trauma and making this experience of motherhood a joyful experience for mother. Thank you.
Thank you, Dr. Nalini, for covering this huge topic in 15 minutes only. And because I know that this is a very important aspect of the postpartum hemorrhage. And here the only problem when the hematoma is at the upper vaginal level or a supralevator kind of hematoma. And these cases that requires a laparotomy. Otherwise, most of the time, lower genital tract injury that can be taken from vagina only. But when the hematoma is enlarging in the vagina and particularly supralevator kind of hematoma, there we don't have any other option than ligating the internal trachea, and that gives a very good results. But anyway, thank you for covering this exhaustive topic in short time. Congratulations and thank you.
Yeah,
Thank you, sir.
Thank you, Dr. Nalini. Now I have the pleasure of inviting the second speaker, Dr. Neeta Sata. And Dr. Neeta Sata is going to deliver a conservative management of massive PPH. She is works at Sri Dwarkadish Hospital, which deals with infertility care, laparoscopic surgery, and sonography. She was organizing secretary of SOGOG in 2019, which was held in Jamnagar. President Jamnagar Obstetrics and Gynec Society, and she was she's ex-head of the unit and associate professor at Sri MP Shah Medical College, Jamnagar, and co-author of textbook of complications in gynecological surgery published by Fogsi. And she's also a recipient of Best Innovative Laparoscopic Surgery Technique Award from IIG in 2008. I welcome you, Dr. Neeta, to deliver your talk. I think both the speakers from Jamnagar and really feeling nostalgic and having so many nice memory of Jamnagar visit. Over to you, Dr. Neeta.
Thank you, Dr. Sheila.
Thank
I would like to start with this painting, which I have clicked while I'm myself visiting to London, which has been painted in 19th century, showing the death of Queen of England immediately after delivering the baby. And since more than a decade, I think we, the obstetricians, are behind giving safe motherhood to all women in the world.
Your screen is visible?
Are you?
You're good? Her screen is visible?
Not visible, Mahesh.
Yeah, screen is not visible.
Let me check. I think now I'm visible.
Yes.
Yeah.
Slideshow, you can make it a slideshow.
Since more than a decade, I think we all the obstetricians are trying hard day and night to safeguard the motherhood. And the result we know is there's still more than 50% of medical legal cases are for PPH and related morbidity and mortality. And 35 to 56% of maternal deaths within first 24 hours are due to PPH. So what to do? Knowledge and quick action saves lives here. So now let me come to what is massive PPH. By word massive, according to Oxford Dictionary, is gigantic or voluminous. So the loss of more than 1500 ml of blood loss, we should consider as massive PPH. The loss of more than 150 ml per minute or loss of more than 50% of blood volume in 3 hours is to be considered as massive PPH. And now what to do? I think let us revisit what we have done till date in presence of Master of Obstetric Surgery, Dr. Mahesh Gupta, and Chairperson, Dr. Sheila Mane. It is a beautiful mnemonics, hemostasis, by which we can manage this massive PPH. Now, what is this hemostasis? H is to get help. Whatever compatible, whatever smart you are, but you just remember you have 2 hands and 1 brain. So always get help of your partner, your senior staff, your senior obstetrician, anesthetist or a medical officer, and a record keeping person as well, which is very important. Mind well, seeing is not believing for blood loss. It is very, very important to assess blood loss to quantify blood loss rather than just estimating, because estimate is generally underestimated, especially in large volumes by 30 to 50%. There are very beautiful underwater drapes which are available, which are very reasonable by cost as well, which can quantify blood loss. You can assess the blood loss by clinical science as well. Observe multiple parameters serially. Not a single parameter is going to be helpful. Catheterize women immediately. Observe the rule of 30. More than 30% of loss in blood volume is showing a moderate shock. A systolic BP fall by 30, heart rate rise by 30, or respiratory rise by more than 30 breaths per minute, or urine output less than 30 ml is indicating a moderate shock. Very important is to observe shock index rather than only systolic BP or heart rate. If it is more than 1.2, you have to be very, very alert. Now, assessing the blood loss by blood parameters, hematocrit value of reduction of more than 30% is indicating a moderate shock. But mind well, only hematocrit is not going to be helpful whenever you haven't replaced the fluid, because in absence of fluid replacement, hematocrit is going to remain same, and whenever there occurs increase in blood volume, expansion of volume, this hemoglobin is going to fall down, so it will be giving you false result. Now, regarding the loss replacement statistic, follow the rule of 1 to 5. If the loss is 1 liter, replace fluid. If the loss is 2 liter, replace blood. If the loss is 5 liter, you have to replace component like FFP, cryon, platelets, which has already been discussed. Here, there is very important role of large ball needle. See, most of the time it happens that we are not keeping 14 or 16 gauge cannula at our hand, we prescribe. But it is very, very important you keep it handy, because the flow of the fluid through this large bore cannula is twice that or thrice than your routine cannula of 20 gauge. Prepare a PPH box so that you need not instruct your staff that bring this instrument, that instrument, bring this. A ready PPH box should contain different sizes of speculum, a speculum with good illumination, different varieties of sponge holders, angled and a straight long needle holder, good retractors, sterile mop, plasma expander, a large ball cannula, and this Foley's condom catheter, which I'll discuss later on. Now comes to E. E is to find out etiology. A perfect illumination is key to success. A very good speculum examination and a bimanual examination is going to lead to you to the etiology, whether it is atony, whether it is retained placenta, trauma, or clotting. Now comes to massage and compression. Once you ruled out trauma, you go for a very good compression and massage, and you can come to know the tone of the uterus. You can stimulate the tone of the uterus and atony will be treated. Now, oxytocin, what does the evidence say? A very large Cochrane database trial of more than 1 lakh women across 53 countries have shown that old is gold. Well, oxytocin is still the gold standard in treating atonicity. Carbetocin, which has been newly introduced, it is just a heat-stable molecule with no better effect than oxytocin. It has got no advantages over oxytocin. Rectal misoprostol also has got no advantages over oral misoprostol, which has been proved by multiple evidences. Regarding oxytocin, here I would like to add my personal experience. To many of the atonic uterus, I am giving intramyometrial oxytocin directly. Just 1 ampule of oxytocin to be dissolved in 10 ml of normal saline and to be given intramyometrial on both the corners, both the angles of the uterus. Even in normal delivery, you can stabilize the uterus and give directly by withdrawing. And it has given marvelous results to me. I haven't performed any single obstetric hysterectomy in last 15 years after starting this use. So I would request all of you to start using this. Even it is giving better result than intramyometrial carboprost. Now, next comes the S. S is shift to OT. Our aim is to stop bleeding and treat the cause so that we do not end up with the vicious cycle of bleeding and coagulopathy and hyperemia. Here I would like to add the role of non-pneumatic anti-shock garments, especially when patient is to be transferred from periphery to a tertiary center. It gives very good result. It saves life of a patient, especially when it is to be transferred within 3 to 6 hours. Now comes T. We rule out trauma, use tamponade. What to be used as a tamponade? Yes, uterine picking with good sterile mouth. Or we have many other options like Bakri balloon, which is costing around 9,000 rupees, zinc stick and Blackmore tube, which was to be used earlier in esophageal varices and nowadays available at the cost of around 6,000 rupees, or Rash balloon, which is available around in the cost of 3,000 rupees with a good success rate of 80% within 5 to 15 minutes. Mind well, the success rate is 80% within 15 minutes. But we, the Asians, are always master of making everything at a reasonable rate. And we have a good option to all these things in the form of Foley's balloon condom catheter, which has been developed by Askar from Bangladesh. And I think many of us are using it now with a best result in 50%, more than 80%. Here we are supposed to use just a 300 to 500 ml of normal saline to be infused with this Foley's condom catheter, and you will see a marvelous response contracting uterus. I don't think I need to discuss a lot in presence of a very good surgeon, Dr. Mahesh Bhai, the role of this B-Lynch technique and CHO. I think I would like to listen it from him, which one is better and giving the best result. But I think according to my experience, B-Lynch gives very, very, very good result if performed in time. Immediately once you find uterine atony along with best oxytocics and good perfusion to be maintained with fluid therapy and blood transfusion. Now, let me go ahead with the next, that is selective devascularization, pelvic devascularization, ligate uterine artery at its base, either and go for ligation of tubo-ovarian branch and internal iliac. According to my experience till date, whatever number of internal iliac artery ligation I have performed, I have found that directly approaching internal iliac artery, just 2.5 centimeter lateral to the sacral promontory and medial to the crossing of the ureter, gives very quick and easy access to the internal iliac artery, especially when you are dealing an obstetric patient. The role of this interventional radiology, especially the embolization of uterine or internal iliac artery, has not yet been established in emergency PPH like saving, but it may be helpful in secondary PPH with abnormally adherent placenta. There you may expect a massive secondary PPH, and it can be useful, but not that easily available in all the centers, but definitely it is going to develop in near future. I think I'm supposed to discuss only conservative management. So leaving behind this subtotal hysterectomy and concluding my talk with saying that be prepared perfectly if you don't want to leave your life partner running like this from a beautiful candlelight dinner. Have a watchful eye, continuously assess and quantify blood loss. Keep a special mark on your antenatal record card in the patients in whom you are expecting PPH. Watch serial clinical parameters to judge rather than a single pulse or blood pressure recording. A rapid, aggressive, timely, and skilled intervention is always critical for survival. Get help and make a very good team. And just remember, use golden hour. The first hour after PPH is golden hour. Chances of survival sharply reduces if management is started after 1 hour. Just do not sit praying that God is going to be helpful just simply after packing or giving oxytocics. Work, because the estimated time from start of a bleed to death is very, very short due to rapid blood loss. So you need to work aggressively to enjoy a better and to provide safe motherhood to all women. Thank you.
Thank you. Thank you, Dr. Neeta, for that comprehensive talk where within a short time, I think hemostasis, and you nicely explained about elaborately about that hemo and stasis, that is medical as well as surgical management for the massive PPH. Thank you. I think we'll take the questions at the end of the session. So requesting all to wait. Over to you, Priyanka. Unmute. Can't hear you. We can't hear you.
Anyway, we'll go to the next talk.
Yeah.
Yeah, Dr. Neeta, you were talking about the jaw suture is better or B-lane suture is better. Yeah, for our audience, I would like to tell you that for generalized atony, please don't go for a jaw suture. For generalized atony, it is better you go for any vertical compression suture. Because last year only I had come across one postpartum uterine necrosis.
Yes.
Because that doctor has done a jaw suture for generalized atony of the uterus. Because if you are doing a jaw suture for generalized atony, it gives a pocket kind of the hematomas, and ultimately that hematoma leads to the muscular necrosis.
Okay.
So just that a point I would like to make.
That is, I think hardly we do chose, except that there is some focal area.
Exactly.
Yes.
Mainly in the upper segment, that too, and that particular focal area keeps on bleeding. We can just go in one place only. We don't have to go all those 4 places, depending on the pocket. I mean, wherever the area is bleeding. Yeah, very true.
Very perfect.
Yeah, so generalized atony, no jaw. If it is a focal fundal accreta and bleeding, and if there is a myometrial weakness on one part, you can jaw on that portion. Thank you, Dr. Neeta. And one compliment I would like to give you that if you will keep on talking, then I don't think any chairperson or any moderator will stop you, because we are talking in such a sweet language and sweet tone that we always like to hear continuously.
Thank you. Thank you. Thanks a lot.
Anyway, now our next speaker is our senior colleague, Dr. Vipul Kapadia, who is also organizing chairman of this conference. So, first of all,
stop share. Neeta can stop share.
So first of all, I would like to congratulate Dr. Vipul Kapadia for arranging this Waist Journey of Fogsi. And on screen, I can see my one more senior, Dr. Mukul Bhai Shah, who is also a legendary gynecologist of Ahmedabad. So welcome, Dr. Mukul Bhai.
Thank you very much.
Yeah, and now over to you, Dr. Vipul Kapadia. He is going to talk on the peripartum hysterectomy, which is again a nightmare for most of the young gynecologists. So I think the young participant will love to learn the art of peripartum hysterectomy. So over to you, Dr. Vipul Bhai.
Thank you very much, Dr. Mahesh Gupta. As usual, I have to present the first slide as my CV, but that's really not important. The topic given to me today by the committee is to talk on peripartum hysterectomy. It is defined as a hysterectomy performed at the time or within 24 hours of delivery or a hysterectomy performed at any time from delivery to the discharge from the same hospitalization. It could be an emergency hysterectomy, it could be a planned hysterectomy, or it could be a hysterectomy in late prepartum. It's a dramatic event. It's an emergency. It is life-saving, but unfortunately, it ends the fertility potential of the lady. It could be total, subtotal, with salpingectomy, with salpingo-oophorectomy, or in rarest of rare cases, it could be even radical hysterectomy. Dr. Bharti Sharma from PGI Chandigarh gave the incidents as I've shared screen.
Morning, sir. Your screen is not
I've shared screen. Am I being visible? Is my slide being visible?
Visible, sir.
Yeah, visible, no?
So no, sir. It's not visible, sir. Please share your screen. Yes, sir. Now it's visible, sir.
Now it's visible? Okay, fine.
Yes, sir.
No, it's okay. It's okay. I'll do that now. Now,
Slideshow.
Make it slideshow, sir.
Slideshow. You can make it a slideshow.
Yeah, I'll do that.
Yes. So yes, that's all. That's good.
It's perfect now?
Yeah, it's perfect.
Yeah, thank you. Dr. Bharti Sharma from PGI Chandigarh gave us an incidence in the recent past, 2017, as 6.9 out of 1,000 of all deliveries. Now compare this to American figures, only 0.1% of all deliveries. That is something that is we must aim to achieve. Now, if you look at the incidence, it could be bleeding from the placental side, and it could be bleeding from a rupture uterus. It's a life-saving procedure in conditions of severe uterine hemorrhage, which cannot be controlled by conservative measures. But is it the first line of therapy? No, it is certainly not the first line therapy. One has to rapidly execute sequential steps to arrange the bleeding. But at the same time, you should avoid indecisiveness, you should avoid delay and procrastination. Because if you do that, if you avoid that, the hypovolemia will rapidly progress into tissue hypoxia, acidosis, hypothermia, coagulopathy, shock, irreversible shock, multi-organ failure, and ultimately death. So hysterectomy should not be offered too late. What could be the risk factors? Placenta previa with previous cesarean, transmural myomectomies, endometrial synecectomy, endometrial septectomy, ablation, coexistent large fibroids, atonic uterus, over-distended uterus, chorioamnionitis, severe puerperal sepsis, difficult vaginal instrumental deliveries, and uterine rupture, which could be due to either hyperstimulation or toe lag. Talking about toe lag, that is trial of labor after cesarean, we all know that the need for cesarean hysterectomy after first, second, and third cesarean section is less than 1%. But if you move up the order of parity, the fourth and the fifth cesarean section, the need for cesarean hysterectomy would be nearly 4%, and after fifth cesarean section, it jumps to about 9%. Compare these figures, Indian figures and American figures. We in India have uterine atony and rupture uterus that is forming the bulk of indications, whereas in the United States, abnormal placentation and uterine atony form the bulk of the incidences. What about elective peripartum hysterectomy? Cervical neoplasias, uterine fibroids, postpartum uterine infections usually form the bulk of elective peripartum hysterectomy incidences. When I started practice about 50 years ago, cesarean hysterectomy was offered to women for permanent family limitation. Believe me, it's a cruel form of birth control. Elective cesarean hysterectomy is controversial. It's a surgery on a highly vascular and altered anatomy of the pelvic organs. It leads to increased morbidity, and it should be deferred preferably when the pelvic organs return to pre-pregnancy status. Before we start doing hysterectomy, we have to, of course, take informed consent. And what do we discuss with the patient? You have to tell her that there may be intraoperative complications, there may be intraoperative interventions, there may be severe hemorrhage and the need for blood transfusion, there may be injury or even partial resection of the bladder, ureter, and even bowel, and there may be postoperative risk of fistula formation. And you also have to tell her that you may have to have other specialists around when the surgery is being performed. We have to schedule the cesarean hysterectomy as an elective weekday procedure. Inform the anesthetist that there is central vein cannulation, anesthetist that you are supposed to have, you may have to have even hysterectomy done. You have to cannulate the central cannulation of the vein has to be done, and you may have to alert the blood bank. You put a Foley catheter. It is better a three-way catheter. Sometimes a ureteric stent is put. Double suction setup is required. Adequate instruments, suture materials, and even vessel sealer should be in working order. Compression stockings will help DVT prevention. You have to give prophylactic antibiotics, and above all, you have to have helping hands. What is better, total or supracervical? Supracervical hysterectomy is safe, but total hysterectomy is required with cervical neoplasia, deep cervical laceration, placenta previa, and placenta accreta spectrum. However, there is no difference in complication rates between total or subtotal hysterectomy when performed after an emergency cesarean section. Let me tell you that the patient-specific factors and surgical experience should determine the choice. You should open the abdomen. That gives you a beautiful exposure, and a vertical median incision that can go around the umbilicus and go into the upper abdomen would be the best. You may also take a right paramedian incision, but if you have already begun the surgery with a low transverse or a phalansteal incision, be prepared to convert into a Cherney or a Maillard incision. Before you start doing the cesarean, you have to dissect the bladder down 4 to 5 centimeter initially, because at that time the patient is hemodynamic is stable. Now, the fetal delivery is done or achieved through a classical or a low vertical or a lower segment transverse incision after the bladder dissection. Placenta should not be disturbed after delivery of the baby. Hysterectomy incision is rapidly closed in a single layer interlocking suture, and extraperitonization of the uterus will always help. Now, coming to the hysterectomy part, the round ligaments are doubly clamped, cut between the clamps, or ligated or sutured or sealed. If the patient is hemodynamically unstable, you can go in for a delayed ligation of these structures. You have to cut the anterior leaf of the broad ligament and reach the utrovesical fold of the peritoneum on both the sides. After this, you now go on to tubo-ovarian pedicles, secure with 3 clamps, 2 lateral and 1 medial, and cut between the medial 1 and the lateral 2. Ligate, seal, or leave for delayed suturing. If there are lots of big vessels in the mesosalpinx, you have to have multiple ligation or multiple securing of the pedicles. At this time, you have to identify the ureters. If you find the ureters are too close, you can even cut the posterior leaf of the broad ligament and go right up to the uterosacral ligament, because that will allow the ureters to fall below and laterally, and it will also help you to skeletonize the uterine bundle. How do you now manage the broad ligament? A series of clamps are then put. And how do you put those clamps? The toe of the clamp should touch the lateral border of the uterus, and the heel of the clamp should touch the previous pedicle, because that will allow no raw areas to bleed in cases of coagulopathy at a later time. Final pedicle is the uterine bundle. After uterine bundle, don't start amputating the cervix. Do take one more clamp, that is the descending cervical branch. And only after you've secured that, start amputating the uterus for supracervical or a subtotal hysterectomy. Cervical edges are approximated with continuous or a figure of 8 sutures. If you decide to do total hysterectomy, then you have to examine the cul-de-sac for rectal reflection, incise and push it down. Dissect the bladder now further for nearly 2 or 3 centimeters more from the upper vagina. And how do you know where the cervix is ended and the fornix has begun? If it is very difficult, because the tissues are very soft and flabby. So what you can do is you can incise the cervix either vertically or transversely, put a finger, index finger in the endometrial cavity, into cervical cavity, and hook the anterior lip of the cervix and place an LS forceps, because then that will be the anterior fornix. Now, leaving the LS forceps there, cardinal ligaments are cut, clamped, and secured. Vaginal angles, the uterosacral ligaments are clamped en masse and then secured. Vagina is then severed. The cuff is sutured or may be kept open in a case of sepsis and by taking Bostonian sutures. Ovary is then stabilized. That will prevent postoperative ovarian torsion. Complications, of course, there will be urinary tract or bowel injury, there may be coagulopathy, there may be infections, or there may be complications of massive blood transfusion. There may be persistent bleeding, and you can start using hemostatic of your choice. You may need to even pack. And how do you pack? You have to pack firmly, and you have to pack all the interstitials. But at the same time, do not abrade the pelvic tissue. Observe for 10 minutes. If the blood is not seep through the pack, you can start closing. How do you close? You have to leave the tail of the pack to be brought out of the skin incision or through the vagina. You have to remove the pack after 48 hours. And how do you remove? You have to dip the end of the pack in betadine solution, let it go through, go to its main mass with capillary action, and then very gradually remove it in the next 48 hours. Bladder may be densely adherent to the cervix. Don't get scared. Open the dome of the bladder, inspect and palpate the posterior bladder wall, because that will simplify the bladder dissection from the cervix. But if you find that the bladder is fused with the cervix, resect that portion of the bladder wall. Don't get scared. Seek a help from a urologist, because that will really help you and will save you from a lot of medical legal issue. Avoid ureteric injury, of course, by all cost, but remember, hemostasis is more important, and ureteric anastomosis will be possible after hemostasis or correction of the hypovolemia or coagulopathy. Inject methylene blue through the Foley catheter. If there is peritoneal spill, there is bladder perforation. Inject IV indigo chymine 2%. If there is peritoneal spill, the ureters are severed. Do a cystoscopy, absent flow from one orifice, then the ureter is ligated, and the ureter stenting is employed to localize the site of ligation or the site of transection. So to achieve a mortality after peripartum hysterectomy to less than 1%, you have to anticipate it intelligently. You have to do meticulous preparation. You have to have a team effort, and you have to have very good technique. I thank you all for a very patient hearing. Thank you.
Thank you so very much, sir, for the wonderful talk. Now I request Mahesh sir to kindly give the concluding remarks.
Yeah, thank you, Dr. Vipul Kapadia, for elaborating on the peripartum hysterectomy. You have covered almost all the things, but just for the audience, that in contrary to the gynec hysterectomy, in obstetric hysterectomy, you have to ligate what you have to cut. Because in gynec hysterectomy, generally we cut the peritoneum without ligating. Generally we cut many things without ligating. But in obstetric, it is dictum. Whatever you cut, you have to ligate. That is the one thing. Second thing, what you have talked about the bladder adhesions and cutting of the posterior portion of the bladder. So practically, I have seen that most of the bladder adhesions is at the scar of the previous surgery. The bladder is adherent to the uterine level where there is a uterine scar. Below that, there is no adhesions. So it is always better you go from literally below that scar, below that adhesion, and then you come up. Then the chances of the bladder separation and chances of the bladder injuries are less. This is my practical experience till date. I have seen. I am doing the many obstetric hysterectomy. And third thing is, when before closing the abdomen, one must be sure of any small oozer, because most of the time in re-exploration of the post obstetric hysterectomy cases, the small oozers are there, and that can give rise to a re-exploration. Because at the time of obstetric hysterectomy, generally the blood pressure is low, and anesthesia, general anesthesia is given, or spinal anesthesia is given. So small bleeder may not appear at that time, but once the patient come out from the anesthesia, that small bleeders start oozing, and that may be the reason for re-exploration in post-hysterectomy, post-obstetric hysterectomy. That is my view. Thank you, Priyankur, and thank you, sir, for nice
thank
lecture.
you, Dr. Gupta. We have employed your technique also in a couple of cases, and we have been successful in avoiding hysterectomies there. I think it's a very good scientific contribution from your end.
Thank you, sir. Thank you so much. I'm obliged.
Thank you, Dr. Vipul. I think it was very impressive, and your experience speaks, the way you, I mean, it is your experience and the we can make out that the number of cases you have handled, I think it was a lot of learning for all of us. Thank you.
Thank you.
And particularly, Dr. Vipul sir is practicing in that area. So he is the only senior gynecologist in that area who can manage all these kind of the cases.
Thank you.
Thank you. Thank you, Vipul sir. So obviously your experiences are teaching points and it was wonderfully demonstrated, sir. Thank you so much. So next we move on to the next talk. I would request Sheila ma'am to kindly introduce Dr. Jitesh Shah sir, and he's going to talk on ICU, HDU, critical care in obstetrics.
Okay. Yeah, it's my pleasure to invite our next speaker, Dr. Jitesh Shah, to deliver a talk on ICU and HDU management in critical care of obstetric patients. He's passed his MD and DGO from BJ Medical College, Ahmedabad in 2000, worked as assistant professor at Government Medical College, Bhavnagar, presently working as additional professor at Simar Medical College, Surat, and various posts in Surat Obs and Gynae Society. And he has many publications to his credit, national as well as international. So over to you, Dr. Jitesh.
Good morning to everyone. Am I audible?
Yes.
Yes. Okay. Respected chairpersons, seniors, dear friends, greetings from my medical college, Simar Medical College. My topic is critical care in obstetrics. Am I audible properly?
Yes, Dr. Jitesh, you're audible. Please go on.
Okay. So, objective of the obstetric care is to ensure a normal pregnancy with delivery of a healthy baby from healthy mother. To achieve our objective, majority of the women require routine obstetric care. A small but significant number, however, require critical care due to disorders related to pregnancy like preeclampsia, eclampsia, obstetric hemorrhage, aggravation of pre-existing illnesses like heart disease, or coincidental illnesses like malaria, hepatitis, etc. There are 3 levels of care. Level 1 is normal care for low-risk cases. Level 2 is HDU care for high-risk cases, and ICU care in which patients require 2 or more organ support or needing mechanical ventilations need to be admitted. What will happen if critical care is not available? The outcome may be poor in the form of maternal mortality. We all know that India has very high maternal mortality ratio. But maternal mortality is just a tip of iceberg. Vast base of it is maternal morbidity. It may be mild or severe. Severe maternal morbidity is also known as maternal near miss cases. Maternal near miss, mother is a woman who is almost died but survived by chance and may suffer long-term complications like severe sepsis, genitourinary fistula, etc. And most common causes are hypertensive disorders, obstetric hemorrhage, and severe anemia. We all know that for each maternal death, at least 25 to 30 women suffer from severe maternal morbidity, and most of these complications are preventable. India has high MMR and maternal near miss ratio. One of the reasons is unavailability of the critical care services in India till now. There are different challenges to prevent maternal complications because any pregnancy can develop life-threatening complications at any time, with or without warning. Once complications develop, deterioration is fast. Also, physiological changes in pregnancy affect the management. As many diseases, the pathophysiological changes are changed in the pregnancy. Drug therapy is affected by altered pharmacokinetics, and there may be concern of fetal effect of the drugs. Even giving a CPR may not be effective in second half of the pregnancy, and mother may require peripartum or resuscitative hysterectomy within 4 minutes of the cardiac arrest to revive the mothers. Also, we have to consider 2 patients simultaneously, mother and the fetus. But favoring point is our patients are generally young and healthy and recover rapidly if they receive the critical care. India has registered a stark decline in maternal mortality ratio, which was 212 per 1 lakh live birth in 2007 to 9, which was reduced to 113 in 2016 and 18. This sharp decline in MMR caused by various national health mission activities like Janani Suraksha Yojana, Janani Sishu Suraksha Karyakram, EMOC, ambulance services, etc. Institutional deliveries increased up to 80%. Still a lot of work is required because our target is to make MMR below 70 and to reduce the severe maternal morbidities, that is near miss cases. Over the years, we have found that majority of the maternal deaths are occurring in medical colleges and district hospitals, but most of these cases are referred from periphery in a bed situation. These medical colleges and district hospitals have dedicated general ICUs since many years, but these ICUs are almost always full to accommodate the obstetric patients. Even after admission, obstetric care is suboptimal. To overcome this, concept of obstetric ICU HDU is rolled out by Government of India in 2016. So separate critical care units are required to deal the obstetric challenges in India. There are two types of specialized care unit. One is obstetric ICU that is dedicated for obstetric patients who require critical care, and another one is obstetric HDU, that is high dependency unit. It is an area in a hospital where patients can be cared more extensively than a normal ward, but not to the point of the intensive care. And another mixed model is hybrid model, in which few ICU beds are combined with few HDU beds. And it is a more appropriate way of using the resources optimally, particularly in our country. Now coming to the what is the obstetric HDU, it is an area for management of high-risk pregnancies requiring vigilant monitoring and interventions by specially trained teams. It is located near labor room and OT for easy and prompt setting of the patients whenever required. It is recommended that all pregnancies should be managed in obstetric HDU. This HDU acts as an intermediate care unit between labor room and obstetric ICU. Means when a woman becomes critical in HDU, she can be stepped up to the obstetric ICU. Similarly, when women become stable in ICU, she should be stepped down to the HDU before shifting to the obstetric ward. This HDU care is cheaper as compared to ICU care. We all know that all obstetric care all over India in government hospital is free, but for a management point of view, the care is cheaper. It reduces severe complications, so it reduces the need of ICU. It allows the continuity of antenatal, intranatal, and postnatal care by the same team with better fetal-maternal outcome. So HDU must be established in all maternity units. The persons working in obstetric HDU ICU should be properly trained. Obstetrician, medical officers and staff nurse all should be trained in critical care, and medical officers and staff nurse should be trained in obstetric services, including neonatal care. Criteria of number of beds are laid down by government, that means the units which have more than 1,000 deliveries per month should have 12-bedded hybrid ICU, and the units which has less deliveries, less than 500 per month, only HDU is sufficient. And at present, almost 500 HDUs are functional in India. Regarding criteria for admission in HDU, mothers with obstetric complications like severe anemia, antepartum hemorrhage, postpartum hemorrhage, severe preeclampsia, eclampsia, multiple gestations with complications, vesicular mole, ruptured ectopic, septic cases, and post-operative patients requiring intensive monitoring can be admitted. Similarly, pregnancy with medical or surgical disorders like endocrinological disorders, renal disease, jaundice, respiratory disorders, complications of malaria, dengue, surgical illnesses like appendicitis, pulmonary edema, pregnancy with poisoning can be admitted in HDU. Different parameters are laid down regarding criteria for admission to HDU and ICU, which includes pulse, blood pressure, respiration, urine output, electrolyte imbalance, pH, maternal pH, SpO2 level. But indications depends upon the clinical condition, severity of the illness, and the numbers of the organ involved. Broadly, patients require admission in obstetric ICU if she is hemodynamically unstable, needs advanced respiratory support, needs inotropic support, having DIC, ARDS, or multi-organ failure. Always, mothers with complicated by infectious diseases like COVID-19, H1N1 should be kept in the isolation. So, if the persons working in the ICU are trained properly, and there is definite SOP regarding management of different complications, works become smooth. Otherwise, chaos occurs without proper outcome. Apart from routine equipments and instruments, ICU requires different instruments like infusion pump, syringe pump, central oxygen suctions, multi-para monitor, ventilator, defibrillator, etc. We all know that we need multiple investigations frequently, so it should be backed up by proper laboratory support. Also, fetal surveillance in the form of CTG, ultrasonography machines should be available. If required, delivery tables should be there, and facility for neonatal resuscitation should be available. Regarding fetal outcome in the mothers admitted in HDU ICU, it depends upon the maternal conditions. The outcome may be poor, so they require intensive fetal monitoring. Preterm delivery may require, so consider steroids, and delivery timing should be decided as per the maternal and fetal conditions. So in comparison, in nutshell, HDU and ICU are dedicated for obstetric patients. Roughly bed requirement is 10% of the obstetric load for HDU, 0.9% for ICU. Obstetrician is in charge for HDU. Obstetrician plus anesthetist in ICU. In HDU, mother condition is usually stable after delivery, so maybe can be accompanied, and breastfeeding should be supported, which may not be possible in ICU due to critical condition of the mother. Staff nurse requirement is less. Infectious morbidity is less in HDU than the ICU. Expense is less, and environment is more patient friendly in HDU than the ICU. We all know that transportation of critically ill patient to the ICU is a very challenging and responsible task. Condition must be documented properly and consent must be taken. Proper referral slip is must. It is mandatory to inform ICU team before referral, so they are ready to accommodate the patients. Ideally, patients should be accompanied by the doctor or staff nurse to monitor the vital during transfer and to continue the resuscitation. This is our own HDU ICU data in 2020. We have 6-bedded hybrid ICU with 3 ventilatory facilities. We have around 8,000 deliveries. In 10% cases, we required HDU ICU admissions. Most common reason was preeclampsia, eclampsia in 27% cases, followed by PPH, then APH and severe anemia. To conclude, critical care is the need of time to reduce maternal morbidity and mortality. Critical care units should be established in maternity units. All high-risk pregnancies should be managed in HDU. HDU care will suffice when single organ support is required, and patients with multi-organ failure should be managed in ICU. A good understanding between multidisciplinary team is a must for the success. Thank you for patience hearing.
Yeah, thank you.
Thank you. Thank you, Dr. Jitesh Shah. I think it was, in a nutshell, I think you made all the points very clear, the importance of HDU. And I think now everybody is geared up all over the country. You spoke about Laksha initiatives also. So almost the district hospitals where the delivery load is up to 500 also are gearing up to have the HDU beds. And I must tell you that we are really proud of our president, Dr. Alpesh Gandhi, who is one of the main contributor to this HDU concept to Government of India. And we all have those guidelines with us for HDU. And thank you, Dr. Jitesh, for that elaborative deliberation about the need for HDU as well as ICU. As you rightly said, that it is not only the mortality, but we are also looking at the morbidity, and that also is in our hands. And if we manage them in a HDU, definitely I think the morbidity can be managed in a better way, as well as the case fatality ratio also will come down. Thank you. If you have any questions, we can take it, I think, for all the speakers.
Thank you, ma'am. I must mention over here that, as you mentioned, Alpesh sir is a pioneer in the HDU care in India. Now we are doing the UNICEF project as well, where for the Lakshya training and also for the HDU care, it's going a long way towards training the district hospitals as well as the medical colleges. So I'm very sure Alpesh sir would be proud of the presentation of Dr. Jitesh sir. Alpesh sir, I think, wants to say something.
Thank you, Priyankur. And first of all, I would like to congratulate Dr. Jitesh for nicely covering all the aspects briefly in a short time. It's a big topic itself. I would like to inform all of you that we have lots of data from many medical colleges, as Dr. Jiten has produced the data of Smimmer Hospital. Similarly, we have collected data across India from many medical colleges, hospital, and it is found that 1 year before the advent of the establishment of obstetric HDU ICU and 1 year after the establishment of obstetric HDU and ICU, and it has found that improvement in 50 to 60% of maternal mortality in a single year in many institutes because of this. So now when Government of India is also going outside India and representing some of the health summits, they are also presenting this data. And previously we have 3-tier system in our Indian obstetric practice. It was a stillbirth attendance, then basic emergency, and then comprehensive emergency obstetric care. Now it has extended to 5-tier, and HDU and ICU are included. So we have brought successfully, we could brought revolution in Indian obstetric system also. And now our aim should be, as Dr. Jitesh has mentioned, nearly 500 obstetric HDU ICU are functioning in India. So now we need 500 experts to run these obstetric HDU and ICUs, and where our responsibility is there. So at Fogsi, we are active for providing these experts to our country. We are prepared. We have our syllabus. We have our critical care fellowship courses. We are also trying to discuss with some of the recognized universities, and now the course had been started in many universities. So I am requesting all those who are interested in high-risk pregnancy critical care, please do this course of critical care in obstetric, because it is the need of our country. Once again, I would like to thank Priyankur and Dr. Sheila Mane and Dr. Mahesh Gupta for giving me this opportunity. And once again, I would like to congratulate Jitesh for the excellent presentation.
I think we, during Abhigyan, our VC promised that we'll be starting in Rajiv Gandhi University, Bangalore. So
Yes,
let
yes,
us all follow it up and see to it.
So
Yeah,
please,
that's again
please remain in contact with your VC, because VC is interested in starting this course in Karnataka, but we need to provide all the details and all the material.
Sure, sure. Thank you.
Thank you.
Thank you, sir. Now, ma'am, I don't see any questions in the Q&A box. So we will start the oration. I would like to thank Dr. Mahesh Gupta, sir, and Sheila, ma'am, for the wonderful chairpersonship, and Dr. Nalini Anand, ma'am, Dr. Neeta Sata, ma'am, Dr. Vipul Kapadia, sir, and Dr. Jitesh, sir, for the wonderful talk.
And he's a very senior faculty who has demonstrated notice and BH and many other surgeries, national conferences.
Okay, so now I would now we have the pleasure of the presidential oration for the session. It's a plenary session that we will be running in both the halls. So to chair this session, it's my proud privilege to welcome Dr. Narendra Gajjar, sir. Sir is the organizing chairperson of the West Zone Yuva Fogsi conference that is being conducted so very well. He had his career in the BJ Medical College, Ahmedabad, where he was awarded a number of prizes. He is a practicing obstetrician.
Priyanku, there is an echo from other hall. I think the B hall we can hear.
Ma'am, it's echo from Narendra sir's screen, I think, sir. If you can just reduce the volume of the screen, please.
Hello. Hello.
Sir, you are audible. Sir, you are audible. But
Yeah, you are audible in
side,
hall
sir.
A. Priyanku, you are audible in hall A.
Yeah, now it's better, sir. Sure, sir. Okay.
Yeah. Now let me ask whether people from hall B, they can see it or
They
not.
have finished,
Please.
sir. They have finished. They have finished.
They
They are
have
joining this
finished,
hall,
but
sir.
whether this the same thing is being relayed, so whether they can see us or hear or not. Just a minute, hall B.
Yes.
So if it is not relayed, we are instructing them to change the link and enter into the hall A.
नहीं वही मैं मैनेज कर रहा हूँ मैं अभी हाँ मैं यहाँ पे ओके
चलो तुमके
एक वैलिडिटी ना प्रोटोकॉल पे चले अच्छा
Ms. Jhalak, I would like to request you to give us a green signal once this oration is relayed in Hall B as well.
We could just wait for a moment. They are just shifting also in the Hall B.
Sure, great. Yes.
So they will relay both the things in Hall A and Hall B simultaneously. Just wait.
Great. No problem. Sure. Just let me know once we start.
So then if they cannot, then you can pass an instruction that just they change the link and it will take only seconds.
Hello. Hall B છે relay થઈ ગયું Hall B માં. Okay. Priya, now you can.
Sure. Thank you.
Then can you see the things in Hall A, Hall B?
Yes, we can see.
Okay, so fine.
Okay. So thank you. Now it gives us immense pleasure to have the presidential oration session. So I would like to first of all invite the chairpersons for this session, Dr. Narendra Gajjar sir. He is organizing chairperson of the West Zone Yuva Fogsi conference that has been beautifully conducted this year. He has a brilliant career academically and is a senior gynecologist practicing for 37 years in Ashirwad Hospital in Chikli. He is also a faculty in many international and national conferences. I would also like to invite Dr. Vipul Kapadia sir, who is a pioneer in the area of Navsari. He has installed the first ultrasound machine over there. He has brought in IVF to the region and also endoscopy. So it gives me immense pleasure to welcome Vipul sir to this platform. We already have heard him and we have already seen the experience that he has already gathered through his practice. And it's also my immense pleasure to welcome Dr. Satyan Kasabala sir. He is presently the secretary of the Navsari OBGYN Society, organizing secretary of this wonderfully organized conference, and he has been a past organizing secretary of the SOGO conference at Daman, as well as the midterm SOGO conference. So welcome, sir. Now it's my pleasure to invite Dr. Satyan to kindly introduce our president, Dr. Alpesh Gandhi, sir.
Good morning, everybody. It's a proud moment for us and for the Gujarat to introduce our own Dr. Alpesh Gandhi on this platform. One is sitting at the Fogsi level and one is sitting at the Parliament, Dr. Mr. Narendra Modi. So he is the president of Fogsi. He is the resource person for Fogsi's on pregnancy with COVID-19. He prepared the National Registry on Pregnancy with COVID-19 infection. He is a resource person to prepare guidelines of establishment of obstetric HDU ICU. He is a resource person to prepare operational guidelines on obstetric HDU and ICU. And he is a resource person to prepare Fogsi justices and preparing the guidelines for on optimizing CS rate. His book on principles of certificate critical care in obstetrics and available in more than 5,000 world-renowned medical libraries and translated in Chinese and Spanish language. RCOG awarded him with the Honorable FRCOG. He received the Best Society Activities and Best Publication Award from Fogsi. He is the convener of one of the most successful annual conference of Fogsi AICOG 2017 at Ahmedabad. He is practicing at high-risk pregnancy expert at Ahmedabad since 29 years. He is the president of Fogsi 2013. He is a chairperson, practical obstetric committee Fogsi. He is the vice president, Justices India chapter at Ahmedabad OBGYN Society 2011. He was the secretary also from the Ahmedabad Society. With him many publications and also the editor for the so many journals and Fogsi. He has the right now chief editor of Fogsi book of obstetrics and gynecology. So his innumerable publications and editorial team. So it's a really proud privilege to introduce him, Dr. Alpesh Gandhi, with us.
Thank you, Dr. Satyan. Sir is going to talk to us about women's health crisis in COVID-19 pandemic, and I would request Dr. Vipul Kapadia sir to kindly introduce the topic, and then we will move on to the presidential oration.
Good morning, all Foxians. May 28, our conference began. Also, May 28 is the International Women's Day, and we have to respect the women's health. And what is women's health? Women's health is the menstrual hygiene, her reproductive health, her antenatal care, labor, delivery, postpartum, then contraception, sexual health, mental health, perimenopausal health, menopausal health, and COVID-19 pandemic has affected almost all these aspects. And it's a beautiful coincidence that Dr. Alpesh Gandhi is going to be talking to us on the topic of women's health crisis during COVID-19 pandemic on this conference, which began on May 28. It's a beautiful subject, and I'm quite sure he will give the utmost justice to this lovely topic. Over to you.
Yes, so thank you, Vipul sir. So Alpesh sir, the stage is all yours, and we are waiting to listen to you on women's health crisis in COVID-19 pandemic. Ms. Jhalak, I would request you to kindly mute everyone. Let only Alpesh sir be unmuted. Thank you. Sir, requesting you to kindly unmute yourself, sir.
Am I audible now?
Yes, sir, you're audible, sir, and the screen is visible too, sir. Thank you.
Okay. So, respected chairpersons, Dr. Narendra Gajjar, organizing chairperson, West Zone Yuva Fogsi Conference, Dr. Vipul Kapadia, organizing chairperson, West Zone Yuva Fogsi, my brother, Dr. Satyen, organizing secretary, West Zone Yuva Fogsi Conference, respected teachers, respected seniors, dear friends, a very good morning to all of you. First of all, I would like to congratulate Navsari Society and the organizing team for this wonderful conference, for the great scientific program, for proper execution, for the great teamwork. We all are enjoying the conference and scientific deliberations. I am also thankful to West Zone Yuva Fogsi organizers for giving me this opportunity, for awarding me this oration, for honoring me. I am thankful to all of you, and I have no words to express my feeling. I am going to speak on a topic, women's health crisis in COVID-19 pandemic. And I think being a President Fogsi, I should take this topic. I should speak on this particular topic. This is very relevant to the present need of our country. We all should know how much it is affected. 30th of January 2020, WHO declared it's a public health emergency of international concern. On 11th March 2020, WHO declared it as pandemic. The biggest impact, no doubt, will be a need to reassess priorities in health and how we access and deliver healthcare. Till WHO declared its pandemic, it is number of cases still increasing across the world, and total number of cases till yesterday in the world was 17 crore 4 lakhs. Out of this, 35 lakhs and 43,000 people lost their lives. Sorry. In India, the number of cases reached to 2 crore and 78 lakhs, and out of these, 3,25,000 people lost their lives. So a very huge number and significant number of deaths across the world and of course in India occurred because of this pandemic. Last year, WHO has released a graph showing the sex ratio and age ratio affected with COVID-19. It is said that men are affected more than women, female, and it is true. But if we look at the age-wise ratio, then here we can see that. Sorry. Here we can see that the between 20 to 29 years of age, more female are affected, and we all know that our population, mainly pregnant women, are younger and belong to this group. There is emerging evidence suggests that more men than women are requiring critical care and are dying, maybe due to more association with comorbidities or sex-based high immunity or behavioral differences such as smoking. On 29th December, Government of India released the data. Men and women respectively account for 63% and 37% of the total cases in India. And 70% of COVID deaths have been reported in men, and 45% fatalities due to disease reported in less than 60 years of age. But if we look at the case fatality rate, then this is not true. There is an eye opener. Of course, men are affected more and more men are dying than women. But if you look at the case fatality rate, then across the world there are 4 countries where case fatality rate is higher in women compared to men. And India is one of the country. India, Nepal, Vietnam and Slovenia are the countries where case fatality rate is higher in women. As per the Lancet, November 5, in India, the case fatality rate among men is 2.9, whereas among women it is 3.3%. So when we are taking care of women of India, it is eye-opener for all of us that of course men are dying more, but case fatality rate, that means severity, is more in women. Women's healthcare crisis in COVID-19 pandemic affected women's healthcare in 3 different ways. Direct effect of COVID-19 on women's healthcare. Less women are approaching to the healthcare facilities because of fear of getting COVID-19 infection, and because of measures taken to combat COVID-19 pandemic like lockdown. The world had experienced that during Ebola virus outbreak. An estimated 3,600 maternal, neonatal and stillbirth birth occurred, which were equal to the number of deaths directly caused by Ebola virus. Women's healthcare crisis, as Dr. Vipul Bhai has mentioned, affected in different ways, in different services: maternity care, contraceptive care, abortion care, gynec surgeries, including laparoscopy, oncogynec care, mental health, domestic violence, and it has affected many more. 86% of deaths in New York State in the ongoing COVID-19 global pandemic have occurred in people with comorbid non-communicable diseases, maybe diabetes, hypertension, obesity, COPD, cardiovascular disease, asthma. And across the world, it has been found that 70 to 85% of patients are having comorbidities. But is it true for women? Huntos Zahed et al. Analyzed 9 pregnant women with severe infection, and out of this 7 of women patient died. Out of 7 reported maternal fatalities, 5 had no underlying health issues, suggests that pregnancy could put women at higher risk of consequences. So out of these 7 reported deaths, 5 were not having any comorbidity. Similarly, government of Brazil Ministry of Health released data and of 20 maternal mortality, and out of this 20 maternal mortality, 9 pregnant women, means 45%, were having no risk factor, were did not have any comorbidity, and only 9 had 1 comorbidity. Means on one hand, average patients when comorbidity mortality, if we look at the mortality, then the morbidity has been found in 70 to 85% of patients. But in women, particularly in pregnant women, we have found that in 45 to 60% of patients, pregnant women do not have any comorbidity. Is pregnancy works like itself a comorbidity. We cannot say pregnancy is a comorbidity, but effect of pregnancy is something like which comorbidities can affect. Similar type of effect we can see when patient is pregnant, because 40%, 50 to 60% of women are not having any comorbidity, which is different from the average ratio. Again, if we look at the Indian data, then 8 pregnant women out of 700 total pregnant women delivered with COVID-19 at Nair Hospital. Out of these, 7 pregnant women died. And as per Fogsi's National Registry on COVID-19, Fogsi is the first organization in India to start any registry for COVID-19. We have started our COVID-19 in pregnancy registry since beginning of the April last year. And till August end, we have the interim report. And as per the interim report, out of 989 COVID-19 positive pregnant women, 10 mothers died. So we all know that the maternal mortality rate in India is around 115 out of 1 lakh live births. So if we extend this rate of maternal mortality, 10 mothers died out of 989, then the average pooled data we can say is 1000 mortality per 1 lakh birth. So we can say when pregnant lady developed COVID-19 infection, then the possibility of maternal mortality increases by 7 to 8 times more. So it is a very, very significant number of increase in maternal mortality if we compare pregnant women who develop a COVID-19 infection and pregnant women who do not develop COVID-19 infection. Moreover, there are many maternal deaths which are unreported, maybe because of home delivery due to fear of getting COVID-19 infection at hospital, maybe because of refusal of admission of a pregnant woman with labor pain because of some of the health facilities are shut down, or maybe because of the problem of staff, or maybe because of fear of again getting infection of COVID-19, and maybe because of during shifting from one hospital to another hospital because of confusion of COVID and non-COVID designation, and because of non-availability of beds in some of the hospitals. So many, there may be some of the deaths, maternal deaths, which are unreported. After maternal mortality, if we look at the requirement for admission in intensive care units, then initial reports from United States are consistent with those from China. 8% of pregnant or postpartum women with COVID-19 have severe disease and they require admission in HDU ICU, and approximately 1% are critically ill. In an analysis of 8,207 cases of COVID-19 in obstetric population, CDC reported a higher risk of ICU admission and mechanical ventilation compared to non-pregnant women. And Al-Safi et al. Highlighted 4.41% of COVID positive pregnant women require admission in intensive care units. It means in routine case when there was no COVID-19 pandemic, or when pregnant women do not develop COVID-19 infection, if we compare, usually the average rate for admission in ICU is 1 to 1.5% in normal cases when there is no pandemic. But in this COVID-19 pandemic, this need for admission in ICU increased to 4.4% again, which means it means 3 to 4 times more than normal requirement of ICU admission. And again, if we look at our own registry, our own Indian data till the end of August, then in our registry, we have found that 7.19% of pregnant women require admission in obstetric ICU. Again, it means we can say 5 to 6 times more pregnant women require admission in ICU when they develop COVID-19 infection. Now, if we compare the first wave with the second wave, then in Nair Hospital, Mumbai, which is the designated hospital for COVID-19, last year from April to December, in 9 months, 12 mortality were reported. Whereas this year in the second wave, of 4 months of second wave, they reported 26 deaths. Significant increase in maternal mortality in the second wave. The mortality rate that was around 0.2% in Nair Hospital last year has increased to more than 0.8%. And the sad part is, the eye opener is, The deaths have been caused by complications of lungs, kidneys, and brain triggered by the COVID-19 infection. And there were no deaths in Nair Hospital in this 26 mortality because of obstetric reason. So all mother lost their lives because of COVID-19 infection and its complications. In Kama Hospital, Mumbai, again, it was found that oxygen requirement appeared to be higher unlike last year. In our one of the medical college, again, if we compare, then the first year and the first wave and the second wave, then in second wave, the admission need for the admission in HDU ICU increases a lot, and maternal mortality also increases a lot. There is 4 to 5 times or 7 to 8 times more need for admission in ICU and admission in HDU, and there is 6 to 7 or 8 times more mortality also. And again, if we look at the stillbirth, then again the number of and percentage of stillbirth increases in the second wave. So there are lots of medical colleges who have who came out with this data because of because of a shortage of time. I am not going in detail of so many medical colleges, data of so many medical colleges, but it has been found that during second wave, the infectivity, the severity, the criticality, the mortality, and IUFD also, number of stillbirth also increases significantly compared to first wave of COVID-19 in our country. Again, one article was published by the UN of direct and indirect effects of COVID-19 pandemic and response in South Asia. And they estimated that there will be a 10% increase in stillbirth in India, and they also estimated that there will be 18% increase in maternal mortality in India when pregnant women develop COVID-19 infection. So when pregnant women more than age of 40 years, when they are having obesity or severe anemia, or when there is a history of asthma or any comorbidities, uncontrolled high-grade fever with high CRP, when pregnant women with COVID-19 infection have more than respiratory rate more than 30 per minute, SpO2 less than 93%, at rest or after 6-minute walk, when imaging showing more than 50% lung involvement, when neutrophil lymphocyte ratio is more than 3.13, and when there is a significant increase in IL-6, significant increase in D-dimer serum ferritin and LDH. These are the women who are at risk, and they require care in intensive care unit, and probably they are at risk of severity, criticality, and mortality also. There is a big unmet need in India for contraceptive and family planning measures. The big unmet need is from the period of non-COVID also. But now, because of COVID, the unmet need increases a lot. UNICEF has estimated that the forecast birth in the 9-month span, dating from when COVID-19 was declared pandemic, the countries with highest number of forecast births are expected to be, and India is number 1 country. The forecast birth is for India is 20.1 million in these 9 months. And as we have discussed, the unmet need for family planning and mortality is already there, and there is further decline in these services during lockdown and after that because of the COVID-19, because of fear of getting infection of COVID-19, maybe because of problem with transportation, maybe because of problem with supply chain of medical abortion drugs, maybe because of so many other problems. There is a further decline in the service of family planning and abortion across India. And as per the article published in a survey conducted by Health Economic Advisor, it was found that in Asia Pacific region, the decline is found to be between 20 to 50% in different countries. And if we take it the best case scenario of decline of family planning and abortion services of 20%, then there will be it is estimated that it would lead to 25,493 additional maternal deaths. And if we consider the worst case scenario of 50% decline in use of family planning and abortion services, then it will lead to 68,422 additional deaths because of the decline in family planning and abortion services. so many unwanted pregnancies and so many unsafe abortions are there, and which can lead to this extra maternal deaths. One situational analysis study was conducted by Fogsi in association with Indian Pediatric Association and UNICEF in Gujarat, and at 670 private pediatric and obstetric facilities in providing services, and it was found that 63% of obstetric facilities and 67 to 68% of pediatric facilities continued the vaccination services, whereas in remaining obstetric and pediatric healthcare services, they stopped vaccination or they suspended temporarily the vaccination services, and because of lots of women and lots of children are deprived of vaccination services and can develop infections. If we look at the incidence of cesarean section, then across the world we found that the incidence of cesarean section increases tremendously because of this COVID-19 pandemic. From initial report from Wuhan city, China, 93% of pregnant women underwent cesarean section. And then report from Italy, Bologna city, Italy, it was found that 90.2% women underwent cesarean section. Later on, then from systemic review, including 538 pregnant COVID-19 patients, reported that 20% of women delivered by preterm delivery and 85% delivered by cesarean section. A prospective cohort study of 427 pregnant women in UK found that 27% delivered by preterm delivery and 59% delivered by cesarean section. Again, in New York City, a cohort study of 241 pregnant women, it was found that 50% delivered with preterm delivery and 52% of severe infection patients have undergone cesarean section, and 92% of those with critical disease had undergone cesarean section. If we look at our own registry, Foxi's National Registry, our own data of India, then interim report till August, we found that 59.71% of pregnant women with COVID-19 infection underwent cesarean section, and our incidence of preterm delivery was found for 18.9%. So the incidence of preterm delivery of India is at par with other countries across the world, but incidence of preterm delivery before COVID-19 pandemic in India was 13%, which has increased to 18.9%. Again, if we look at the incidence of cesarean section, then India is at a lower side. Across the world, the incidence has been found of cesarean section has been found from 54% to 92 or 93%, in the range of 54 to 93%. So India is at a lower side of this range compared to so many developed and other countries where the incidence of cesarean section is significantly high. But again, if we compare the incidence of cesarean section in India, then before COVID-19 infection, then in 2018 and 19, India conducted 20% of total institutional deliveries through cesarean section. So our incidence of cesarean section increases from 20% to 59.71% in institutional deliveries because of in this COVID-19 pandemic. In a prospective cohort study in UK, it has been found that the stillbirth rate among infected women was almost 3 times the national rate. They found that 11.5 stillbirth versus 4.1 stillbirth per 1,000 total births. So again here they have found 3 times more stillbirth. So incidence of stillbirth across world, there are so many reports. We have found that the incidence of stillbirth and IUFD increases significantly. Again, one interesting article was published in JAMA, and they compare with pandemic and non-pandemic period, and they found that 9.31 stillbirth per 1,000 births versus 2.38 stillbirth per 1,000 births. So again here we can see significantly 4 times more stillbirth were reported. Again, another article published in JAMA, it was found that stillbirth rates were 1.2 during pre-pandemic period versus 7 during pandemic period. So again here we can found that the incidence of stillbirth increases 5 times more an increase in stillbirth during pandemic was reported in a large British hospital, London, but surprisingly, none of this stillbirth occurred among women with documented COVID-19 infection. In this study, all women with stillbirth were asymptomatic. So it is not required that stillbirth will occur when pregnant women have infection or when pregnant women have symptoms and severity. None of the stillbirth occurred in women with COVID-19 in large British hospital in this study. And the reason was probably because of the fewer antenatal visits, because of fear of getting COVID-19 infection, because of the resistance to visit healthcare facilities, or maybe because of many other reasons. They were deprived of healthcare facilities, and because of this, the fetuses which were at the risk, which were at the distress or at risk, could not be identified, and they lost their lives. So there are so many direct or indirect effects of COVID-19 pandemic on pregnant women and the fetuses, and across the world it has been found that the incidence of stillbirth also increases 3 to 4 times more. If we previously it was thought that there is no vertical transmission, later on we came across the evidences which suggest that there is definitely vertical transmission can occur, but the incidence is very low and not much significant. Systemic review and meta-analysis of 17 studied were included in one of the three, and it was found that vertical transmission was found in 16 per 1,000 newborns. Again, in a systemic review of infants born to 936 COVID-19 infected mothers, it was found that 13 units were having vertical transmission. So the incidence of vertical transmission was found in this study was 3.2%. And in our own study in India, Nair Hospital, out of 700 deliveries, 40 babies were found to have COVID-19 infection, vertical transmission. So in our study at Nair Hospital, as the little more incidence, 5.7% incidence of transmission, vertical transmission. And again, coming back to our own registry, till the end of August, the interim report suggests that 12 stillbirth out of 792 deliveries means 27.7 stillbirth per 1,000 newborns, again significantly increase in the incidence of stillbirth in India, and 30 infants means 2.99% neonates had vertical transmission, which is at par with the other countries. And the need for NICU admission was found in 28.34% of the infants. Maybe with the more and more experience, this need probably have decreased. But this till August, many neonates were admitted in NICU. Just on precautionary measures also. Again, coming back to the decrease in the services of abortion and family planning, as the pandemic spread, many countries implemented tough lockdowns and travel restriction in a bid to slow the transmission, and India lockdown was introduced on 24th March 2020 for a longer period. We had experienced that the West South Africa Ebola virus disease outbreak had showed that the biggest threat to women's and girls' lives was not the virus itself, but the shutdown of routine health services and fear of infection that prevented them from going to open healthcare facilities. UNFPA predicts 7 million unintended pregnancies worldwide because of decline in the abortion and family planning services. Mary Stopes International, working in 37 countries, estimated that there will be nearly 2.7 million unsafe abortions and 11,000 pregnancy-related deaths. Foundation for Reproductive Health Services India estimated that 2.3 million unintended pregnancy and over 8 lakh unsafe abortion. And we all know that in India, unsafe abortion is the third leading cause of maternal deaths. Again, IPAS estimated that 1.85 million abortions, means 47% abortions were compromised during lockdown. And all this had led to so many implications in women's healthcare. Women are now able to access abortion services but little delayed had happened, and because of this, many women had to undergo surgical abortion instead of medical abortions. Many women have a requirement for second trimester abortion instead of first trimester abortion. Many had to undergo abortion more than 20 weeks, which was the legal limit for abortion last year. Many had to continue unintended, unwanted pregnancy, and some of women may resort to unsafe abortion. So these are the implications of declining family planning and abortion services in India, and the situation adds additional responsibilities on the health system to offer remedial safe option to these women. Again, because of the disruption in global supply chains for contraception could result in more sexually transmitted infections, including HIV, and the risk of sexually transmitted infection, in particular HIV, going in the wrong direction could be proved catastrophic in future. Several countries had taken several actions. In Australia, telehealth consultation for early medical abortion have increased by 25%. Ethiopia approved a pilot scheme for nurses to provide medical abortion in homes. Nepal stipulated that medical abortion can be delivered outside of healthcare facilities. And in India, government has issued telemedicine guidelines that do not rule out medical abortion. Fogsi had foreseen that this problem first in India and published a short advisory on 27th March, immediately within 3 days of lockdown, to continue an essential time-sensitive health services, maternity services, SRS services to all the women of India, and for the use of telemedicine services. And later on, after 17 or 18 days, Government of India also published the same advisory on 13th of the April. So Fogsi had taken so many proactive and measures to tackle COVID-19 pandemic, to tackle the effects of COVID-19 pandemic on women's healthcare. Again, coming to the gynec surgeries, all elective surgeries, there is a consensus among all the national, international surgical societies that all elective surgeries should be avoided. Only emergency, life-threatening and selected semi-emergency cases should be posted for surgery. Whenever possible, a non-operative management should be considered. Alternate route of surgery, then laparoscopy can be considered when possible. So these were the guidelines published by some of the surgical and national and international surgical societies. Again, laparoscopy remained the preferred surgical route, we all know that, but because of a theoretical possibility of generation of aerosols contaminated with COVID-19 from leaked carbon dioxide and smoke generation after energy device use, so many endoscopic societies came out with the different guidelines. They advise for RT-PCR test in every patient before surgery. Again, they advise for a smaller pot size. They advise for insufficient pressure of carbon dioxide should be kept minimum. And because of the so many other restrictions, all surgical societies related to endoscopy agree that there should be a minimum use of energy devices wherever possible. And because of this, all guidelines restriction to postponing of gynec surgeries and changing of the preferred route of surgeries, and now women had to continue to suffering of problem for a longer period or a longer time. Again, there is a skyrocketing increase in the gender-based violence during this pandemic, and it is itself a pandemic within a pandemic. In Colombia, reports of gender-based violence during lockdown increased by 175%. Gender-based violence has distinct the pandemic because of restriction of contact, because of restriction of movement, because of being trapped in abusive situations. Before pandemic, it was estimated that 1 in 3 women experiences violence during their lifetime. Now these women are trapped in homes with their abusers. Crowded homes, substance abuse, limited access to services, reduced peer support are exacerbating these conditions. In some of the countries, cases have found to be double. There is a different countries have different studies. The incidence of gender-based violence increased from 25% to 200%. Violence against women is increasing as it combines with economic and social stress also. A survey conducted in New South Wales, Australia revealed that 40% of frontline workers have reported increased requests for help by survivors during outbreak. Domestic violence shelters are deemed essential services now in many countries. Again, mental health crisis suffered a lot. Physical distancing, stay at home have had larger implications for women in every sphere of their lives. There have been an exponential increase in unpaid work with closure of the schools and colleges. Burden of increased household responsibility, heightened care needs of family members, particularly single parent is facing significant difficulty in supporting themselves and their families, increased vulnerability to domestic violence and partner abuse, economic stress during the outbreak expose them to increased risk of exploitation by the service provider, by the owner of the job owners. Then the threatened complications in reporting and seeking help. So many factors are there which had led women for mental health crisis. Again, diminished community support, disconnection from the social network, inability to seek temporary refuge outside home. Women are experiencing chronic distress and experiences various mental health outcomes, including depression, anxiety, trauma, self-harm, and in some of the countries, suicide have also been reported. There is increased risk for perinatal mental health in pandemic, maybe because of rapidly spreading disease and more number of pregnant and lactating mother catching the infection, maybe because of fear, constant fear of getting infection, maybe because of uncertainty of disease diagnosis, prognosis and treatment. And many of these pregnant women lost their near and dear ones in their family because of the disease. So they are under constant stress, emotional stress, and constant fear. Social media and news channels play a counterproductive role. Impact of lockdown and poor social support due to restricted movement of people. Many pregnant women are also now found to have increase in the incidence of postpartum psychosis. So again, mental health has been suffered a lot in women. So we need to come out with certain strategies to tackle this mental health. We need to increase awareness and advocacy campaigns among women. We need to start helpline number working for 24/7. We need to start designated domestic violence shelters as essential services. We need to start designate safe spaces where they can report their abuses. Then we need to move services online and create social network for survivors. We need to prioritize sexual and reproductive health care services, and we need to provide them psychological counseling, support and treatment and legal aid. So many things we require to provide to save them from this mental health crisis. And it is now established fact that pregnant women are at increased risk of severe COVID-19 associated illness compared with non-pregnant women. Such illness can require hospitalization, intensive care unit admission, mechanical ventilation, IUFD, and even can cause death. So the prevention is always better. Thus, preventing critical COVID-19 infection is of paramount importance for both mother and her fetus. And therefore, Fogsi came out. Again, Fogsi took the initiative to came out with its position statement for demanding for advocacy COVID vaccination for pregnant and breastfeeding women across India. And with the support from all of you, I would like to take opportunity to thank all the Fogsians and all 260 societies for supporting Fogsi's position statement, for advocating, for pushing advocacy statement to all the authorities, to all the governments, to all the policymakers, and to all the media. Now we can have lots of debates on TV, on print and electronic media about the vaccination to pregnant and breastfeeding women. And thank you to Government of India that they also approved now COVID-19 vaccination for lactating women. And I'm quite hopeful we are continuously pursuing our advocacy for pregnant women. And I'm sure and I'm quite hopeful that within a week or 10 days, we will have this positive news, this good news that now our pregnant women would also be able to take COVID-19 vaccine. Till then, we have to wait because at present it is not approved and we can't give, but it is our moral responsibility to counsel all the breastfeeding women to take COVID-19 vaccine at the earliest. Across the world, 4 premium organizations of women's healthcare came out with the guideline or the position statement. FIGO, ACOG, RCOG, and our own premium organization, Fogsi, all 4 premium organizations are advocating, recommending COVID-19 vaccine for pregnant and breastfeeding women. So in conclusion, maternity care is an essential healthcare. Accessibility of vaccination, quality, respectful in-time maternity care is a right of every pregnant woman, irrespective of COVID-19 health crisis, irrespective of COVID-19 pandemic. COVID-19 is not the indication for cesarean section, not the indication for induction of labor. Of course, complications because of COVID-19 can force us for the induction or cesarean section, but COVID-19 as such itself is not big indication for cesarean section. Prevent the preventable like preterm delivery, stillbirth, and unsafe abortion. COVID-19 may not be so harmful than not getting healthcare facility because of just fear of getting COVID-19 infection. Rather of keeping for fear of COVID-19, we should follow the preventive measures. Antenatal, delivery, and postnatal care may be the only opportunities women have to access contraception. So LARC such as PPIUCD are more effective and can reduce visit to healthcare facilities, can reduce the burden to healthcare facilities, enabling delivery of essential and time-sensitive non-COVID-19 health services during the COVID-19 outbreak is very, very essential. We cannot forget non-COVID issues of women's healthcare in this COVID-19 pandemic, and it is our responsibility to provide healthcare services to our women of India. Healthcare family planning methods should be promoted. Self-care family planning methods should be promoted and supplied. Women are avoiding health facilities because of fear of getting COVID-19. So the role of midwifery, role of community health workers, role of ASA workers, and role of telemedicine is important. Ability of someone to receive care at their places, at their home where they reside is essential in this pandemic. Telemedicine services can improve access, it removes fear of infection and can ease pressure on struggling healthcare systems. We need to provide 24/7 helpline number, online support system, designated domestic violence reporting centers and care shelters and legal aid to all those women who are suffering from gender-based violence. We need to start psychological support and care centers for women's mental health crisis and providing them safe and effective care to already affected women. The most importantly, the global infection rate of healthcare worker has reached a critical level. Consider all pregnant women, all women you come across as infected, take due precautions and continue care. Healthcare provider, healthcare workers must be provided with adequate PPE kits, with adequate testing, with adequate quality care if they are suffering, and government need to assure admission, all the facilities, service, healthcare, quality care, health services, and insurance to all the healthcare provider and healthcare worker. WHO recognizing the need to include women in decision making for outbreak preparedness and response for COVID-19. And once American past President Barack Obama declared that we did not come to fear the future, we came here to shape it. And this is very, very true to healthcare system in this COVID-19 pandemic. We cannot fear our women and our staff members for getting COVID-19 infection, but we need to take all preventive precautions. We need to counsel, we need to do a lot of advocacy, we need to do mass education program to spread awareness about the vaccination, to spread awareness about the preventive measures like following social distance, wearing mask, and frequent hand washing. By failing to prepare, you are preparing to fail, and this is the time for healthcare system, Government of India, and for all the organization from private practitioner to public practitioner. This is the time to prepare the healthcare system. We need a lot of changes in our healthcare system. A big section of society in our country is still unreached and underprivileged, deprived of benefits of healthcare system. And being a professional organization, being a women's healthcare taker, we being a policy maker, being a frontline worker, healthcare worker, healthcare provider, and being the largest organization of medical specialty, and also government of state governments and government of India, it is the responsibility, joint responsibility of all of us, Fogsi, IMA, all NNA, Pediatric Association, Neonatology Forum, all medical organization. We all should work with state government of India as one unit, and it is our joint responsibility to provide the benefits of healthcare system to the deprived, unreached, and unprivileged deprived women and citizens of India. In this COVID-19 time, I know at least 12 of our Foxy members who lost their lives while serving to mankind. There may be many more who I may not be knowing, but it's a big number, and it's a painful that Foxy pays tribute to those who sacrificed their lives while serving the mankind. We pray for all those friends who have lost their COVID lives, and we also pray for their family members. We pray for all those who have COVID-19 infection and are on treatment. We pray for their speedy recovery and complete recovery. As per IMA has declared the data in the first wave, more than 800 doctors died, and in the second wave, more than 350 doctors died. So even after, if you have not taken vaccine, please take both the vaccine, 2 doses of the vaccine. If you have already taken vaccine, then also please follow the all the preventive measures, because even after vaccines, infection can occur. Of course, severity can be less, but we need to take precaution, and we all should have to follow the preventive measures. Let us work together for women's healthcare during and after COVID-19 pandemic, to tribute to all frontline workers, Corona warriors who sacrificed their lives while serving mankind. A big salute to all the Corona warriors. Once again, I am thankful to organizers for giving me this opportunity, and I am thankful to all of you for your patient hearing. And I salute all of you. You all are Corona warrior, and you all are doing great work. You all are doing good. You all are continuing good essential and healthcare, essential maternity, contraceptive, abortion services at your level, and you all are doing good social work at your level and at Foxy level. So I would also like to take this opportunity to thank all of you. You all are Corona warriors, and Foxy salute. Thank you very much.
Wow, sir, that was an excellent oration that you just delivered, sir. This year together has been a very important word, because you have taken us together through your this presidential year, and we have all gone together to the heights that Foxy has reached because of your leadership. Now I request Narendra Gajjar sir to kindly give the concluding remarks for the talk.
Thank you, Dr. Alpesh Gandhi, President Foxy, our dynamic president, I would call, for delivering a wonderful oration on women health crisis in this COVID-19 pandemic. We are very proud to announce that Foxy is the first professional agency to start registry for COVID-19, and that is under your able leadership. And sir, because of that, we are able to study and we are able to find out strategies to control this COVID-19 pandemic. We have learned from you that though number of men suffering from COVID-19 is more, but fatality rate in women is certainly higher, and that is a point of concern for us. COVID-19 affects various aspects of woman health care, and it exposes a woman to a higher risk of death. There is an increased incidence of maternal mortality that is 7 to 8 times higher in comparison to a pregnant woman who is not having a COVID-19 infection. And it is disheartening to know that there are many unreported maternal deaths also. ICU admission rate has increased, and we have seen its effects on the healthcare services. 1% of the patients are critically ill. And the second wave, as you already said, that it carries a higher maternal mortality even in comparison to first wave. SB rate has increased. One of the most important point of concern for us that it has affected the family planning and about MTP services, and that has many, many adverse effects. It has not only increased the incidence of preterm and cesarean section, sir, as you have nicely narrated, that cesarean section has increased to 20% in comparison to former incidence of 10%, 60%, and preterm rate is 20%. SB rate has increased 3 times, and that may be the reason because fewer antenatal visits. Vertical transmission rate, for which we are all concerned whether during neonatal period or whether intrauterine, but it is 5.7%. And because of other factors, there is an increase in the NICU admission rate. It has not only affected obstetric services, but it has affected our gynec surgeries, and we have to stop all gynecological services. Not only from OB and GY field, you have very nicely studied the social aspects, economical aspects, even gender-based violence has increased, domestic violence has increased, mental health crises has increased, postpartum psychosis has increased, and we are very proud to announce that you have helped the government of India by various recommendations, especially your statements for vaccination in pregnancy and lactation. And this has been very well recognized by policymakers, by authorities, by media. And that is the reason Fogsi has come up into the life of an average person. Even people are asking me that can I take vaccine during lactation? So that is the role of Fogsi. Instead of reaching to members, it has reached to even a common person. Your recommendations are very nice. You have covered precautions, quality care, insurance. Unreached and underprivileged people also have gained benefits. It is disheartening to note that our 12 Fogsi members have died. More than 1,200 doctors have died. And in spite of vaccination, you have very nicely recommended all precautions need to be taken. Thank you, sir. Thank you very much. And on behalf of Navsari Gynec Society, it's a proud privilege for us to present this small memento to you, sir. Please accept on behalf of us.
With great pleasure, I accept it, and thank you very much for this honor. Thank you very much for giving me this opportunity. You gave me a platform where I can share my feelings. I can share the data of our registry. I can share what is going to our women's across in India and across the world. Thank you very much for patient hearing. Thank you very much, all of you.
Thank you, sir.
Thank you, sir.
Thank you, Alpesh sir. I must at this platform say this proudly that there are a few friends of ours, international friends, who even ask us about the Fogsi registry because it has come out so well, and there are so many cases that has been included in it. So that's definitely a proud moment for us Fogsians, as Dr. Narendra sir has already mentioned. So thank you, sir, for the
Dr. Priyankur and Dr. Vipul Bhai and Narendra and Satyan, there is one more fact came out that now the incidence of institutional delivery is decreasing, and some of the women are lost. We do not know where they have delivered, not delivered, where they have delivered, and particularly there are few states Uttar Pradesh and Bihar, where lots of pregnant women are lost. We do not know where they have delivered. Number of institutional delivery is also decreasing in many states, and in some of the states, home delivery rate is also increased.
Yes, sir. This telemedicine and even fear not only from the side of the patients, but also from the side of the doctors, because to take care of a COVID-19 patient during pregnancy is really, it requires a hard work. And some of the patient might be afraid of getting infection from hospitals. And that might be a reason for increase in the maternal mortality. I definitely agree with you.
Absolutely, sir. So I think it's an honor to present the certificate to sir. So Satyan sir, would you read out the certificate, please?
It's based on Yuva Fogsi, hosted by Navsari Australian Gynec Society under the aegis of Fogsi. And the certificate of appreciation is presented to Dr. Alpesh Gandhi for prestigious presidential oration on women's health crisis in COVID-19 pandemic, 30th May 2021. And thank you very much, sir, for this.
Thank
Sir,
you for
please
this
accept
very,
it.
Thank you very much for this certificate.
Thank you, Alpesh sir, for the presidential oration. I would also like to thank Dr. Narendra Gajjar sir, Dr. Vipul Kapadia sir, and Dr. Satyan Kasabala sir for chairing the session. Thank you so much.
Thank you. Thank you.
Thank you, Priyanka.
Thank you, sir. So we come to the end of this plenary session of the presidential oration. Now I request that we'll have two different halls now, Hall A and Hall B. So the participants of Hall A can continue staying here, and the Hall B participants requesting you to kindly log in back to the Hall B. So thank you so much. So in this Hall A, next we have a wonderful panel discussion on recurrent pregnancy loss. This panel will be moderated by Dr. Parikshit Tank. Parikshit Tank sir is currently the joint treasurer of Fogsi. He is going to take over as a treasurer of Fogsi in the next 1 month, and he has also been instrumental in the GCPR, which on the advocacy that Fogsi has presented to the government of India regarding vaccination of COVID-19. So welcome, sir. With him to chair this, to moderate this panel, we have Dr. Munjal Kapadia sir. He is the director of the Ramaben Hospital in Navsari and also the director of the Namaha Healthcare in Mumbai. He has undergone his ultrasound training from Dr. Suresh in Chennai, IVF training from USA, fellowship in advanced endoscopic surgery from Germany, as well as the university diploma in advanced endoscopy from France. So it's a pleasure to have Munjal sir with us today. I would request now Dr. Parikshit sir and Munjal sir to kindly take over the panel discussion with our esteemed panelists now. Thank you.
Thank you so much, Priyankur. Very kind words from you. And I'll just start sharing my screen. I hope it's visible to everyone.
Yes, sir, it's visible, sir. It's visible.
Right.
Please
I'm
go on.
going to full screen, and so we are going to talk about the current perspectives in recurrent pregnancy loss. And I'm so happy to have Munjal with me, an old friend. And we have this array of panelists today who have joined us to shed some light on an otherwise difficult topic. So we've got Dr. Meenu Agarwal, Dr. Yogini Rolekar, Dr. Yuvraj Jadeja, Shaili Agarwal, Kajal Mangukia, Aditi Natkarni, and Vinita Avasthi. I welcome all the panelists. And before we start, my sincere thanks to the office bearers of Fogsi, President Dr. Alpesh Gandhi. What a wonderful oration. The Secretary General, Dr. Jaideep Tank, and the team of West Zone Yuva Fogsi, especially Dr. Vipul Kapadia, Dr. Narendra Gajjar, and Satyan Kasabwala for the kind invitation to be with all of you today. So Munjal, if you want to kick things off, and let's get into the topic really.
Very good afternoon to everyone. And so let me be very honest, I was very relieved when I heard that I had to moderate the panel with you. For everybody else who has logged on, they also know that once you have Dr. Parikshit Tank with you, all your effort goes out of the window because it has been done for you already. My only job today has been to show up and let me thank Navsari House Gynec Society. Let me thank Fogsi, especially Dr. Alpesh Gandhi. So what a wonderful oration. It was excellent to hear and refresh all the data on COVID in pregnancy. And I would like to thank Fogsi personally for advocating vaccination for lactating and pregnant mothers on such a large scale. It felt for the first time that there is somebody standing up for this nearly 25 million vulnerable population, and hats off to Dr. Gandhi for that. Welcome all the panelists today.
Munjal, can I say 1 minute? Can I take a 1 minute?
Of course, sir.
Thanks to Fogsi team, there are so many who all have worked for this position statement. So of course, thank you for appreciating me, but there are Dr. Pariksit, Dr. Atul Ganatra, all the Fogsi office bearers, and at every stage we require a teamwork. Some have helped us in preparing the document, some has helped us in representation level, some has helped us in pushing the advocacy statement. So it's a big teamwork, and because of the efforts of all of us, this became possible. Thank you.
Dr. Pariksit, if I'll start off with the first few questions and then I'll hand it over to you. Let's start off with how recurrent pregnancy loss should be defined. If we can start off with Dr. Aditi, if you can start off there.
Hello, everybody. Good morning. So, recurrent pregnancy loss can be defined as pregnancy losses, more than 3 consecutive pregnancy losses, maybe less than 20 weeks of gestation or less than 24 weeks of gestation in a couple who is wanting to have a baby, have a pregnancy.
Dr. Kajal, would you agree with that definition? Would you when would you start initiating investigations for a patient who has come with pregnancy losses?
Yeah. So good afternoon, everyone. First of all, we have 2 guidelines basically. The RCOG guideline 2011, which shows that 3 or more consecutive pregnancy losses. But in practice, we generally start with 2 or more such pregnancy losses. And that is as per the American Society of Reproductive Medicine 2008, they have given the guidelines. And in practice, sometimes such scenario happens when the maternal age is more. Then we cannot wait for 2 or more recurrent pregnancy loss to occur. So we may have to, start the investigation earlier. Or if there is a case of infertility or poor ovarian reserve, then these are the cases we may need to start investigating this couple earlier.
Okay. Dr. Vanita, would it help in classifying patients into primary or secondary recurrent pregnancy losses, or whether for diagnostic purposes or even for prognostic value? Could you even briefly tell us what each is?
What is the primary RPL is that the patient has never had a live birth. And in the secondary, she has 1 or 2 live births, and after that or before that, she has a history of recurrent pregnancy losses. So there are certain causes which are repeated. So once a patient had a live birth, we can say it is a good prognosis for the further one. But if she has a recurrent, if she had a primary recurrent pregnancy loss case, she may have more problems either with the chromosomal abnormality or something like in the genetic material, or here the age of the patient is also important. So some acquired conditions are also important in the secondary RPL. So we have to rule out, we have to classify the patient in secondary as well as in the primary RPL cases for the diagnostic and for the prognostic, both purposes.
So if you want to take it from here.
Right. So as I mean, as we've seen, there is a difference in opinion right from the level of how do we define recurrent pregnancy loss. So I'm sure that we are going to have a lot of entertainment on this panel with plenty of disagreements and differences in opinion. And yes, Aditi stuck to the classic definition, but I think thresholds are changing over time and over the way expectations are. So yes, there is a case for redefining or re-looking at how recurrent pregnancy loss needs to be seen as a clinical entity. Now let's go to the standard evaluation, and this is for a couple who otherwise doesn't have anything else going in particular. So we all know that looking for clinical picture and keeping it, in the background is essential for every sort of gynecological and obstetric problem. So my question to Dr. Meenu Agarwal is, are there any specific clinical aspects that we need to look for? Any red flags, any highlights?
See, couple of things. One is, I think, a detailed, good history taking, whether the pregnancy loss is in the first trimester or in the second trimester, and whether the pregnancy loss is before the fetal heart cardiac activity or after the cardiac activity. So all these three would probably have different outcome or different way of analyzing the patient. So I will divide it into these three groups clinically, and then of course go ahead with the investigations.
Right. I think that's a very important clinical pointer. In addition to all our routine history taking, etc., these are the important things which we need to bear in mind when we go ahead with the further investigations. I'm not sure whether Dr. Rolekar is with us or not. Is she there?
No, sir. No, sir. No, sir.
No. Okay. So
she messaged early today that she won't be able to
right. Right. So can I ask Dr. Shaili Agarwal the next question? And
Yes,
that is, what major groups of etiologies or reasons are we really interested in investigating this couple for?
Good morning, sir. So basically, they are the etiology groups. One is the uterine anomalies. Another is the antiphospholipid antibody syndrome. Then there are hormonal factors like hypothyroidism or hyperprolactinemia. Then there can be metabolic disorders like diabetes, mellitus, or anything else. And then cytogenetic abnormality, which has a major chunk in this RPL. And then also we have some controversial etiologies like chronic endometritis, like inherited thrombophilias, neutral phase insufficiencies, and also recently we have seen the articles on high sperm DNA fragmentations. So there are a majority of etiologies. Some are established and some are still in the controversial phase. So
Right.
these are mainly the group we can classify.
Correct. So, Dr. Jadeja, this one is the standard evaluation, and we know that a lot has changed over, the last 15, 20 years when we look at etiologies. Do you think that certain etiologies have now kind of become discarded? I mean, they are almost obsolete when it comes to, being putative factors for recurrent pregnancy loss. What's your opinion on this? Are there some tests which you strongly feel that clinicians should stop doing, even though it's routine practice?
Yes, sir. Very honestly, sir, completely negated would be difficult to say, but yeah, I think there are a lot of tests that have come under a lot of surveillance and question. And I think, especially for someone like me who, was studying a few years back, I think torch infection panel was something that was very routine in terms of how we used to prescribe for investigate recurrent pregnancy loss. Torch has been something that I think a lot of us have routinely stopped doing until and unless we are strongly suspecting an infective etiology. Also, I think we are much more careful in diagnosing and specifically testing thrombophilias also. Like just a simple, when I used to study, there was just an antiphospholipid antibody test, but now we know that, just a plain, simple 1 or 2 tests for thrombophilia or just routinely prescribing that entire array of thrombophilia panel is not something that is recommended anymore. I think these are the two important. Second, third, also somewhere karyotyping in terms of only karyotyping was being done. Numerical testing for POCs and also for parental mutations is something that we've changed. We've kind of stopped doing it blanketly in terms of only FISH. We're thinking more of NGS and microarrays. So there have been a few changes like this.
I think that was very nicely put, Dr. Jadeja, and it gave a good capsule into what not to do, because we know that there's no point wasting time and money behind certain tests. So if we look at the etiology of recurrent pregnancy loss very broadly, we've got possible and we've got doubtful. So, the ones which are possible, well-established, genetic, anatomical, autoimmune, and hormonal, and a lot of it goes into the doubtful basket, and that is alloimmune, subclinical thyroid abnormalities, glucose intolerance, infections, environmental factors, and I mean, it could be a list from A to Z, which you could really put into this bucket. And of course, as Dr. Jadeja said, there are some things which probably should be struck off the list, including torch infections, subclinical hypothyroidism, and abnormal glucose tolerance. I don't mean to say that these aren't important. They aren't important from the point of view of investigating etiology. They have their own place. They have their own place in terms of maybe investigating fertility issues, in terms of investigating lifestyle issues. Yes, they have their place, but otherwise they don't. So, Munjal, would you like to go ahead with the fetal chromosomal abnormalities?
Sure. I think back to Dr. Aditi. Aditi, do you usually advise a karyotype on products of conception?
Yes, actually, I usually advise the karyotype if she has had recurrent pregnancy losses, like more than 2 or 3. So basically, if the patient is also keen to know, usually the question from the patients is, why did it happen? So if there are no important, all the investigations have been done and there is no per se any reason for it to happen. So we could as well advise a karyotype of the products of conception. It might give maybe a prognostic information for the patient regarding the subsequent pregnancy losses. So yes, but not in all patients. In few patients who are really very apprehensive to know why did it happen.
Other than, say, closure for the patient, or other than patient insisting on a genetic test, Dr. Kajal, do you think that there is any drawbacks of doing karyotype on products of conception, say after a DNA procedure?
According to me, if there is a history, 2 or 3 missed abortion is there, then only I would prefer to go for the karyotyping of the POCs. And if patient is asking, because nowadays patients are all techno saver and Google, they read and come, and they do say that, ma'am, we want to go for the karyotyping of POCs, then I would prefer if the maternal age is also high. So there is no harm in doing karyotyping.
Okay. Anybody else on the panel? Say, Dr. Shaili, would you?
Can I say something here?
Yes, please. Yes.
See, if you are doing the POC karyotyping, it is better to do a microarray, because then you can check on the unbalanced translocation, which is not viable with life. If it is a balanced translocation and the couple also has, so it will not help us, because they are living, they are nice, so the baby could also have been okay. I mean, it can go to full term. So I think I would 2 things. One is to do microarray, and second is to tell the lab to preserve the sample for the future pregnancies. So these 2 things I would do in these cases.
Okay. Munjal, I would like to say something on this.
Yeah.
Actually, I was when I was studying for this RPL, I have gone through a very wonderful article, and it has a very clear, very beautiful guidelines. It said if the products of conceptions are available and you have the facility of microarray, as the Meenu Agarwal ma'am has said, and the CGH, there's a comparative genomic hybridizations, then if the POC is available for karyotyping and it is euploid, then you should go for the complete workup for RPL, like all the array of hormones and all these works. But if the POC has an unbalanced translocation in the fetus, it means you have to go for the parental karyotyping, because they might carry the balanced translocation in them. And these are the couples which can be offered IVF and PGT in later pregnancies. And if the POC karyotype is aneuploid, then it is the cause is already explained and there's no need to go for the further workup. So this was the summary which was given that. I found it very useful.
Munjal, coming back to your question, I think the important thing about DNA and products of conception karyotyping, the biggest drawback is maternal contamination or any form of contamination. Yeah. And that is one reason why somewhere we have discouraged doing fetal karyotypes per se after DNA. And the second, of course, very common reason is if you find an aneuploidy or some form of
that is important.
yeah, and sometimes we tend to stop our investigation when we already know that aneuploidies are the least recurrent cause of pregnancy loss. So I think contamination and
also contamination and no growth, especially aneuploid embryos would not grow in culture. So that is the time where you would actually miss out on a genetic problem.
And I also want to add something. It may happen this is the only single event. It may not present in the next pregnancy, so it will not give you the prognosis. इस बार अगर problem है तो अगली बार रहेगी, कोई जरूरी नहीं है ऐसा.
Yeah, if it is aneuploid or if it is Turner's, so these these are random. So in fact, they have a good prognosis next time.
Yes.
Actually speaking, yes.
Okay, great. So you can take the next one.
Okay, so I mean, just carrying on from the whole concept of genetic and chromosomal testing, it's natural and it's quite human to take it to the next level. Then once we find something, then we want to know whether there's something wrong with the genetic or chromosomal component of the sperms and the eggs. So my question to Dr. Jadeja is that since you mentioned about genetic arrays, anything that you would offer in terms of testing sperms, eggs, etc.?
Honestly, sir, I wouldn't offer. But if you're talking about what can be done, of course, we know that there are sperm aneuploidy tests for sperms per se. But I think all of us know that it doesn't make sense because once you diagnose an aneuploid sperm or a euploid sperm, that is not something you're going to use. So you never know when you're going to do your actual, and also that warrants an ART. Where eggs is concerned, again, it's a polar body test that biopsy that you can do, which is, I think, a little bit far-fetched right now for us to probably routinely prescribe to patients.
I think that's a very balanced kind of an answer. So, I mean, if we look at karyotype, I think these have been spoken about, these points, and it's important to understand that we need to put it into perspective where we are also thinking about next generation, or I think now we should say current generation testing of the products of conception. And then that could lead to some further tests. I mean, at the moment, the problem is we don't know what to do with these tests. Even if we know the results, we don't know what to do with these tests. So as they say, if a problem has no solution, it may not be a problem. It may be a fact which can't be solved, and we have to just cope with that fact. So moving on from something which doesn't really have that much of intervention possible, let's go to something which has some key messages what we can give, and that is the autoimmune etiology. So my question to Dr. Agarwal is, how do you usually evaluate autoimmune factors in a scenario of recurrent pregnancy loss? What are your first line tests?
Okay. Please, ma'am, go ahead.
I'm so sorry. I meant Meenu, but then I'll come to you, Shelly.
Okay. All right. So for autoimmune etiology, I would do the EPLA test, the anticardiolipin antibodies, along with LA, lupus anticoagulant. And as per RCOG guidelines, even if it comes positive, you got to repeat it after 12 weeks again. So you have to do it 2 times, and both the times it is positive, then you label the patient as EPLA positive.
Okay. Now coming to Dr. Shaili Agarwal, what are the common pitfalls? I mean, there are these tests. One of the pitfalls, Dr. Meenu did mention that, you can't just rely on one test report. You need to do it again after 12 weeks. Anything else which you see?
And the cost, sir, because in India, we are doing it in a government setup. I am an associate professor in the government medical college. So the cost is very a constant factor for these tests. Once the patient can do, but again, after 12 weeks, it is not possible for them. And another thing is that there are no standardized assays for the laboratories to confirm the findings. And third is, it may be some false positive in case of viral infections or some other diseases. So these are the pitfalls in these tests, sir.
Thank you. Aditi, next question is to you. Nowadays there are these fairly comprehensive profiles called thrombophilia profiles or autoimmune profiles, RPL profiles, so on and so forth. Have you any experience with testing for protein C and protein S levels, their deficiencies in our populations?
Sir, actually, yes. Means we usually don't advise these hi-fi levels, means protein C and protein S. Usually, they are deficiencies which lead to these hereditary thrombophilias. So, if the patient has had any history of such things like maybe hereditary, which has a hereditary component, then yes, we may advise protein C and protein S deficiency levels for such patients, because they cost a bomb for the patient, and in rural areas it is a little bit of a difficult thing for the patient to pay for such hi-fi tests. So I think till APLA, LA, ACA, usually they suffice for such patients if at all they have such tests coming positive. And yes, if there is any hereditary component, then we could as well give this option to the patient.
Right. So I think there should be like a two-step kind of a testing, and we should keep these rather more expensive and uncommon tests in the background when we are looking for autoimmune etiologies. That's evidence-based as well. Sometimes what happens, Dr. Mangukia, is that a woman may come to you when she's say 6-7 weeks pregnant, and she's had this history of 3-4 miscarriages. So do you think it's valid to do tests for an autoimmune etiology when the woman is pregnant, even if she's like in an early pregnancy or something, or there's just no point and you might as well get on with whatever empiric treatment you want to give?
You're on mute, madam.
Hello.
Yes, we can hear you.
Yes, sir. We can go for the investigation for the autoimmune etiology, even though she is pregnant 6 to 7 weeks.
Okay.
And if the report comes positive, then we may start with the tablet ecospirin 75 to 150 milligram, and we can give the low molecular weight heparin also in these patients.
Right. So that's an interesting perspective. I mean, yes, the test would strengthen your position in prescribing certain type of treatments, but we also know that, the changes in the pregnancy physiology might affect the test performance. So there are, things which could cut both ways. Dr. Avasti, if a woman has proven PAPS, she's proven primary antiphospholipid syndrome, what's your modality of choice in treating her when she's pregnant? Dr. Vinita Avasti?
I don't think she's there.
I think she got disconnected by some chance. So let me come to Dr. Jadeja then.
So I think we have only two options, which is aspirin and heparin. We're all very comfortable with low molecular weight heparin, so to speak, if in case that's something we want to use. So I think these are the two modalities that we would want to use it. How long, and all that is something that, of course, we can decide postpartum, how long to continue and all. Of course, if it's a proven case of any form of thrombophilia, you can switch over to an oral post second trimester, which nowadays a lot of us do. But yeah, heparin and anticoagulants and aspirin is something that.
So I think, most of the panelists might agree that, you probably start off with aspirin, low dose, usually 75 milligrams, but nowadays the trends are towards using 150 milligrams. As soon as the urine test is positive, and then once, the fetal heart is demonstrated on ultrasound, then you could probably add heparin, either low molecular weight or unfractionated, depending on the circumstances. So are we all agreed on that, or
even Ishri is recommending use of ecospirin even in the pre-conception period.
Yeah,
So this is the latest guideline. Yes, it is saying you have to start it in the preconception period itself. And once the UPT is positive, you take the patient on the heparin therapeutic dose. If it is
So
positive.
that's another way of doing it. There's difference of opinion over there in terms of the guidelines as well. So just to run through quickly the pitfalls and the diagnosis we spoke about. There's a problem with standardization, variations, false results, and we need 2 reports at least. And one thing again, which I would like to emphasize is that now steroid therapy is out, and we've all been hearing so many bad things about steroids that we are probably not going to use them empirically for a long, long time. So when we are solving problems, let's dig at the roots instead of just hacking at the leaves. And one of the very common issues that may be faced in women with recurrent pregnancy loss are abnormalities of the uterine structure. So Munjal, if you could please take up this one.
Sure. Dr. Meenu Agarwal, if you could tell us what is your modality of choice for evaluation of the uterine cavity?
See, I think it is ultrasound. So you can, for the delegates, if you have a 2D ultrasound, you can do a simple 2D ultrasound, and also maybe HSG also is a good modality to give you an idea about the uterine cavity. Other options, if you have, is of course a 3D ultrasound or an office hysteroscopy. If you feel okay, you're dealing with the septum, or actually in the latest guidelines, even a septum is put to a question mark whether treating a septum helps in the recurrent pregnancy loss of the second trimester. So that should also be kept in mind before telling the patient that we have done it and now nothing is going to go wrong with you. So yeah, I would say 2D ultrasound and maybe 3D ultrasound. MRI does not, as of now, it does not show much advantage over a 3D ultrasound.
Are there any common problems, madam, that you find with HSG evaluations?
Yeah, because HSG, are you asking me, right, Munjal?
Sure.
Okay.
The next question, Dr. Shaili Agarwal can answer this. Madam?
Ma'am, answer दे रहे हैं?
नहीं, आप दे दीजिए आप.
Okay, HSC is basically a slightly cumbersome procedure for the patient itself. So the 3D ultrasound, as ma'am has said, TVS 3D ultrasound has a sensitivity specificity is comparable with the HSC, even more than that. So 3D USG is the choice, right choice for investigation, the cavity. And then we can do the sonosalpingography if we want to evaluate the cavity like polyp or some fibroids or mucous fibroids. And also we can do the tubal pedicity test also in this thing.
Dr. Yuvraj, what are we? Yeah, go on. Sorry, man.
MRI, and when we are suspecting some Mullerian agenesis, then we can go for the MRI to evaluate the kidney and other abnormalities. So just
Dr. Yuvraj, what? Yeah. Whether we do an HSG or a 3D ultrasound or a sonohysterography, Dr. Jadeja, what are we looking for? When a patient comes with RPL, what actually crosses your mind? What do you want to rule out?
Mujal, I'll differ. For me, a patient of RPL, I think my modality of choice is always endoscopy. Because, we might have the best of ultrasound, but I don't want to miss a small polyp or a synetia or anything, which is, I think we are all bound to make some error at some time. So I wouldn't want to miss that, especially when someone has had 2 or 3 abortions previously. So my first choice would be... Yeah.
Even I would also go with Yuvraj. I would also prefer a diagnostic hysteroscopy and evaluate the cavity, because it is important for the future pregnancy of the patient, to plan her pregnancy basically.
I think we should prefer diagnostic like laparoscopy and hysteroscopy both together. That is the gold standard.
Yes, I think Dr. Jadeja meant complete endoscopic evaluation.
Yeah.
Go on.
And what we are looking for is, anything and everything. From a uterine anomaly, which could range from a septum to a biconjugate uterus, for a matter of fact, even the controversial severely arcuate uterus or a small polyp, Asherman's, synetias, everything.
Yeah. One of the main advantages, I think, of counseling a patient for an endoscopic evaluation is that you have a see and treat approach. That if you do actually see a small septum, you can excise it at the same time. If there is a small polyp, you can do a polypectomy at the same time. If there's a small band of adhesion, maybe due to a past curettage procedure, you can excise it at the same time. Sonosalpingography and 3D ultrasound have are very, very accurate tools. Of course, it requires a certain amount of training and practice. We saw a wonderful presentation, I think, a couple of days ago on this very conference by a very senior sonologist in Ahmedabad. Fantastic results, almost probably as good as hysteroscopy. But very important thing to remember is that there is no therapeutic benefit that you can give during these procedures. So, going on, yes, Dr. Meenu.
Please go ahead. Please go ahead.
What could be the possible reasons for a patient to have a T-shaped uterus? Yes, Dr. Meenu Agarwal.
Okay. See, earlier we used to say if the mother has taken diethyl during her stilbestrol in her pregnancy, the daughter may have a T-shaped uterus. But other than that, now I don't know of any other reason why a patient would have a T-shaped uterus. Yeah. But we do see it. I don't know the reason for this, to be very honest.
Okay. Anybody else wants to chime in? Dr. Shaili?
As Ma'am said, DES exposure we are reading for since our PG days, and it can be congenital also sometimes. Any other reason we don't know.
Okay. Dr. Aditi, after doing a hysteroscopic procedure and you've seen that a patient has a T-shaped uterus, you've done a lateral metroplasty, you've widened the cavity. Are there any measures that you take post-operatively to ensure adhesion prevention?
We post hysteroscopy, we usually give her a course of estradiol valerate, 2 milligrams thrice in a day for at least 15 days, and then we call her back after a week and we check for her endometrium on ultrasound. So that is one of the things which we usually do.
We can also keep the pediatric Foley's catheter 6 number, just cut the tip and push the catheter inside and just place about 2 to 3 ml of normal saline, keep it for 6 to 8 hours and then take it out. So
yes,
that is one of a good.
Yes, that is also one.
The intrauterine devices also, property also we can put.
Any without. Yeah.
Right. So I think
going on, sir.
These are the important take-home messages as far as uterine anomalies are concerned, and they are pretty common in women who suffer from recurrent pregnancy loss. The important anomalies that we are looking at is really the septate or the subseptate uterus, and they can be very successfully managed by hysteroscopic surgeries. I think the first question in the list about infections has already been answered, and I won't belabor the point with that. But tying in with that T-shaped etiology, does anyone think that tuberculosis might play a role in the etiology of RPL? Because that's one of the investigations that people do tend to send, an endometrial biopsy for various tuberculosis related tests. That's a pretty common investigation that has been seen in clinical practice. One might not necessarily do it, but one has to deal with the reports. So Aditi, do you usually investigate this way, or do you strictly look for what anatomical problems tuberculosis might have caused?
So usually we, after hysteroscopy, we usually send a test for Cox investigations. So basically, as we all know, this genital Cox is quite common in our country. Usually affects around 20-25%. So it usually we have to find out whether she is having any genital infestation in the endometrium, because it may cause harmful release or harmful cytokines in the distia, which might affect her implantation in the future. So yes, usually we do send an investigation to find out whether she has any any tubercular infestation in there.
Right.
May I add something?
Yes.
So actually, because of the tubercular infection, endometrial thickness is very much affected. Thin endometrium is maybe one of the important cause of early pregnancy loss, especially in the chemical form.
Yeah.
And even ectopic pregnancies are also very common due to the distortion of the tubes and shapes.
Sure.
So tubercular infection one must have to rule out. And
I think that ties in nicely with what. Yeah, I was just coming to that, Meenu, that it ties in nicely with what you said right at the beginning. What's the clinical picture? I mean, was it a pre-embryonic loss? Was it an embryonic loss?
Yes,
was it a fetal loss?
Yes.
So on and so forth. And infections really probably play a very, very small role. The torch doesn't show any light, and we've all been taught this in medical college, that if you don't know what you're looking for, look for tuberculosis. So yes, I mean, there is a problem. I mean, with RPL and tuberculosis, you've got anatomical distortion. Well, yes, okay, then that might be a possible mechanism. Histological, not so common, but maybe. But when we are doing molecular tests like an RT-PCR, and if you get a positive result, does that necessarily mean as an association with miscarriage? I think that's where the things aren't so linear in terms of the causation. So
the very important thing also, once the tubercular infection has become, it has created the permanent loss. So even if you treat
loss of the
even if you treat the tuberculosis, the patient will not get the advantage of that in terms of pregnancy.
So we've got to be careful with whom we are prescribing the anti-tuberculosis therapies to. So the only probably clinically relevant infections are bacterial vaginosis for second trimester losses. And even there, probably there's no benefit from routine screening and treatment. And as they say, an undefined problem like RPL has an infinite number of solutions. So coming to the last part of today's panel, we must touch upon empiricism, because that's what we really rely on every day in clinical practice. And a very, very honest and transparent opinion from the panelists. What are your favorites? Dr. Meenu Agarwal, a woman, comes to, typically clean history, clean investigations. What empiric treatments do you do before and during pregnancy?
Before I talk about the empirical treatment, I think all of us will agree that even if we don't do anything, 70-75% chances that this woman will have a good outcome of this pregnancy. Having said that, yes, I would definitely start with low dose ecosprin. That I would do if she has a previous history of recurrent pregnancy losses. Maybe low molecular weight heparin, maybe not. So yes, aspirin I would start.
Okay.
I will start with the progesterone.
I'm going to ask the same question to the other Dr. Agarwal, Dr. Shaili. What is your opinion? What's your favorite cocktail? And I mean for RPL women.
Yes, sir, yes, sir. First is the counseling. So TLC, tender loving care. It is the utmost important, because when we counsel the patient that it is 1 or 2 episodes, it's not necessary कि अगली बार होगा ही होगा. तो ये positive feedback जो हम डालते हैं patient के उसमें, it works wonder. And then
very true.
Yes, sir. And I personally start defosteron, that is dydrogesterone, because of its immunomodulatory properties. And we have seen the evidence in our practice. And ecosprin, if she is not APLA positive by test, then I will start it after the pregnancy test is positive.
Okay.
And so heparin, I do not use empirically. I use only when the patient is coming with the history of APLA positive tests.
Okay, let me ask Dr. Jadeja and Mangukia if they have anything different up their sleeves, besides aspirin, heparin, dydrogesterone, or natural micronized progesterone. Anything else you guys
or tender loving care.
Or tender
loving. Folic acid, the most
folic
important.
Acid, of course. I mean, that's universal, right? Yeah. Good, but good point. Yeah.
Sir, I want to add something.
She is not immune to the rubella, then rubella vaccination.
Fine, fair.
Sir, I
think,
want to add
now we are getting
something.
into the broader preconception care, so to speak. So all those points are very important. I agree with you completely. Vinita, one question to you.
Yes,
Do
sir.
you advise bed rest in
No, sir. No, sir. I do not advise bed rest, but I advise the mental peace. And for both the partner lifestyle modification, proper nutrition, and avoid any substance use. The nicotine use in the male partner is very important cause of the RPL. So I used to advise both the partners because दोनों को बच्चा चाहिए, तो both of you have to do the sacrifice. Both of you have to modify your lifestyle. You have to do some exercise, yoga. You have to add some nutrition in your diet. Avoid fast foods. Avoid substance misuses, and no bed rest. Although I advise कि avoid some heavy physical activity, but no absolute bed rest. And I advise patient to keep yourself calm and cool. That's all.
That's probably the hardest part to do, isn't it? Aditi, let me end with you. And this question is that, couples sometimes come at the end of their tether. And is there a role for third-party reproduction when we are looking after these couples?
Yes, sir. And some couples who have really, really tired of getting, the lady especially, she's really tired of getting pregnant, and again she's had a mishap. In such patients, yes, if the patient is consenting for a third party reproduction, and if there is a proven gamete disorganization, means if the gametes are really faulty, then yes, I would definitely advise a third party reproduction, either a sperm donation or a egg donation. And if she's rich enough, then yes, surrogacy also.
Okay, and I think let's just put in adoption here as well, because those are all the broad options by which a couple could complete their family. So I think we all use some form of empiricisms or the other, and which probably makes sense because you've got to give something at the end of the day, and the ones which we mentioned, they do have some evidence of benefit somewhere or the other down the line. So I think with that we come to the PROMISE trial, which is the latest in terms of evidence. Well, vaginal progesterone doesn't seem to have much of benefit, but we don't know for sure about dydrogesterone. It's a possibility, not that one can advocate it with the full weight of evidence. Empiric therapies like heparin, these are some places where we need to be careful because these drugs do have some downsides. So don't use it absolutely without any clinical or biochemical or lab basis, though there are some studies which will always say that it's useful. So the great tragedy of science is the slaying of a beautiful hypothesis by an ugly fact. And sometimes we run into so many hard facts when we are managing recurrent pregnancy loss that it's quite easy to feel a bit disheartened. But we've got to keep going. We've got to give the realities to the couple that 70% of couples are going to have a successful outcome. We need to maybe at some level motivate them to try again. And we need to understand that reality in science of RPL is also rare because there are multifactorial etiologies, there are lacunae in literature, which are very difficult to overcome in terms of sample size, etc. And with that, Munjal and I would like to thank all the panelists for a very, very hearty participation in today's panel. Thanks for shedding light on an otherwise not so easy topic. And Munjal, if you want to close with some last words.
No, first of all, thank you to all the panelists for being very, very active participants. Thank you to the organizing chairpersons, Dr. Vipul Kapadia, Dr. Narendra Gajjar, Dr. Satyan Kasabwala, and Dr. Vaibhav Kapadia, all of them for organizing a wonderful weekend. And sir, thank you, as always, for doing all the work for me and just ensuring that I have to show up.
Thank you so much, sir.
Thank you, sir.
Yeah, over 30 years of practice, I have had so many. Earlier we used to say toxoplasma is the culprit. So many robamycin babies. Now only to realize it was actually just 70% of them, they probably carried the pregnancy without my intervention into that. So all
now
of
we
you,
know that rowamycin is safe in pregnancy.
at least
Imagine what we learn in the next 30 years.
सर सबसे खराब तो टॉर्च के साथ हुआ.
Okay, over to Priyankur. I think we are, unless sir wants to say something.
And on behalf of all the panelists, we thank Dr. Parikshit and Dr. Munjal for such a wonderful and very interactive.
And very practical. कोई theory
Yes,
के
sir.
नहीं गए, बहुत practical points, sir. Thank you so much, sir.
Thank you, Parikshit
Thank
sir.
you.
Thank you, Munjal.
Can I come in for a
Thank you
minute,
very
Thank you,
Parikshit?
sir.
Thank you,
Can I come
Parikshit
in?
sir. Thank you, Munjal.
Sir, Dr. Kapadia, Dr. Vipul Kapadia wants to say something, I think.
Yeah, I really want to thank Parikshit, Dr. Parikshit and Dr. Munjal Kapadia from the bottom of my heart, because at a very short notice, they accepted our invitation to conduct this panel discussion. We had to give it to them for some unforeseen reason, and I'm really indebted to you for accepting this. Thank you very much, Dr. Parikshit. Thank you very much, Munjal. All the very best. And West Zone Yuva Fogsi conference organizing team will be indebted to you. Thank you.
With pleasure, sir.
Thank you, sir, for giving us the opportunity.
Sir, thank you, Narendra Gajar, sir.
Thank you so very much. It was indeed a wonderful panel. And as Munjal said in the beginning, if Parikshit sir is there, there's nothing to worry because 99% of the work is done. You have to show up on the screen. So that is good enough for you. So thank you, sir. And thank you, Munjal. Indeed, a wonderful panel. And the panelists have done true justice because it was beautifully discussed. Thank you so much. So we come to
Thank
the
you,
end
everyone.
of this morning session. And the best part I would say about this Western Yuva Foxy conference that I'm seeing is we started at 9 o'clock and we're supposed to break for lunch at 1 o'clock and we're just at 1:14. So
Yes, sir.
14 minutes delay is totally acceptable. Very good timing and very well managed the support team of this conference as well as the organizing team. So we break for lunch and we meet up again at 2 o'clock for the post-lunch session. Thank you so much. Join us then at 2 o'clock. Thank you.
Thank you. Thank you.
Bye. Bye. Bye.
પ્રીતિ મને ત્યાં મૂકી જજે ને પછી 5-10 મિનિટ પછી મને ગાડીમાં સત્યને ત્યાં મૂકી જજે 5-10 મિનિટ પછી ત્યાં પાર્કિંગનો સવાલ ને એને કોઈ પેશન્ટ ની પડી હોય ગાડીનું ન મળે કદાચ ઉતારી જા ને ના લાવ ના લાવ નહીં એ પેલું ટ્રાયલ નું કરવામાં તો કે તો અમે 5 મિનિટ પછી પહેલા જ આપીએ જે હતા એ જે પ્રોફેશનલ લોકોને રાખ્યા છે ને એ લોકો અમદાવાદમાં બેઠા છે હવે કઈક લોચો પડે તો આખો પ્રોગ્રામ એ થઈ જાય એ થાય એના કરતા
Hello, good afternoon. Good afternoon. Hello.
Hello.
Good afternoon. Myself, Dr. Manish Pandya.
Hello.
Yes.
हाँ बोलो.
Acha, I want to share my screen because my presentation is at 2 o'clock. So just want to check, is it possible?
You contact the person we have hired, Jalak
Okay.
Patel. हाँ.
Jalak
Number.
Patel. Okay.
हाँ जी. हाँ.
Okay. हाँ जी. Thank you.
Welcome.
હેલો.
હા, ડોક્ટર મનીષ પંડ્યા બોલું છું. ચલા, મારું 2 વાગે છે પ્રેઝન્ટેશન, તો મને સ્ક્રીન શેર કરવા માટેની પરમિશન આપશો?
હા હા હા.
બરાબર. હોલ એ માં. હોલ બી તો બંધ થઈ ગયો મોટી બેન. હોલ એ માં છું હું, ઓનલાઈન જ છું. તો જસ્ટ આઈ વોન્ટ ટુ ચેક, પછી આપણે એક્ઝેક્ટ 2 વાગે ચાલુ કરશું. ઓકે, હું ઓનલાઈન જ છું મોટી બેન. થેન્ક યુ. Hello. Hello.
Dr. Manish Pandya.
Yes, yes, madam. Yes, I am ready. Huh.
I think you are mute. Yeah.
No, no, madam. Now you can listen. Hello. Hello, am I audible?
Yes,
Hello.
yes, we can listen to you. I think.
Okay, okay.
So good afternoon, Dr. Manish. We are looking forward to listening to you.
Thank you, madam. Thank you. So let give host me permission to share my views. Yes, they are allowed. Just checking, then I will unshare. Just Bella, tell me my screen is visible. Hello, Bella.
No, this is Dr. Chinmay here. Yes, your screen is visible.
Screen is visible, na?
Yes, yes.
Okay. Now tell me one thing more. Is this?
Yeah, you're changing the slides fine.
Lines
Yeah.
here, our lines are seen?
Yes, yes.
Okay. Thank you. So, Dr. Chinmay,
Yes.
I hope we had meet again because
I know.
last time we had meet with abnormal placenta.
True, true. No,
So
I'm very much looking forward to your
Thank you, madam. So I'm just stop sharing.
Yeah.
And whenever you will say, I am ready with my presentation.
I think they'll have to start the session, no?
Yeah.
At 2 o'clock.
That's right. So
So
we'll
just I checked because it takes only 1 minute for dry run, that whether we can see all things or not.
Sure. Perfect.
So good show, Bella. Bella is mute now. Satyen, hi.
Hello, Dr. Manish.
Yes, madam. Namaskar. ક્યાંથી બોલો છો દેખાતા નથી. સત્યન દેખાય છે. નમસ્તે પ્રકાશભાઈ.
Yeah. Hello.
બેલા મેડમ સંભળાય છે?
કેમ છો?
બસ from Mumbai at home. આ કોન્ફરન્સે બહુ સારું કરી નાખ્યું. કોઈ મુસાફરી નહીં, કશું નહીં, ઘરે બેઠા મજા કરો.
ઘરે બેઠા બધાને મળી શકાય.
નમસ્કાર આશ્વી મેડમ.
Hello, Prakash Joshi.
Yeah.
Welcome.
Yes. Atul, all well?
Ekdam fine.
You people have organized very excellent conference, really.
And voice quality is also very good. There is no echo, no humming.
I think this should be the tradition even with non-COVID, without COVID pandemic.
Now we used to this. Even
Yeah.
our children used to have home classes. They don't want to go to school.
And then our children loves the parents that they are not leaving the house all the time for the conference.
But
and
most
hospital.
common disadvantage is Bill Gates. You see, living in home for more than 1 year make you separate. So it is also hazardous. Bella,
No,
any good news?
For many, it is a good news.
So longer
Dr.
people
Chinmay.
staying together, the vices are coming more.
That's true.
Which were hidden when we are out for 10 to 12 hours. Then it is emerging like volcano. Then it erupts and they disturb everything.
ડુંગર દૂરથી રળિયામણા.
And then you can continue online academics and offline saving your families. So
Right.
No, that's why. So your voices should be hidden. It should not come out.
Vices should be hidden from wives.
એવું તો ના કહી શકાય ને બેલા, કેમ કે અમે 2-3 જ મેલ છીએ. પાછા મરી જાય. અમે તું ત્યાંથી મ્યુટ કર દે. મનીષભાઈ આવું કીધું, મ્યુટ કર દો. Dr. Chinmay, now you able to follow little bit Gujarati, ne?
I completely follow Gujarati. I don't know. I find Gujarati very similar to Oriya also.
Yeah.
You said
Very
wait
similar.
karu chu. We also say like that.
મજા કરું છું.
I can understand.
Only difference is, Dr. Chinmay, you are speaking very slowly and we are speaking very loudly.
No, that is fine. I'll speak loudly if I speak
No,
loudly.
but the only difference, because I have got lots of friends in Oriya, so they
I
are
am not
speaking-
even. I am married to a Fauji. My husband is an army officer.
Wow.
So he was posted in Baroda, Pokhran, everywhere. So I have gone to the interiors of this country where you have not gone.
Jai Jawan, Jai Kishan.
डीसा, धनेरा, किधर से तो मैं गई हूँ. From Baroda to Ahmedabad to that Pokhran. हम लोग ड्राइव करके गए कितने बार.
अरे वाह, पोखरण में रहे तो बहुत अच्छा है। वो रणुजा के दर्शन करके आए थे कि नहीं?
हाँ बिल्कुल। तनोट माता we've had a camp there, मतलब 3-4 बार गए।
बाप रे बाप।
वो सब जगह अच्छा है आपका।
નિશાબેન મજામાં? મ્યુટ છો તમે?
એકદમ સાહેબ, તમે મજામાં?
સૌમિલ મજામાં?
સૌમિલ મજામાં સાહેબ, ઓલ ગુડ?
નવું મશીનના ખૂબ ખૂબ અભિનંદન.
થેન્ક યુ. તમારી સુધી ન્યૂઝ પહોંચી જાય ખરા નહીં?
પટેલ સાહેબ તરત જ બીજે દિવસે મેસેજ મોકલી દે. મોટા પટેલ.
મોટા સાહેબ,
મોટા
બરાબર
પટેલ.
બરાબર છે, બરાબર.
ના ના સરસ. ઓલ વેલ. સાહેબની તબિયત સારી ને?
એકદમ ઓલ ગુડ સાહેબ.
ચાલો 2 ને 3 મિનિટ થઈ, મારી 3 મિનિટ કપાઈ ગઈ. ભાઈ જલ્દી કરો, 15 મિનિટ જ છે. સત્યેન પછી કહેશે કે 10 મિનિટ મોડું ચાલુ છે.
कौन स्टार्ट कौन करने वाला है सेशन?
बस मैडम आप ही लाभ ले लो.
अतुल
2 મિનિટ જરા વેઇટ કરવાનું થોડું.
ઓકે. પછી એ મારામાંથી કાપતા નહીં. એક્ઝેક્ટ 15 મિનિટનું બનાવ્યું છે.
મનીષભાઈ અમે કપાઈ જઈશું પણ તમને નહીં કાપીએ.
થેન્ક યુ સો નાઇસ ઓફ યુ. મારી ફિટલ મુવમેન્ટ અત્યારે ઇન્ક્રીઝ છે, પછી ડિક્રીઝ થવા માંડશે. પછી તમારે ઇમરજન્સીમાં સિઝેરિયન કરવું પડશે મારું.
તમે જમીને આવ્યા કે બાકી છે મનીષભાઈ?
ના જમી લીધું હો, પ્રેમથી. 1 થી 2 તમે લંચ નો ટાઈમ આપ્યો હતો ને?
आज भी काम कर रहे हो या खाली इसके लिए?
नहीं, संडे को भी काम रहता है मैडम. पेरिफेरी में काम रहता है ये. वो राउंड रहते, कुछ जो नॉन पेशेंट है वो संडे को दिखाने के लिए आते हैं, क्योंकि वो पेशेंट की किचकिच ज्यादा नहीं होती, वरना बाहर 100 पेशेंट बैठे हैं तो सर्टेन लोग नहीं आते, तो उन लोगों को संडे बुला लेते हैं, क्योंकि वो चालू ओपीडी में सर खाए और 1 घंटा लेके जाए, उससे बजाय वो संडे आ जाए. ऐसे पेरिफेरी में ऐसा थोड़ा रहता है. बेला को अनुभव है. बेला भावनगर में थी तो बहुत काम करती थी. मुंबई में तो भी झंडे गाड़ रही है.
10 years in my Gujarat.
हाँ. भावनगर में उन लोगों ने बहुत अच्छा काम किया. सबसे अच्छा काम किया, इंसिनेटर लेके आए. Only place in I don't think गुजरात में कहीं पे है. IMA is owning the waste management.
Yes, that is Bhavnagar IMA, thanks to
Bhavnagar IMA, thanks to Hitesh.
Thanks to Hitesh. Yes, he was the pioneer. He started everything.
बाकी सब जगह पे हम वेस्ट मैनेजमेंट के लिए किसी और कंपनी को हायर करते. हितेश ने अपना इंसिनेटर बता के IMA को.
And I am the witness to how much hard work he did in Bhavnagar then.
और इतना बड़ा हार्ड वर्क किया तो भावनगर के लोगों ने उसको बॉम्बे भेज दिया. अब तो बॉम्बे जाके होता है.
That was his own wish.
मनीष भाई.
Yes.
हाँ अतुल भाई. हेलो.
नमस्कार गजर साहब.
कंफर्टेबल.
एकदम कंफर्टेबल साहब.
जम्या.
एकदम आनंद थी.
सर.
वीडियो ऑन कर दो.
सत्येन सर के पीछे जो कैलेंडर है उसमें ओडिया में माँ लिखा हुआ है.
यस.
है ना?
पीछे दिख रहा है.
તમને દમણનું સરસ જમાડ્યું નહીં આ વખતે, બધું રહી ગયું ખાવા પીવાનું.
ના ના અમે પાર્સલ સ્વીકારીએ છે. કુરિયર સર્વિસ ચાલુ છે અને એવું અમને
ઝોમેટો નહીં આવે.
જમવાનું મળે, અમને નાન ખટાઈ પણ ચાલશે.
પણ પેલા જેવી મજા ના આવે ને, આ વર્ચ્યુઅલ છે. વર્ચ્યુઅલ
ના ના અમે સાહેબ વર્ચ્યુઅલ કેમેરામાં રાખીને નાન ખટાઈ ખાશું.
અચ્છા અચ્છા.
સત્યને દેખાડ્યું આ નાન ખટાઈ અમે ખાઈ રહ્યા છીએ. આકાશ બરોબર ને?
હા બરાબર. નાન ખટાઈ બી વર્ચ્યુઅલ જ છે.
હેલો.
કેમ છો નરેન્દ્ર અંકલ? હાય આકાશ.
હા કેમ છો?
મજામાં અંકલ?
યા નિશા, હેપી ટુ સી યુ.
કોન્ફરન્સ કરી છે તમે ઓર્ગેનાઇઝ.
ના ના એકદમ સરસ છે. છોકરાઓને તો બહુ મજા આવે છે, સ્ટુડન્ટ બધાને.
હા થેન્ક યુ.
પતે છે. ધેટ્સ ગુડ.
પ્રકાશભાઈ
બસ ફાઇન. નરેન્દ્રભાઈ
બરાબર. ચલો આ બાને તો મળાય કોવિડ માં તો.
તમે બહુ એક્સલન્ટ, એકદમ કહેવાય ને ફ્લોલેસ, એકદમ ફાઇન કોન્ફરન્સ કરી.
અને મોર ધેન 1000 ડેલિગેટ્સ જોઈન થતા હોય એટલે સાહેબ.
નહીં સાહેબ 1700.
એટલે કહું મોર ધેન 1000 તો મેં જોયા હતા. 1700 ઇઝ ગ્રેટ નંબર.
હા એ જ તો.
અને આપણે ઓરિજિનલ કર્યો તો આટલા નહીં થાય.
ના ઓરિજિનલ તો 600. 500.
તો તમે 1100 પ્લસ છો સાહેબ ધીરુભાઈના ગામમાંથી.
હા.
અજય સાહેબ કેમ છો? નમસ્તે, બેલા બોલું છું.
હા, કેમ છો?
કેમ છો સર?
મજામાં છે. ચાલો સ્ટાર્ટ. Shall we start?
I think we should start, madam.
હા, ચાલુ કરીએ કારણ કે આપણે બધું
7-10 મિનિટ આપણે લેટ છીએ સાહેબ.
ઓ યસ.
5 મિનિટ જરા બધું હોલ બી ને હોલે સાઈન ચાલુ થઈ ગયા સાઈન.
નો પ્રોબ્લેમ સત્યન, પણ મારો ટાઈમ ચાલુ કરીશ પછી 15 મિનિટ. આ બધું તમારી 7-8 મિનિટ કાપી નાખો.
હા, એ તો આમાં નહીં ગણીએ.
આમાં ના ગણતા.
આમાં નહીં ગણીએ. વાત એવી છે કે આપણે આ રેકોર્ડ છે, આપણે કોઈને વેબિનારમાં જે કલાક આપણે આગળ પાછળ થાય અહીંયા જરા બી આગળ પાછળ.
ના ના, સવારે સાહેબ 1:14 પતી ગયું સાહેબ.
હા,
સવારનું સેશન તમારું 1:14 પત્યું. વિપુલભાઈ છેલ્લે 1:14 થેન્ક યુ બોલ્યા.
હા, કાલે તો બહુ ટાઈટ ટાઈમ મેનેજમેન્ટ કર્યું એકદમ.
ના, આજે હું એટલે જ 1:45 તો લોગિન થઈ ગયો, પણ થોડું આ ચાલ્યા કરે. 8-10 મિનિટ
જમવા તો દેવા પડશે ને.
હા, જમવા જ દેવા પડશે ને. ભૂખ્યા પેટે તો સાહેબ ભજન બી ના થાય.
પ્રિયાંકોર
પ્રિયાંકોર હવે કોન્ફરન્સ સ્પેશિયાલિસ્ટ થઈ ગયા છે.
હા, પ્રિયાંકોર ઇઝ ડુઇંગ ઈસ્ટ ઝોન યુવા ફોક્સી.
હા, સરસ છે સિલિગુરીમાં. અને થેન્ક યુ પ્રિયંકર, તમે એલાવ કર્યા સ્ટુડન્ટને.
થેન્ક યુ સર, થેન્ક યુ સો મચ.
બધા સ્ટુડન્ટ પેપર કરવાના છે, બધા સ્ટુડન્ટને પેપર આપ્યા છે, એબ્સ્ટ્રેક્ટ મોકલી દેશે.
Absolutely sir, no issues sir, absolutely.
Thank you Priyank.
थोड़ी हाइब्रिड करो ना, हम लोग सिलीगुड़ी आए, थोड़ा हाइब्रिड 50 faculty is hybrid.
Sir, we would have loved it to have it sir, but abhi sir the situation in Siliguri ka abhi bhi it's not improving sir. Case बढ़े जा रहे sir.
Yeah. Maybe the ravaging results of election.
Dr. Roy, can we start now?
Dr. Atul is in charge in the afternoon, Ms. Alak. So I think.
But let's start.
Okay.
Yeah.
Now we can start.
Gajjar sir, we are starting.
Dr. Atul sir, please start this session. Yeah.
Let's start.
Good afternoon, everybody.
Good afternoon.
I welcome in the post-lunch and the last session of the conference. And I thank Dr. Vipul Kapadia, Dr. Narendra Gajjar, Dr. Satyan Kasabwala for asking me to conduct this session. In Kathopanishad, it is said, Utishtat Jagrat Prapya Varan Nibodata. अर्थात उठो, जागो और उत्तम गुरुओं से श्रेष्ठ ज्ञान प्राप्त करो. This is the best platform to learn from श्रेष्ठ guru from the every corner of the world. Spiritual leader Mahatrai, he has said, knowledge is given to you to construct your future. And this is the best platform. This is the best conference, is the best occasion. And Yuva Fogsi in particular, to construct the future of the young Fogsians. With this remark, I invite Dr. Chinmay Rath and Dr. Prakash Joshi. Dr. Prakash Joshi is the senior consultant of Himmatnagar. He had been the president of Himmatnagar Fogsi, Himmatnagar Medical Association and Rotary Club of Navsari, practicing for the last 35 years. He is my senior co-resident in BJ Medical College. Welcome Prakash and Dr. Chinmay Rath. Okay, Prakash and Chinmay, carry on.
Thank you, sir. It's an honor to be here in the West Zone Yuva Fogsi. And I think Prakash sir, will you like to just start the session?
Yes, without wasting the time, I like to start the session with Dr. Manish. And he will talk on the hospital movement. And I just give a brief introduction. That he is a professor and HOD at Surendranagar, and is a very dynamic speaker. And he has published so many papers and in so many journals. And he is having his own book published in the count of 8. He is having a center for CPS, and nearly 49 residents have passed, and he is having a 4 seats for the GO. I request Manish to start his session.
Yes, sir. Thank you very much, sir, for kind words. Just 1 second. This check. Is my screen visible?
Yeah.
Yes, we can see.
But with participant list is there or only screen?
No, we can see your screen.
Screen, but not participant list, na?
Is that your slide or is that the CV slide?
I don't know. Let's
Please
just
change your slide. We'll come to know. Yeah, I
but
think
the
that's
participant list is there, na? Yes, I am just cleaning it. Okay. So thank you. Welcome to Yuva Fogsi. Thank you for kind words, Dr. Prakash sir. How beautifully everything is arranged by Almighty. That as soon as child enters the world, it finds mother ready to take care of it. With the blessings of mother of mine and so many mother, 3 books recommended, written by him is recommended by RCOG. As sir has rightly mentioned, these are 2 books, Atlas of Fetal Echocardiography, IVF Made Easy. And if anyone want to publish their article, I am editor-in-chief of 2 journals. Thank you very much. Today my topic is decreased fetal movement, alarm before fetal death. And now my 15 minutes starts now. My objective is normal. What is normal fetal movement? How fetal movement get decreased? Factor affecting the fetal movement and what is the optimal outcome? This is very good prey that I have no energy to move. I am struggling to keeping my mom. I am moving and my mother says I am live. I am a fetus in the womb. I fear it may become my tomb. If only I could give a shout to make my mother get me out. We try to put a title, Decreased Perception of Fetal Movement. Why? Because if you see in London 2001 and in Stillbirth Association has a nice review that 422 stillbirth has found that 69% cases are of reduced fetal movement. Over 55% of women experiencing a stillbirth perceive a reduction in the fetal movement. Early recognition of decreased fetal movement make it possible for a clinician to stage when fetal is still compensated and you can save the baby and you can save baby from neonatal death. If you see the prevalence, 40% of pregnant women experience decreased fetal movement 1 or more time during the pregnancy in either in a constant or in a transient form. So what are the different types of fetal movements she is experiencing? It may be rolling, it may be respiratory, hiccup, sometimes sucking, thumb and blinking also we can see on ultrasound. So what is maternal perception of fetal movement? It starts around 20 week and usually gets peak around 28 to 34 week. We almost know that multiparous notice fetal movement more earlier compared to the primary. Fetal movement tend to get plateau at 32 week of gestation and no reduction in fetal movement or in frequency in late or 3rd trimester. Fetal movement follow a circadian rhythm. That's why if we going for BPP biophysical profile, usually we are taking 30 minutes because usually fetus has got sleep awaken cycle around 20 to 40 minutes. So if you do your BPP around 30 minutes, we know that fetal has aroused at least once. Fetal movement slow diurnal changes. In the afternoon and evening periods, they are most at peak active. That's why if we are giving daily fetal movement kick count, we are telling that you have to do 1 hour in the morning, 1 hour in the afternoon, and 1 hour in the evening. Decreased fetal sensitivity to the fetal movement. So many times if fetal position is not proper, she may not perceive the fetal movement. Anterior placenta, and most important, beware that if you are administering corticosteroid, it will give you a less fetal movement. Unlike betamethasone, dexamethasone does not induce decreased fetal movement. That's why dexamethasone is most preferred. But once we know that beta is doing little bit of decrease in the fetal movement, decrease in the fetal heart acceleration, the preterm newborn chances will be less. So we are knowing that this is the effect because of betamethasone. So unnecessarily preterm deliveries has been prevented if you know this thing. Increased fetal movement with elevation of glucose concentration in the maternal blood. Vice versa is not right. In women with persistent decreased fetal movement, if we give glucose, it does not give increment into the fetal movement. What are the conditions associated with decreased fetal movement? Usually, most important is IUD, intrauterine fetal death, or fetal growth restriction. In cases of oligohydramnios or hydrophytalis, or polyhydramnios or congenital fetal malformation, anemia, this all can cause decreased fetal movement. Most single cause of decreased fetal movement is stillbirth in IUGR. Sorry for this disruption. And you around 30% of baby with IUGR, with SGA, has got reduced fetal movement, and if you don't carry out your action immediately, you may lose this baby, and this is 10th percentile, so it is a very high number. If placental insufficiency is the cause of decreased fetal movement, how you monitor this? What are the things which we will know that this is a decreased fetal movement and we have to carry out specifically? So, just one slide before. This is a very good slide. This is a sequence of struggling and sequence of capitulation. What is the struggling? If there is a chronic respiratory and nutritive deficiency, first is decreased fetal growth rate. Secondary adaptive mechanism is fetal energy conservation. It will go for decreased fetal movement, decreased fetal heart rate, failing cerebral blood flow, gives polycythemia, decreased oxygen carrying capacity. Ultimately, there is a decrease in the fetal movement. But if we don't correct this, then this will go for progressive decompensation, goes for hypoxia, respiratory acidosis, metabolic acidosis, absent diastolic umbilical flow, and ultimately it will go for fetal death. So we have to get alarmed at this struggling adaptation and we have to give baby out. 55% of cases of stillbirth are associated with decreased fetal movement, and 30% of IUGR are associated with decreased fetal movement. What is the importance of congenital fetal malformation? We all know that major congenital malformation is more likely for reduced fetal activity, and the lack of vigorous motion related to abnormality of central nervous system, muscle dysfunction. So in cases of decreased fetal movement are there with congenital malformation. What is assessment? Subjective versus objective. Can we depend on ultrasound fetal movement? During the recording of ultrasound, 20 to 30 minutes in semi-recumbent position gives best results of perinatal outcome, but evidence says that no study is useful for doing ultrasound for at least 30 minutes. But it is very useful. You can show patient that fetus is moving and they are happy. Fetal movement in a healthy fetus may vary from 4 to 100 per ultrasound. When corrected sonographically, 50% is isolated limb movement and 80% involving both and trunk limb movement, and mother usually perceive 33 to 88% of percentage visualized on ultrasound. What is the definition of decreased fetal movement? Till date, no society gives proper consensus. Royal College says that above the level of fetal movement that distinguishes a healthy fetus from not been determined. NICE and SCOG guidelines do not provide a definitive of reduced fetal movement with reduction in dilemma of controversy. Still, there is no definite movement. Till date, no alarming limit of observed fetal movement for fetal well-being. While sudden decrease in fetal movement should be evaluated as a potential risk marker because it may give death, and we have published one paper that when fetus commits suicide, that paper is very well appreciated. It is published in Indian Journal of Obstetrics and Gynecological Research, and it is cited very long. Adapted from Australian guideline, 10 fetal movement during 12 hours or normal activity, 10 fetal movements over 2 hours when mother is at rest, 4 fetal movement in 1 hour when mother is at rest and focused counting, 10 movements with 25 minutes of in pregnancy. So count of 10 is very good. It should be between 10 to 20. How to get rid of that dilemma? If woman is unsure about the rapid fetal movement at 28 plus weeks, Royal College in 2011 says you have to do count of 10. This is level C. ACOG 2014 perception of 10 distinct movement of a period of 2 continuous or interrupted fetal hours is considered normal. Only numerical number, again, it is count of 10. And if you see, lots of literature available on net on count of 10. It should be either qualitative or quantitative. There is no evidence that qualitative limit more effective than quantitative. So either they are doing on ultrasound or they are doing perceiving fetal movement. It's good. Most important evaluation, what is the rationale, what is the goal, and what is the method? Rationale is fetal heart rate, fetal movement are impacted by uteroplacental blood flow. By alteration, they are sensitive to fetal hypoxia. Any diminution in fetal activity requires fetal reevaluation, regardless of the amount time elapsed since last stage. Fetal movement decrease as fetus attempt to conserve the energy. The loss of fetal movement can be a sign of ongoing central nervous system hypoxia. So fetus is conserving the energy. So our goal is to rule out the imminent fetal demise. Assessment of the common risk factors such as fetal growth restriction and decreased placental function. Most important thing in decreased fetal movement is history taking. And believe me, the definition of history is very good. History is study of past in light of present to have good future. So give the ears and listen them carefully. In the morning, baby is moving well, but in afternoon now baby has stopped moving. Go for ultrasound, confirm what are the cause, what are the condition in which still risk born is high. There are multiple with hypertension, diabetes, smoking, placental insufficiency, congenital fetal malformation, obesity. These are the causes in which there is decreased fetal movement. What are the clinical implications? They are schedules. We have to go for physical examination, and most common thing is some symphysiofundal height. It should grow properly. NST and test, ultrasound, umbilical artery, Doppler, amnioscopy is the last source. This is very good study in topography, and you see the topography gives the best result of fetal well-being, 93%. Nowadays, we have got computerized topography is available. Kick chart has got 64, not bad. BPP is 54, the 34%, and umbilical artery is 23%. Umbilical artery blood flow they had given is 23%, but it is also good. Count of 10, morning, evening, and afternoon, everybody should go for it. But what evidence says? Using kick charts were associated with higher intervention, 32% more cesarean section. This is published by Sina and around 2007. And my dictum is better to have scar on uterus rather than scar on heart. You may increase the number of cesarean section rate, but baby is saved. What is the rationale of fetal movement count is not even established. ACOG supports formal movement counting in their bulletin on antepartum fetal surveillance. They instruct the woman to count up 10, preferably after meal and for 2 hours. Cochrane has got 5 trials involving more than 71,000 patients. No enough evidence on counting of baby's movement in the womb. Check is well-being, but still we are doing it and we are believing that it is a good thing. These are the charts available on net. You can see CTG is very much important. Most important thing in CTG is even without fetal movement, fetus does not experience fetal heart acceleration for 80 minutes, then suppose that fetus is compromised. One negative predictive value of NST alone for predicting preterm birth, 1 week of a normal test is 99%. So you have got very good breathing time of 1 week when CTG is normal, no heart acceleration, no deceleration. Ultrasound, almost very good, but it can exclude the fetal growth restriction. Growth restriction has been associated with decrease in number of quality, strength, and duration of fetal movement. What we can see in ultrasound, perfusion and growth velocity, and most important thing, we can see the Doppler. BPP, I had already talked, it is for you have to do for 30 minutes. It has given a score of fetal movement, fetal breathing. A total biophysical profile less than 4 is abnormal and suggestive of fetal compromise and increased risk for fetal outcome. RCT does not support the use of BPP as a test of well-being, but we can go for BPP in case of suspicion or in case of IUGR. Doppler is very good for diagnosis of IUGR. They had done study of more than 599 cases. They found no additional benefit of Doppler, but Doppler demonstrated a pathological pattern in 1% of cases in 1,150 cases. 94 cases after exclusion have got non-reactive CTG, and Doppler can find out the abnormality only in one case. But in low, that 100 ગુનેગાર ભલે છૂટી જાય પણ એક નિર્દોષની સજા ન થવી જોઈએ. Likewise, if you are able to save one baby, then it's good. I advise that you have to go for Doppler velocimetry, and these are the different Doppler findings that we can see on ultrasound. This is the umbilical waveform. No evidence says that inclusion of umbilical artery in an antenatal surveilling provides additional benefit in assessment of fetal growth. SEOG support that use of uterine artery Doppler assessment only in the management of suspected IUGR. Uterine artery Doppler results in combination of other fetal tests. So we are usually advocating uterine artery Doppler and umbilical artery Doppler. Abnormal elevation of Doppler indices precedes loss of fetal heart rate variability, reactivity, and eventually leading to decline and loss of fetal breathing and body movement. These are the two slides. I will do it very fast. You can see there is an abnormal umbilical heart rate. This is, you can see the umbilical artery waveforms. They have got decreased fetal movement. You can see there is an absence of the umbilical heart rate. This is, you can see there is absent umbilical diastolic flow associated with very bad uterine artery Doppler. You can see systolic notch as well as diastolic notch. So these babies are very much compromised, and you have to act very promptly to save the baby. Another good important thing is fetal bleeding. If you have got fetal bleeding, the sinusoidal heart rate pattern will be there. There will be tachycardia and fetal hypotropes. CTG is very good with middle cerebral artery Doppler velocimetry. If it is more than 110 peak systolic velocity, there is a fetal anemia. Large fetal-maternal transmission is entered in 0.3% of pregnancy, and this is significant contributor of stillbirth. There is no study to determine whether intervention alerts perinatal morbidity and mortality. No randomized trial have evaluated any aspect of management of decreased fetal movement. So only suspicion, abnormal findings, non-reactive states, low biophysical profile, less fetal growth. So manage according to the clinical standard, manage according to your sixth sense and gut, deliver the baby, give the breathing time. If there is persistent fetal movement and normal evaluation, there is no study evaluation that optimum frequency of method of follow-up pregnancy complicated by persistent decreased fetal movement in antepartum surveillance is normal. No data from randomized trial guide practice recommendation in management of decreased fetal movement. There is an adaptation recommendation of managing women's reported decreased persistent of fetal movement are associated with Stillbirth Foundation, the Perinatal Society, and International Stillbirth Alliance. There are agencies, those who are working in this favor. The management with persistent decreased fetal movement depends on the gestational age, the presence of other risk factor. We have to go for biophysical profile twice weekly or non-stress test. Do the elective cesarean section at 37 weeks as it is recommended. And this is a grade 2C recommendation that we have to go for cesarean section or immediate delivery when there is an abnormal Doppler. Decreased fetal movement in multiple pregnancy, we can see it depends upon the chorionicity. If there is no structural malformation, no TTTS, it is associated more with monochorionic gestation. So beware for that. You can have a cases of decreased fetal movement in post-date. That is because of the amniotic fluid, which is very less in post-dated pregnancy. Here, the uterine artery Doppler would not exclude, and it should be helpful in postnatal cases to relate impaired placental gas exchange rather than impaired blood flow. And recently in placental abnormality, madam, we had discussed that new dates, new investigations are coming. We can know that how much oxygen is going in the placenta, and that will be helpful in delivering those baby. These are some flow charts that how you can do decreased fetal movement at 28 weeks. If you don't act properly, it will go for IUD. And if there is a normal case, normal scan, you can wait for at least 1 week. Episodes of recurrent decreased fetal movement, very good chart, but we cannot go in detail. RCOG guideline for the management of small for gestation age fetus should be considered, and deliver the baby at 37 weeks, woman with suspected IUGR. So don't wait. Whenever you are in doubt, give the breathing time, go for cesarean section. Again, there is very good algorithm for recurrent fetal movement when 24 to 26 week, 27 to 36 week, and more than 37 week. If more than 37 week, don't wait. Just deliver the baby, give them the option of deliver. If 26 to 28 week, you have to perform CTG, wait for breathing time, and if neonatal facilities are good and baby is not able to survive in utero, you can go for cesarean section. So in summary, every mother who present with concern of reduced altered fetal movement should be taken seriously. The initial assessment include detailed history, deepest vertical pool of Liker, abdominal circumference to rule out IUGR, plus CTG. If normal, you can discharge the patient. Kick chart has got no value, but I am not agree with this statement because till date I am following the kick chart and I am very much happy. You have to evaluate it very judiciously. Don't go for cesarean section each and every case. BPP scoring has not shown beneficial effect. Uterine artery Doppler and vibroacoustic stimulation test has got limited use in assessment of reduced fetal movement. So take-home messages are NST alone for predicting stillbirth within 1 week is 99%. BPP and CST is 99.9. So use the technology very well and give the benefit of doubt your patients. These are the charts available on net. You can go, you can search, you can have evaluation. And this is my last slide. Thank you very much. I am able to stick to time of 15 minutes, sir.
Thank you.
Thank you.
Thank you, Dr. Manish. I think before we kind of wind up what you have said, you've kind of summarized, but I would like to drive home that point that although kick charts are not useful is what evidence says, it doesn't mean don't give it to the patient. I think there is a very good role of involving the patient in her own care by giving her that kick chart. And in low resource settings, particularly, the patient's monitoring of her own movements is one of the methods that you can hold.
It is in my
antenatal file, yeah.
Antenatal file, and everybody is measuring. And I may say it may increase little bit cesarean section rate, but we are saving the baby.
Cesarean also, delivery at term need not always be a cesarean section. See, they say that if there is recurrent fetal, reduced fetal movements, RCOG says if a woman comes back with recurrent episodes of decreased fetal movements, then maybe at 37 weeks, you can offer her delivery, which is a grade 2C recommendation.
Yes, madam.
But it is an offer of delivery, not an offer of cesarean section. So you might as well induce delivery and maybe you do continuous fetal monitoring in that labor. That is not, but not the take home point is that there is a good negative predictive value to fetal movements.
Yes,
so if a woman is monitoring her fetal movements and feeling good fetal movements, then a lot of major problems are not there. If she feels decreased fetal movements, not necessary that there is a problem, and then she might go for further investigation like a CTG or a Doppler examination or something else. So there is some role of decreased fetal movements, and you've given us enough evidence about it. Thank you. Dr. Prakash, you want to say something?
No, I just agree with you, Chinmay. You're absolutely right. Yeah. But
And
I do remember that in late 80s, Dr. Eddie Dastur from Mumbai Wadia Hospital, he published the paper on decreased fetal movement in the need of cesarean section, because it was the era of inception of the ultrasound machine in the major institute of the country. But I did remember the statement that in those days, due to lack of the technology, that when the patient, irrespective of class of her education, whether literate or illiterate, but one should never ignore the complaint of decreased fetal movement, because when the illiterate patient says that there is a loss of fetal movement or decreased fetal movement, one should not ignore it. And secondly, in the era of this medical legal litigation, we must offer some option of cesarean section to be done in time, because there are so many relatives, they are go through the Google, they find some idea from the Google, and they cross-check the doctor that why you have not offered C-section, because once you make the delay, if there is accidental death of the baby, whatsoever is the reason, then they are having a good reason to say to the doctor that we were agreed to have C-section. So, and I do remember my own case when my wife
Maybe
during
we go for a second lecture.
second cesarean, she complained of decreased fetal movement, and I did the cesarean section. My baby was absolutely cyanotic, even without labor pain, all the things. And now he's well, aged 24. Otherwise, we would have lost that child. Anyway, let us proceed
Thank
with
you,
the
sir.
next lecture. Yeah.
Thank you, sir. So one sentence: it is better to have scar on uterus rather than scar on heart.
That's a very
thank you.
philosophical statement to take home. I think let's move on to the next
Thank
lecture.
you, madam. Just I'm stop sharing my and thank you very much, Yuva Fogsi, for giving me opportunity to compile whatsoever I was knowing about the decreased fetal movement in a less than 15 minutes time. Thank you very much. Thank you,
Thank you, sir.
Vipul bhai. Thank you, Narendra bhai. Thank you, Satyen.
Thank you, sir.
Thank you.
Thank you. And the next lecture is by Dr. Jai Lakhani. Can I have his slide for his introduction?
No, sure. Okay, sure. Done.
We can see him on the screen, but we need an introductory slide for Dr. Jai Lakhani. He is going to speak about prolonged pregnancy. Okay, we'll, I think, maybe proceed for the lecture itself.
Madam, can you see my slide?
We can see your slide. I was hoping to have an introduction slide for you so that I could introduce you to the audience. I think you will now get introduced by your own work. So he is going to speak on prolonged pregnancy. Really, I would call it an enigmatic topic because there are too many doubts there. So over to you, Dr. Jai, and we'll carry on.
Yes, thank you, madam. So I am presenting today on prolonged pregnancy. I would like to thank Narendra sir and Vipul sir for allowing me for this presentation. Madam, I am practicing as an obstetric and gynecologist in Porbandar, Gujarat.
Okay, wonderful place.
And my field of interest is ultrasound.
Excellent.
So I'll be focusing more on ultrasound in prolonged pregnancy.
Sure, we are looking forward to what you have to say. Please start your talk.
Yes, madam. So shall I start, madam?
Yes, please do.
A pregnancy is considered term when it is between 37 to 42 weeks. American College of Obstetrics and Gynecology has endorsed a few recommendations that term be replaced with early term, that is 37 to 39 week pregnancy, full term 39 to 41 week pregnancy, late term 41 to 42 weeks pregnancy, and post term 42 weeks and beyond. Now in clinical practice, it is very difficult to decide what is the ideal time for induction. But various studies have shown that if you go beyond your expected date of delivery, there are high chances of perinatal morbidity and mortality. So according to various studies and data of perinatal morbidity and mortality available, it would be reasonable to conclude that pregnancy beyond 41 weeks warrant clinical concern. In this talk, pregnancy between 41 and 42 weeks will be referred to as prolonged pregnancy, while those beyond 42 weeks will be referred to as postpartum pregnancy. So, when the pregnancy was diagnosed, when the diagnosis was based only on menstrual history, the incidence was 7.5%. It was 2.6% when it was diagnosed by early ultrasound, and it was 1.1% when diagnosed by menstrual history and USG both. So what are the etiological causes? First is the error of LMP. So if the patient is having history of oligomenorrhea, patient is PCOS and she is having delayed period, or if the mother is lactating, we don't get correct LMP. So the first is the error of LMP. Studies have shown that the patient who have got prolonged pregnancy in her first pregnancy might get prolonged pregnancy in her second pregnancy as well. BMI less than 18.5% is associated with risk of preterm labor, and the BMI more than 25% is associated with prolonged pregnancy. Rare causes include placental sulfatase deficiency. So what happens is that there is less secretion of placental estrogen, which causes less receptors of oxytocin and prostaglandin in the myometrium. So the labor pain doesn't start. Fetal adrenal hypoplasia and anencephaly, these are related with hypothalamic pituitary adrenal axis, and there is no release of cortisol hormone, and the labor pain doesn't start. And you sometimes get oversmart patients who are not willing for induction of labor. So for diagnosis, first, the most important thing is the dating of pregnancy. So for the dating of pregnancy, first trimester crown rump length is most important. So the same funda applies. When you are doing your NT scan, you have to measure crown rump length. Make sure that the fetus is not in the flexion or the extension position, it's in the neutral position. You have to measure the crown rump length. What happens with the second and third trimester is that if the fetus is IUGR, the machine is going to tell you the date which is away from the EDD, and if the fetus is macrosomic, the machine is going to tell more nearer. So first trimester dating is most important, and nowadays we have got the facility of entering LMP as well as the date of conception. So if this is an IVF pregnancy, you know the date of the embryo transfer, so you can put the date of embryo transfer in the date of conception, so you can get the accurate expected date of delivery. So pathophysiological changes in prolonged pregnancy. So we are talking about amniotic fluid changes and the placental changes. The amniotic fluid reaches peak at around 38 weeks and gently decline after it. Addition of meconium in such amniotic fluid leads to respiratory complication in newborn. You can measure AFI by the 4-quadrant technique and the single deepest vertical pocket. So for the AFI, this is the 4-quadrant technique. In our institute, we usually we turn on the color Doppler while measuring the amniotic fluid index, because what happens is that sometimes in the B-mold ultrasound, and if the code is present, you cannot see the code in the B-mold ultrasound, and you may get false increased AFI. So so it's recommended to turn on your color Doppler on while you are measuring your AFI. And another thing is to decrease your gain, because here in this figure you cannot make out if I can measure my AFI from here to here or from here to here. So always turn less your gain, so I know that the placenta is from here and I have to measure from here to here. Placental changes. The placenta starts showing infarcts and infarction after 38 weeks, which increases with gestation. There is fibrinode necrosis and atherosclerosis in decidual and chorionic blood vessel. Grade 0 is homogeneous placenta. Grade 3 is you can see the different cotyledons, and there might be calcification of the placenta. So this is the homogeneous placenta. This is, you can appreciate the different cotyledons, and this is the calcified placenta. But the studies have shown that the placental maturity and the fetal in the prolonged pregnancy, the correlation is poor. So you don't need to depend upon the appearance of the placenta. There are a few studies available which shows that there is a correlation between the fetal lung maturity and the placental maturity. So the fetal and neonatal complication associated with prolonged pregnancy are perinatal death, fetal asphyxia, meconium aspiration. This all occurs because of the uteroplacental insufficiency. There is oligohydramnios, so there is a cord compression. Fetal gets less oxygen, so there is a perinatal death. There is fetal asphyxia. Fetal passes meconium, so there you get meconium aspiration syndrome. Fetal trauma you get because of the macrosomia, because in prolonged pregnancy you get macrosomic fetus of more than 4 kg or 4.5 kg. So there is brachial plexus injury, there is fracture of the humerus and the clavicle, so that occurs because of the macrosomia. So for the ultrasound, the macrosomia, abdominal circumference more than 95th centile is the macrosomia. Here in this slide, this is the subcutaneous fat you can see between the two arrows. So this is a macrosomic fetus. Maternal complication, there will be perineal trauma because of the macrosomic fetus, operative interventional, cervical tear, PPH. This occurs because of the macrosomic fetus. There will be macrosomic because of the macrosomia, you may get shoulder dystocia. This leads to perineal trauma. You have to suture it for hours and hours, and you might have to do cesarean section because of the non-progress of labor, cervical tear, and the PPH because of the perineal tear, traumatic PPH, and the postpartum infection because of the operative intervention, and you may get postpartum endometritis. So antepartum management. So for the fetal surveillance of the prolonged pregnancy, we have got NST, we have got computerized CCTG, we have got biophysical profile, and we have got color Doppler USG. The problem with the NST is that it will always going to show the changes once the fetus develops acidosis. It's not going to show us the early change. Computerized CCTG, it's not easily available. Biophysical profile, I find it very cumbersome because in heavy OPD, it's very very difficult to look one patient for 30 minutes to look for the respiratory movements, fetal movements. So it's very cumbersome. In our institute, we depend upon the color Doppler USG, and for the fetal growth restriction and when to deliver fetus, we strictly depend upon the Barcelona protocol. Though this is out of the scope of this topic, but when to deliver the fetus, we strictly depend upon the color Doppler U ultrasound. So this is the NST. We have got acceleration. We have got good bit-to-bit variability. This is the normal NST. There is less bit-to-bit variability. There is no acceleration. So this is the abnormal NST. For color Doppler, we have got uterine artery, we have got umbilical artery, we have got middle cerebral artery, ductus venosus, aortic root isthmus, and the cerebroplacental ratio. Now, still till date, many obstetrician believes that the uterine artery shows the function of the placenta and the umbilical artery shows the function of the fetus, but that's not correct. The uterine artery shows the maternal function of the placenta, and the uterine artery and the umbilical artery shows the fetal side of the placenta. Uterine artery and the umbilical artery doesn't tell anything about the well-being of the fetus. For the well-being of the fetus, we are measuring MCA, ductus venosus, aortic root isthmus, and the cerebroplacental ratio. So this is the uterine artery PI. In the first trimester, you get decreased uterine artery PI. You may get diastolic nodes. This is because in the first trimester there is less trophoblastic invasion of the spiral artery. But as the gestational age advances, there is trophoblastic invasion of the spiral artery, and you get good uterine artery PI. There are normograms available. What is the 95th centile of the uterine artery PI? But for convenience, we can remember that in the first trimester, if the uterine artery PI is more than 2.5, it is more than 95th centile. In the second trimester, if it is more than 1.75, it is more than 95th centile. And in the third trimester, if it is more than 1, it is more than 95th centile. Uterine artery PI more than 95th centile is the alarm for.
Just conclude in 1 minute.
Yes, sir.
Conclude in 1 minute.
Continue, Jay. Conclude in 1 minute.
Yes, sir. Umbilical artery PI, we all are familiar with it. This is the normal flow. This is the less PI. This is the absent diastolic flow, and this is the reverse diastolic flow. MCA, you get reverse of the MCA. What you are seeing in umbilical artery, you are going to see the opposite of the what you are going to see opposite in MCA. There will be no flow in the first, second trimester in the MCA. But as the hypoxia develops, when the fetal brain is in need of more oxygen, the fetal brain needs more oxygen, there will be more diastolic flow. CPR is more sensitive than MCA, so we are coming to that. Ductus venosus, this is the JVP of the fetus. If an adult gets right-sided heart failure, you can measure the JVP the same way the ductus venosus tells us about the preload of the fetal heart. This is the normal flow. This is the less PI. This is the absent A wave, and this is the reverse A wave. Ductus venosus PI more than 1.25 is alarming. You need to do something. Again, I am talking about prolonged pregnancy. This is not I am talking about 32, 34 week fetuses. Aortic root isthmus. This is a very controversial vessel. This is the left ventricle. This is the aorta. This is the right subclavian artery. This is the ductus arteriosus. So when you put your cursor between the left subclavian artery and the ductus arteriosus, so if the brain is needing more oxygen, there will be decreased resistance in the brain. Brain will be trying to suck more blood. So in the normal, you will get the normal flow, but when the brain is trying to get more blood, you are going to get
1 minute left.
You are going to get this reverse flow in this thing. CPR, there are various normograms available. This is the 5th centile at various gestational age, but you can, for your convenience, you can remember that CPR less than 1 is abnormal. Induction of labor, we have got Bishop score. I'm not going in the detail. CTG monitoring is advised during labor. Dinoprostone gel, Serviprim gel, 1.5 milligram can be used every 6 to 12 hours. Misoprost tablet, 25 microgram can be used every 3 to 6 hours. If the patient is having asthma, contraindication to prostaglandin, we can use manual dilatation by Foley's catheter. Oxytocin and ARM can be used. Intrapartum care, shoulder dystocia, already topic has been covered today. Fetal trauma, again because of the macrosomia. Maternal perineal injury, 3rd and 4th degree tears because of the macrosomia. Meconium aspiration, neonatologist should be present if you are suspecting this. So the take-home message is that the concept of prolonging pregnancy beyond 41 weeks is gone in modern obstetrics. In cases where pregnancy is prolonged beyond 41 weeks, prolonged Doppler and NST should be done every 3 days, ideally color Doppler, but if color Doppler is easily not available, you can do NST. Patient should be explained about the risk and complication of prolonged pregnancy and should be encouraged for induction of after expected date of delivery. Thank you.
Thank you, Dr. Jay. And I think one of the most important things that you've said is establish the dating early on in pregnancy so that, you know, the final date of that pregnancy is known well in advance, because prolonged pregnancy should not be miscalculated. Once you cross 40-41 weeks, the incidence of placental dysfunction is very high, especially in Asian placentas. Most of these guidelines have come from Caucasian studies where they even wait up to 42 weeks for induction of labor. But in our population, after 40 weeks, the placentas really don't function very well. The incidence of meconium staining of liquor is very high. And therefore, by 40 weeks, we take a call. So the methods of monitoring that you mentioned are all good, but Dopplers, really the importance of Doppler starts diminishing after 34 weeks. So we rely more on the CTG and even on the biophysical profile in that one, particularly amniotic fluid index, like you mentioned at that point. And what Dr. Manish was mentioning, maternal perception of fetal movements. So those would perhaps be the better methods of monitoring post-term pregnancies. Prakash sir, your take.
No, it's all fine. You said right things.
It's thank you, and I think very nicely presented. The West Zone Yuva Fogsi is having a lot of nice Yuva speakers who are doing their state proud. And let's move on to the next talk. Prakash sir, would you like to introduce Bela madam?
Yeah, Dr. Bela, but she's gynecologist from Rainbow Women's Hospital, Mumbai. And the most important thing is that she is chairperson-elect Fogsi Imaging Science Committee for the year of 2021-23. And she's a fetal medicine consultant. I request Bela to start MCDA twins diagnosis and management.
Thank you very much, Dr. Prakash sir, for that kind words of introduction. I would just share my presentation. Yeah, can you see my slides?
Yes, we
Yes,
can.
yes.
It's really glad to have Dr. Chinmay and Dr. Prakash as chairperson for this session. And at the outset, I would like to thank the West Zone Yuva Fogsi, entire organizing committee, Dr. Vipul Kapadia sir, Dr. Narendra Gajja sir, for giving me this opportunity to be part of this wonderful conference. Well, the monochorionic pregnancy diagnosis and management, actually this is a very, very vast subject and can't be just covered in 15 minutes, but I'll try to touch upon the important aspect. And once my time is over, please chairpersons let me know so that I'll conclude. So these are the important references, and we all know that ISIOG has given very wonderful guideline as to how to monitor the twin pregnancy with the help of ultrasound. And we know that without ultrasound, we cannot monitor twin pregnancy anymore. So it is inseparable part of management of twin pregnancy, whether it is dichorionic or monochorionic. Now, one thing we must understand that human pregnancies are not designed for multiple pregnancy unlike other animals. It is meant mainly for singleton pregnancy. And therefore, whenever there is more than one number of fetuses in the womb, we are all worried of the complications that can occur out of it. Now, we all know the difference between dichorionic and monochorionic pregnancy. In dichorionic, there will be two separate placenta for each fetus, whereas in monochorionic pregnant twins, they are the identical twins who share one placenta with vascular anastomosis connecting the circulation of both the fetuses. And that is the reason for worry, which is leading to all the complications. We know whenever there is cleavage of embryo between day 4 and 8, we'll get monochorionic pregnancy, and beyond that, of course, the momo and the conjoined twins. Now, although the occurrence of monochorionic twin pregnancy is rare, only 0.4% of general population, associated complications due to shared placenta circulations are frequent, and therefore we need to monitor. I'm not going to detail of this, but just one word, that zygosity is not synonymous with the chorionicity. Dizygous are always dichorionic, but the monozygous can be dichorionic as well as monochorionic, and the majority, 75% of monozygous would be monochorionic diamniotic, 24% can still be dichorionic, and 1% would be momo twins. Now, the single most important aspect of managing twin pregnancy is first trimester evaluation. And this cannot be overemphasized. We know there are so many things, important things which are to be looked upon in the first trimester scan, that is your 11 to 14 week scan. Now we know that everywhere, almost everywhere in India, even in periphery, there is a facility for nuchal scan at 11 to 14 weeks. And therefore, these are the aspects that we look at first trimester. But again, out of all of them, that is number of fetuses, dating of pregnancy, of course, it is very, very important. Determining chorionicity and amniocity is one single very, very important aspect that we all must not miss. Twin labeling, screening for aneuploidy, screening for structural abnormalities, and screening for preeclampsia and fetal growth restriction. But again, once again, I'll emphasize that one must not forget determining chorionicity and amniocity, because this is the golden time when we can, with 99 to 100% surety and sensitivity, we can make out whether it's a dichorionic and or monochorionic twin. Now, why is chorionicity so much important? Because dichorionic and monochorionic twins are way different, and so is their monitoring. We know that monochorionic twins has much more complication as compared to dichorionic twins because of vascular connections and sharing of placenta, and therefore selective fetal growth restriction to the tune of 14%, structural anomaly 10%, and there are many vascular and placental complications which are just unique to monochorionic pregnancy, like twin to twin transfusion in 9%, twin anemia polycythemia sequence in 5%, and twin perfusion in 2%. right? So that's the reason why we are so much worried about monitoring this pregnancy. So how do we decide about this chorionicity? So basically we know about the T sign and lambda sign, which is based on the membrane thickness at the site of insertion of amniotic membrane into the placenta because of the insinuation of the placental tissue in dichorionic pregnancy. So lambda side, you can very clearly see that this chorionic tissue is insinuating between two amniotic membranes, making it a lambda sign, with which we great surety we can say that this is a dichorionic pregnancy. This is at 11 to 13 week scan. Whereas in case of monochorionic pregnancy, you will not find that chorionic tissue going in between these two membrane layers of amniotic membrane, and therefore that is inverted T or the T sign, which will again with 99 to 100% surety tell us that it is a monochorionic pregnancy. And when the pregnancy advances beyond 14 weeks, the sensitivity of T sign reduces to 77%, and in third trimester it is less than 60%. So the best time to find out whether it's a monochorionic or dichorionic pregnancy is 11 to 13 weeks. Not only that, only then and then we'll be able to plan our monitoring of pregnancy, how many times and what way we should be monitoring this pregnancy, whether it is monochorionic or dichorionic, right? And ISU has given this wonderful guidelines which we all can follow. This is for dichorionic, and for monochorionic we all know very well that after 11 to 14 weeks, once we have diagnosed that there is a T sign, this is a monochorionic pregnancy, then we need to follow them up at 16 weeks and then every 2 weeks onwards. And there not only the growth, but we look at the Leica, the Dopplers, and so on and so forth, so that we can find out various complications of monochorionic pregnancy. So it is criminal not to mention about chorionicity at 11 to 13 weeks scan, and no report of first trimester twin pregnancy should go without mentioning chorionicity. This is the biggest message that we all must carry home at 11 to 13 weeks scan. Now, why are there complications in monochorionic pregnancy? Well, we should try and understand there are 3 different types of equators in twins pregnancy. That is membranous equator, vascular equator, and hemodynamic equator, out of which it is the vascular equator and hemodynamic which are more important. In this figure, you can see this is the membranous equator, whereas this is the vascular equator. Vascular equator is the one where the vessels of both the twins or both the placentas are communicating with each other, and therefore all the changes, hemodynamic changes, are going to occur at this level, and therefore it is this vascular equator which is notorious and is going to create all the problems. Now again, in that there are different types of vascular communications. There can be artery to vein, artery to artery, or vein to vein communication between these two placenta or two fetuses. And when there is majority of artery to artery or vein to vein communications, blood flows on either side depending upon the pressure, and there is not much of the complication. But in case of artery to vein, there is a unidirectional flow from one fetus to the other, and that creates all kind of problems. Now, what problems can it create? Well, it can create TTTS, that is twin-to-twin transfusion syndrome, or twin anemia polycythemia syndrome. That depends upon what is the size of the vessels that is communicating with each other. With large central artery to vein connections, there will be TTTS, that is twin-to-twin transfusion, whereas when there are peripheral or small tiny artery to vein connection less than 1 millimeter, then we'll find twin anemia polycythemia syndrome. Now, in twin-to-twin transfusion syndrome, we all know that in monochorionic, there is 100% vascular connection between two placentas or two fetuses. But then TTTS develops only in 10% of this monochorionic twins. Why so? That is because only if there are majority of artery to vein connections, then only the fetus is going to develop TTTS and not otherwise. Now, this is a quintero staging of TTTS, and the stage 1 is oligopoly, where there is oligohydramnios in the donor twin, whether your deepest vertical pool pocket is less than 2 centimeters at 18 weeks, whereas there is polyhydramnios in the recipient twin that is more than 8 centimeter at 18 weeks. Stage 2 is one in which the bladder of donor twin is not visible. Stage 3 is where the Doppler of either of the twin is abnormal in the form of absent or reverse diastolic flow, reversal of wave, A wave or pulsatile lumbility bend, which is a very, very late stage. And stage 4 is hydrops in one or both twins, and stage 5 is demise of one or both twins. Now, Pinter's staging, as we all know, that not necessarily it will be sequential. What do I mean by that is the fetus can go from stage 1 to 3 or 4 also suddenly, not necessarily go down in the same fashion. And therefore, we have to be very, very careful in our monitoring. But we are still using Pinter's staging because it is simple to understand, standardize, improves communication, and it helps us to compare the outcome. Now, how early can we pick up twin-to-twin transmission syndrome? Now, there are markers of TTS at 11 to 13 weeks like CRL discrepancy, amniotic fluid, anti-discrepancy, and ductus venous abnormality. Now, as far as anti-discrepancy is concerned, well, whenever there is anti-discordance of more than 20%, it has a sensitivity of almost 50 to 60% to predict TTS with specificity of 78 to 80%. But whenever there is abnormality in ductus venosus and tricuspid, that is A-wave reversal or absent or A-wave reversal or tricuspid regurgitation, it has a relative risk of 21 for TTS. And therefore, whenever we see all these signs at your 11 to 13 week scan, these are the red flags, and you need to monitor these fetuses very closely with not only growth, but the Dopplers, and to try and find out the TTS in the earliest stage where we can treat them, or we can refer timely if we do not have that fetal medicine center around. The risk of complication is less when the CRL, the anti-discordance is less than 20%, less than 10% complications are there. Now, what if the patient comes only late, or it has been, the 11 to 13 week scan has not been done? Now, actually in twins, this is the most crucial time, but then even if for TTS there were not any predictors of TTS, which is likely at 11 to 13 weeks, even 18 to 20 weeks scan is a crucial time to pick up TTS. And even if picked up at 18 to 20 weeks, a lot of fetuses can be saved. So apart from anatomy in this monochorion twin, we would look at the biometry, the deepest vertical pool, Leica, umbilical artery Doppler, ductus venosus, and fetal echo. Now, in management of TTS, then we must understand about the natural history of TTS. If it is not treated, what happens? Well, there is perinatal death in 90% cases and neurological impairment in 50% of survivors. And therefore, we must pick this fetuses up at right time and either treat or refer to a center where they can be treated. Now, stage 1, when you pick up, when there is oligopoly, less than 2 and more than 8 centimeters, that is the right time. If you pick up, then please refer to a fetal medicine center where there is treatment available, or monitoring and treatment of TTS, which is available, and there it will be followed up weekly. Now, if stage 1 with massive polyhydramnios...
Bilaben, 2 minutes to go.
Sure, sir. Sure. Then the laser can be offered. Now, stage 2 to 4 is the laser treatment of coagulation of vessel is the mainstay of treatment, whereas in stage 5, there will be no intervention. So just I'll mention about the principles of laser coagulation, where only the selective laser coagulation of placental anatomical anastomotic vessels is done, that is SLCPV, whereas a Solomon technique, which is much better, because apart from coagulating the anastomotic vessels, we are also doing coagulation of the entire vascular equator of the chorionic surface. And the advantage is there is better double twin survival, and there is to some extent we can prevent recurrent TTS and TAPS by Solomon technique. Now, there are centers where even referral is not possible. What do you do? After 26 weeks, if it is picked up and laser is not available, do the amnio reduction and reduce the chance of preterm delivery and reduce maternal discomfort and monitor them. But as far as possible, try and refer them to a fetal medicine center. Well, I don't think I'll be able to cover the rest of the important aspects of, as I said, it's a very vast aspect, but I would still emphasize on the 11 to 13 week scan. And if we are able to pick up the monochorionic twins timely at 11th, because there are still many reports that just mentions twin pregnancy, which is not acceptable anymore in this era. You must mention dichorionic or monochorionic pregnancy so that they can be referred to a center where monochorionic twins can be followed up very well, and we can try and prevent the complications in the monochorionic twin. Just one slide here I wanted to show that just for a rough idea as to how to differentiate between different complications of monochorionic twin. That is, when there is oligopoly combination, in one sect there is less liker, one sect there is more liker, it is more likely to be TTTS, whereas one sect there is oligo, there is less liker, and the other sect, the liker is normal, it is more likely to be selective fetal growth restriction of one fetus. And when both the sects showing normal liker and there is mild CRL discordance, then twin anemia polycythemia sequence is likely. Well, I don't think I'll be able to cover the rest of the complications of twins, but thank you very much for the opportunity, and I conclude my talk here.
Thank you. Thank you, Dr. Bella. You're right, MCDA is a very, very huge topic, and 15 minutes is really not enough, but still you managed to cover quite a lot of it. And I think the one take-home message from your talk would be that first trimester evaluation, assignment of chorionicity, and a comprehensive first trimester evaluation, because that is where you can make a sort of guiding path for care thing. And any MCDA requires a 2-weekly follow-up, and any red flag should be referred to a fetal medicine center. Prakash sir, your points.
Yeah, as you said, the laser ablation for the PTTS, but I think it's not a very easy procedure, and I think there are very limited centers available in India, and there are no competent people all around nearby. Actually, I'm lucky to see TTTS laser ablation by Dr. Kypros at London. And incidentally, I was present and I've seen the live ablation, but it is very thrilling and it is very, very dangerous procedure.
No, sir. I mean, now there are quite a lot of
quite a few centers now in India.
And in addition to laser, like when Dr. Bella said, suppose the patient is unable to travel and there's a very severe discordance in the twins, there's another procedure called radiofrequency ablation that has a smaller learning curve. So that also is being performed. And bipolar cord coagulation is there. So many procedures have actually started coming, sir, because they're like gradually people have started taking interest, and parents also have developed that confidence. I mean, 10 years back, most people with monochorionic complication would have opted for termination of pregnancy. Now they also want to think, so it's coming. I think we'll need everyone's blessings and patience, and it'll eventually reach more places. So thank you so much. I think with that, we'll move on to the next talk in the session.
Yeah. Dr. Nisha Patel. She's director and consultant in fertility and IVF specialty, Dev-ART IVF Center, Ahmedabad, and she has presented many papers in different societies. I request Nisha to start her lecture on fetal reduction.
Thank you, Chairperson. I hope my screen is visible.
Yeah.
Okay, fine. So before I start my lecture, I would congratulate the team Navsari for arranging such a nice and splendid, successful conference. And also thank to the society for giving me the opportunity to share my views on a topic called fetal reduction. I'll go through, my video is on, right? You can see. Okay, so my talk will go under the following subheadings, like what exactly the fetal reduction is, when and why it is indicated, what is the pre-operative and operative procedure, what are the different methods of reduction of a fetus, what the post-operative care needed, what are the complications, what is the chance of total pregnancy loss, and ultimately I'll share some experience from our institute. So as we know, what is the fetal reduction? The name suggests it is a procedure which reduces the number of fetus in a multiple pregnancy, usually to 2 or 1. It is a form of an abortion in which the most accessible fetus gets terminated by direct needle, which is stabbed through the heart of a fetus. That dead fetus ultimately remain inside the utero until the delivery of the living ones. Now, why this procedure actually needed? As we know, since the advent of the IVF and ART procedures, there are rising trend in the multiple pregnancy from like double and triple the chances of even quintuplates and sextuplates, and that gives the rising trend of a multiple pregnancy. But whether it is survivable, so ACOG has given some data in 2004, and it clearly suggests that triplets have triplets have average birth weight only around 1600, while quadruplet has 1300 only compared to 2300 grams of twin pregnancy. Average gestational age of delivery is about 32 weeks in triplet, while only 29 weeks in quadruplets, as compared to 35 weeks in twins. With a growth restriction, almost 50 to 60% of triplets and quadruplets have a growth restriction. The average NICU admission is 75% in triplets and 100% in quadruplets compared to twins, which is only 25%. The average neonatal stay in NICU is like 30 days in triplets, and quadruplet it costs 8 days compared to 18 days. So yes, it is bad for the fetus also to go through a multiple pregnancy. Apart from neonatal complication, maternal complication like preeclampsia, gestational diabetes, PROM, PPH is also higher. Yes, it put the financial burden on the family, the quality of life change of the parents, parenting burden, there are higher rates of depression and child abuse. And that's why it is, as Bila madam said, multiple pregnancy is not a human reproduction behavior. So fetal reduction is a procedure to help to get rid of that dilemma. Now, what is the exact pre-operative procedure what we go through? So whenever the fetal reduction patient came, first go through a proper USG assessment and 2D mapping. This 2D and 3D mapping is required, especially when it is higher than 3, like triplet or quintuplet, because when there is twins, we can easily say, okay, lower one or upper one, which you want to reduce. But when it is triplet, when it is quadruplet, which fetus, the upper, lower, side, up, that you have to map in a very initial phase. You decide what are the number of the fetus, what is gestational age, what exactly the size, position, zygosity. Of course, anti-scan also done, anatomical survey, so that will help you which fetus to target, basic antenatal investigation. And after all this, the most important is counseling. What you should include the counseling in. So you should discuss about the chance of complete loss, the chance for preterm delivery or full-term delivery after or without procedure, how many alternative methods you are left with, what are the benefits of the procedure, what are the risks of the procedure, operative care you have to follow up later on, and of course the consent for anesthesia also has to be taken. Now let's see what are the routes of this fetal reduction procedure. There are 3 basic routes. That is first done by transabdominal route, second transvaginal, and third is cervical route. And now which route is better? Of course, transabdominal route is much better. Complication rates are very high with the transvaginal route, almost 16% with transvaginal in compared to transabdominal, only 2%. Convenience is very high with transabdominal. Even when you use a freehand technique, not any guide is used, still it is very convenient. In transvaginal, it is a narrow angle myopic vision, so targeted reduction is a bit difficult. But of course, when it is guided through, for beginner, it is easy to go through the transvaginal route. Now come to the procedure. What instruments are required? It's basically, yes, sonography machine with both the probes, whichever technique you are using, guide if you are using through transvaginal, needle, and then potassium chloride. We generally usually do the transabdominal method.
At this point, add a hysteroscopy, rule out adhesions and other things, and also put the endometrium for biopsy.
I think there is some audio disturbance, please.
Some points of calcifications, or sometimes
can the technical team take care of this?
Should I continue or should I just stop?
Yeah, now you can continue. Yeah, we can hear you.
So at our institute, we usually do the transabdominal and freehand technique, so without any guide. Now, which needle to be used? There are multiple needles available in the market. So which needle to be used? The basic selection criteria is should be smallest bore. The length of the needle should be appropriate, so you can target the depth of the fetus if the fetus is a lower one. It should be able to reflect the sound wave, so it is easily visualized through during the procedure. The tip visualization is very important when you are hitting the target, and of course it should be sharp point so that it will minimize the pain. It's just a single shot and it's done. Generally, we use a spinal needle of 23 gauge for doing this procedure because it gives us very good echo reflection and it's very small bore. So even we can do under local anesthesia also. Now, exact procedure. So after you have taken the patient to the OT, whether you go with a short general anesthesia or we can do in the local, since last 1.5 to 2 years since the COVID, we have started doing in a local anesthesia only, no general anesthesia. Decide the target, which fetus you want to target. If there is again this happening, okay. If both the fetuses are same, just go through normal fetus, target that fetus first. If any suspicious, go with the fetus which has a smaller size, smaller sac, anatomy, poor fetal movement, or any fetus with subchorionic hematoma. Target that fetus because the future prognosis of that fetus is less in that. No gender bias, of course, but convenience should be in mind. Now, go through intrathoracic or direct intracardiac puncture, but if it is not possible, you can just inject supradiaphragmatic, pull back the plunger and confirm that your needle is in heart. Just move a needle bit and you can see that it is in thorax, and then just inject the KCl, potassium chloride. I'm sorry. Okay, now which are the different methods of reduction? As I said, the best method is inject the KCl, potassium chloride, and that will cause a cardiac asystole. Another method is you just puncture the heart and do the air embolization. Another one, puncture the heart, no KCl, just puncture till the asystole develop. Another one, you just aspirate whole blood from the heart till the asystole develop. When it is done in an earlier phase, like 7, 8, or 9 weeks of gestation, you can do aspiration of an embryo with a needle, or you can just dilate the cervix and aspirate the GS. But the best method, which everybody is using, is an intracardiac KCl injection. But always before injecting KCl, just put in mind that KCl will not remain inside the cardia. It may diffuse elsewhere or adjacent sac also. There are cases of limb amputation, anencephaly, pregnancy loss been noted with this procedure. Sometimes that remaining tissue or necrotic tissue may involve the inflammatory reaction, production of prostaglandins and cytokines. There are incidents of periventricular leukomalacia been noted in the preterm surviving twins. So always before injecting KCl, just make sure your needle is where you want to inject. Just move a needle bit so you can see that fetus is moving along with your needle, and that will give you the confirmation that your needle is in your target. And then you just inject and you can see the gush of fluid coming from the tip and the cavity. Now, when we were doing this procedure, we can accidentally sometimes, when that intrathoracic procedure is not possible, we sometimes encounter the fetal cranium, which is entered by accidentally first, and then we see when inject in a fetal cranium, it will also stop the fetal cardiac activity. So we try to do more in another patients, and we can see that both technique is equally giving the good results of fetus loss rate, fetal reduction, similar success rate as of the intrathoracic. So when there is intrathoracic is not possible, you can go in an intracranial insertion. What is a post-operative? Always before discharging the patient of the fetal reduction, just confirm the asystole by sonography, confirm with the patient, confirm with the relative, because many a time it happens when the cardiac asystole happens and after 2 to 3, 20-30 minutes, again, you can see the heart again started beating or bradycardia. So again, you might need a procedure. So always do a sonography and advise the rest for 15 days. Of course, there is a big learning curve. Any interventional sonography procedure comes with a long learning curve. Expertise comes with the time and number of the procedure you saw, you assist. The loss rate is inversely proportionate to the operator's experience. What are the complications being noted in this procedure? So it will vary according to the site of the puncture, which route you have selected, how many fetuses were there and how many were reduced. The complication to be listed are major is an infection and septic abortion, amniotitis, bleeding. This is one video which is going on. You can see this extra amniotic bleed happened in the fetus which we reduce, but it usually will resolve within 3-4 weeks. Damage to the nearby GS may sometime happen. Technical failure, you are going to asystole, then again your heart gets start pumping. Abortion, premature leaking, premature labor pains is also. Psychological impact, of course, and the monochorionic placentation and its problems. The pregnancy loss rate is very high as the number of the fetus is high. It is maximum when it is quintuplates or sextuplates, and it is lower as a triplet or twins. So at the end, I would just love to share some institute's data, which are recently been going to be published in a journal. Of the last 21 year of 975 cases, out of which 805 were done by transabdominal route and 170 were done by transvaginal in the initial phase. And since last, I think 10 years, we have stopped doing transvaginal route, even if it is not approachable. Just the lower segment, the bladder and transabdominally very nicely. Intracranial method of injecting have been done in 25 cases. All the cases we did with the potassium chloride injection, almost 2 to 3 ml average needed. So this is a case 975. The majority, as you can see, are the triplets and twins, out of which majority were conceived by IVF and IVF procedures. The loss rate is, there is the total 32 cases, out of which 18 were lost by the transabdominal and 14 by the transvaginal route. If we see the cessation of cardiac activity in comparison to the sites, we can see that there is equal in heart and intracranial insertion. For almost 5 to 10 seconds, we can see the cessation of activity. The highest time been taken when it is going intra-abdominally, and the almost when it is in thorax, it gives almost equal like 10 to 20 seconds. When we started doing intracranial, then we see the literature and we found two data. There is one comparative study been published in the fetal diagnostic therapy, where they compared two cases where 16 cases were intracranial injection done and 24 with intrathoracic injection. They found that intracranial required fewer puncture. They both required similar dose of potassium chloride, and they both succeeded very nicely with no heartbeat recovery, with similar miscarriage rate and the same gestational age at delivery. There are one case report published in 2009 also, where they injected intracranially potassium chloride, and they preferred this method, technically easier, but they only reserve this only for selected cases where it not approachable to go to cardiac or thorax. Only in those cases you should go for the intracranial injection. The complication which encounter in our setting is there are 20 cases with bleeding, and 32 cases we had abortion, and 30 before 32 weeks and 2 were after 30. So I would like to conclude my talk by saying that multiple pregnancy, of course, carry high risk to both mother and fetus, so proper counseling should be required. Transabdominal and freehand is the best approach for fetal reduction. Even when lower fetus or unapproachable fetus is there, you just stretch the lower segment by feeling the bladder, and you can easily go through transabdominal and avoid the transvaginal route. Intracranial is another alternative when you cannot go to intrathoracic or intracardiac needle insertion. And of course, prevention is always better than cure. Fetal reduction is very traumatic procedure, both for the patient as well as the clinician who is doing. So please carefully use the ART procedures, your infertility treatment, so that you reduce the chances of triplets or higher order pregnancies. So limit the number of embryo you transfer during each treatment cycle. That is the best method to avoid the reduction procedure. Thank you very much.
I think that's wonderful, Dr. Nisha. Thank you, and very good data of your center over this long period of time. But I think one of the most important things that we have to remember is currently in current practice, it is always trans-abdominal reduction. And the establishment of chorionicity is very important prior to the decision. Can I request everyone else to please mute their mics? Dr_221725, can you please mute your mic?
अब ये सीधा एक ही चीज है ना, ट्रैक्टर के लिए तूने पैसे लिए थे 1,80,000 का एक महीने का ब्याज, 2,000 ब्याज होता है।
Can we please mute your mic? Can the technical team help me? Can you just mute everybody so that? Okay, so I think fairly clear messages by Dr. Nisha, and most important is we should first do the 11-week scan and establish the anatomy of all the fetuses before taking a decision for reduction. So waiting till 11 weeks helps both ways. It helps that if there is any spontaneous miscarriage to happen in any of the sacs, that also happens, and you can choose the healthier fetuses to stay and the unhealthier ones to go. And like she mentioned, there can be technical difficulty sometimes. So again, it is not a life-saving procedure at that moment. So you can wait for a couple of weeks. Suppose it's very difficult to access a particular sac and you are at 11 weeks. There's no problem. Just wait till 12 weeks or 13 weeks. And then as the uterus grows, it will be easily accessible. So what we do is instead of going transvaginal or transcervical, we wait. We try the filling of the bladder and all those things. Suppose it is still not in position, there's no harm in waiting for another week and then proceeding. An aspiration of the cardiac fluid and all, as of now, we don't recommend it. In case it is a monochorionic pregnancy, then you should consider non-pharmacological methods. There is some study about injecting glue, but again, that still leaves scope for exsanguination of the normal twins. So needle laser is and cord coagulation would be the two methods that would be recommended there. So I think very good presentation by Dr. Nisha. I think we are done with our session. Prakash sir?
No, but just we finish it in time.
Yes, sir.
It's very important.
Right, sir. Okay.
Thank you, Dr. Chinmay and Dr. Prakash.
Thank you.
Thank you to all the speakers, Dr. Manish, Dr. Bela, Dr. Nisha, and Dr. Jai. Now we move on to the second part of this session. And for that, I invite Dr. Mukul Shah and Dr. Jignesh Gadiari. They are the chairman of this session. Dr. Mukul Shah.
Hello, am I audible?
Yeah. Dr. It's my pleasure to introduce Dr. Mukul Shah. He is a senior consultant gynecologist from Ahmedabad. He has vast experience of teaching in NHL Municipal Medical College, LG Hospital, and GCS Hospital. He is multifaceted personality. He was the youngest chairman of the Standing Committee of the Ahmedabad Municipal Corporation, youngest deputy mayor, then became the youngest mayor of the Ahmedabad Municipal Corporation. He set an example that when a doctor enters active politics, what difference he can make in health services. So, sir, Medical Association is indebted to you.
So nice of you. Thank you.
He has held many positions in university also. He was Pro VC and VC of Gujarat University. Apart from that, he was the Chancellor of Indira Gandhi National Tribal University of Madhya Pradesh. And he is also member of Governing Council of National Forensic University and chairman of the selection committee appointed by Home Department for taking interviews of the academic position of National Forensic Science University. I welcome you, sir. He is really faceted and very high dignitary. And the other chairman is Dr. Jignesh Gadiari, my younger colleague from Navsari and member of the host society. He is practicing here and has main interest in endoscopy, sonography, and high-risk pregnancy. I welcome Dr. Gadiari also. Thank you. Now, Mukul Shah and Gadiari, please carry on the session.
So indeed, thank you very much, sir. Indeed, a matter of a great pleasure for me to be here on the occasion of Yuva Fogsi conference. I am really thankful to Dr. Vipulbhai Kapadia, Dr. Gajjar and his team for giving me an opportunity to be at the end of this session. Now I'd like...
driving mode for you.
Shall I continue?
Yes, driving mode में बैठ के देने का.
Hello.
Go ahead, sir.
So I gladly invite Dr. Sohali Agrawal for her talk on preterm premature rupture of the membrane.
Dr. Suhani Agrawal is not attending this. So we may have to skip a lecture.
Okay, then. Dr. Kavita Kapadia, madam.
Yes, sir.
Hello.
Hello.
Good evening, madam. Good evening.
Good evening, sir.
So please, without wasting a single minute, I gladly invite you for your talk on color Doppler in pregnancy intervention.
Good afternoon, everyone. I would like to express my gratitude to all the Fogsi office bearers, Dr. Alpesh Gandhi, the organizing chairperson of the Yuva Fogsi, and the entire NOGS for giving me this honor of coming on this platform and presenting my talk on color Doppler intervention in pregnancy. The concept of Dopplers was introduced in the 1940s by an Austrian physicist by the name of Christian Doppler. He described how the observed frequency of light and sound was affected by the motion of the source. The principle of Doppler in ultrasound is explained on the fact that when the sound wave meets a moving object, there is a change in the angle of inclination and the angle of reflection, which leads to a change in frequency, which produces what is called as the Doppler shift, which happens to fall in the audible range. There are many different types of Dopplers that are commonly used in obstetrics: the continuous Doppler, pulsed wave, duplex, color Doppler, power Doppler. For the sake of convenience, I'm going to divide these Doppler indices into arterial, venous, and cardiac Dopplers. I'm only going to touch upon the Dopplers most commonly used in obstetric practice. There are, however, a myriad of different options in Doppler that people use, from the hepatic vein to the inferior vena cava, the cardiac Dopplers, which may be beyond the reach of this talk at this point of time. There has been a huge paradigm shift from using Dopplers in the third trimester towards using them in the first trimester. The first trimester nuchal scan is an excellent time to interrogate the uterine artery, which is imaged at the level of the cervico-isthmic junction. The volume and flow characteristics of this change with advancing gestation. What contributes to an abnormal uterine artery? We all know that an increased pulsatility index of more than 95th centile or more than 2 standard deviations above the normal contributes to an abnormal uterine artery index. There's also debate about the notching, and the notching or the uterine artery pulsatility index, both either unilateral or bilateral, are proven to be as a risk predictor for preeclampsia and for intrauterine growth restriction. This is based on the rationale that the arteries, the spiral arteries, haven't been able to convert themselves into uteroplacentile arteries. In a meta-analysis, which included 74 studies of preeclampsia and 61 studies of intrauterine growth restriction, it has been shown that an increased PI with notching was indeed the best predictor of preeclampsia, with a likelihood ratio of 21 in high-risk pregnancy and 7.5 in a low-risk pregnancy. The likelihood ratio of intrauterine growth restriction was 14.6. These are just a brief overview of the uterine artery indices that we use. Another meta-analysis by Velatur et al. Showed that using the uterine artery indices, we could predict the adverse pregnancy outcomes. The early onset preeclampsia had a sensitivity of 47.8%, early onset growth restriction of 39.2%. To conclude, the first trimester uterine artery Doppler was useful in predicting early onset preeclampsia and other pregnancy outcomes. And these are the women who should be started on aspirin. There are various different guidelines, the NICE guidelines, the ACOG guidelines, which use clinical factors and history to decide which women are at high risk. But however, if we use the ACOG criteria to treat women with aspirin, we notice that 2/3 of the population will be needed to treat in order to achieve our goal. This all revolutionized when Kolekar et al. Came up with the idea of combining the uterine artery indices with the maternal history, the biophysical factors, and the biochemical markers, the PAPE and the placental growth factor. The screening program with this will identify 90% of pregnancies at risk. We have this study where we've identified women at risk. What do we do with them? Ever since 1997, the talk has happened about using of aspirin. People have talked about the side effects of aspirin. Well, it's all put to ease with this ASPRI trial. The ASPRI trial was a prospective multi-center trial which included 29,641 singleton pregnancies. They used the maternal history, the mean arterial pressure, the uterine artery Doppler, the Pape and the placental growth factor, and they came up with a factor of preeclampsia. Women who were at a risk of developing preeclampsia of 1 in 100 were randomized to 150 milligrams of aspirin. They noticed that administration of aspirin at a dose of 150 milligrams per deciliter per day from 11 to 14 weeks until 36 weeks of gestation reduced the incidence of preterm preeclampsia by 60%. Hence, this is the first point of intervention that we would use using color Doppler. The next Doppler that we commonly study is the ductus venosus, which is imaged as an aliasing vessel in the sagittal view at the first trimester scan. An abnormal ductus flow is when there is a reversal or an absent A wave. How do we interpret this? Remember that in the setting of an abnormal NT, when you have an abnormal DV, this is a very strong marker for chromosomal abnormalities, and hence intervention in the form of early karyotyping and an early 2D echo may help. What about those pregnancies with a low risk with a normal NT? Well, these have not shown to be a great predictor of cardiac disease. The other place where I think the ductus venosus plays a very, very important role is in twin-to-twin transfusion syndrome. In monochorionic twins, when either one of the twins shows an abnormal Doppler, you know that these pregnancies are at high risk of twin-to-twin transfusion syndrome, and these are the ones we need to monitor at 2-weekly intervals beginning from 16 weeks. The tricuspid regurgitation is often used as a marker during the first trimester scan. But however, studies have shown that isolated finding, it does not seem to be a strong predictor of congenital heart disease. But in the setting of an abnormal NT with an abnormal DV, this can, however, guide us to a high risk of cardiac disease. We move on to the second trimester. A lot of us still continue to use the uterine artery index in the second trimester. But is any intervention at this point going to benefit or going to change our outcome? No, not really. Then why do we do it? It's because doing a uterine artery Doppler at this point and finding that the artery indices are elevated, we can find the fetuses who are at risk for intrauterine growth restriction. And these are the fetuses who need to be subjected to a growth scan between 26 to 28 weeks. The second trimester poses a challenge in twin gestation, in monochorionic twin gestation, especially where we see a myriad of events like twin-to-twin transfusion syndrome, twin anemia polycythemia complex, the twin reversed arterial perfusion, intrauterine death of one twin. Now, all these, along with an RH sensitized pregnancy, we use the MCA PSV to monitor these pregnancies and to determine the degree of anemia that is present. The Quintero's classification, which kind of stages the twin-to-twin transfusion syndrome, uses the Doppler indices. And we know that when we have an abnormal Doppler, it is already Quintero stage 3, and stage 2 and stage 3 are the point of time where you'd like to intervene and either do a photocoagulation. This chart over here shows us the staging depending the staging of the twin arterial anemia polycythemia syndrome, and it grades the severity and the correlation along with the hemoglobin difference, which was found at term. Just a brief overview of the procedures, which already my predecessors, Dr. Bela, have shown. Moving on to actually the most important Doppler studies that we do is the umbilical artery Doppler. Now, remember, the umbilical artery Doppler cannot be used to diagnose IUGR. IUGR is still diagnosed that when an estimated fetal weight is less than the 10th centile. However, when we use 5th centile, we have a higher chance of identifying those fetuses at high risk for adverse outcomes. But then why do we use this tool? We use this tool to monitor the intrauterine growth restriction. And it also helps us to differentiate those fetuses who are small from those fetuses who are growth restricted. What contributes to an abnormal umbilical Doppler? When the pulsatility index is more than 95th centile, this normally happens when more than 30% of the villi cease to function. There's an absent or a reversed end diastolic flow when 70% of villi are destroyed. You have a fetus who is more than 34 weeks, has an abnormal umbilical artery Doppler. You can go ahead and do an MCA Doppler. The MCA Doppler indices when less than the 5th centile. We know that these are the fetuses who are at risk for acidemia, and these are the fetuses who should be delivered. However, in preterm small for gestational age or IUGR, the MCA Doppler should not be used to predict acidemia. There's a lot of talk about the CP ratio. Meta-analysis have shown no predictive value for predicting the adverse perinatal outcome. But however, the Porter group showed that the adverse outcome with a low CPR less than 1 was 18% compared to 2% when the CPR was higher. Coming to preterm fetuses between 24 and 34 weeks, we need to screen them using the ductus venosus, which has a moderate predictive value for acidemia and adverse outcomes. The DV should be used for surveillance in preterm small for gestational age fetuses and to be used time for delivery. This is just a brief overview of the cascade of events that happens. There's a decrease in the fetal abdominal circumference, the umbilical artery Doppler indices increase, the MCA-PI decreases, there is absent or reversed end diastolic flow, the MCA-PSV increases, the cardiac performance deteriorates, you have an abnormal ductal flow and a tricuspid regurgitation. At the end of the spectrum, you have a change in the BPP, there are late decelerations and decreased beat-to-beat variability. However, this may not exactly happen in the sequence, and any of this can happen during any of those times of the Doppler changes. How do we go about monitoring these growth-restricted fetus? If you have a growth-restricted fetus, you've done a Doppler, the Doppler studies are normal, you want to repeat it after a week. If they're normal, then these can be done every 14 days. If you have an abnormal Doppler, that is the pulsatility index is more than the 95th centile, the fetus is more than 34 weeks, you can use the MCA and the CPR and the DV to assess hypoxia. These fetuses should be monitored twice a week. In case of fetuses who have absent reversed end diastolic flow, you are waiting to administer steroids. These fetuses should be monitored every day in the form of CTG. Do any of these interventions really help? Well, oxygen therapy, sildenafil, which was tried, which seemed promising, but a Dutch trial threw it out of the window because of the risk of pulmonary hypertension. Antihypertensives, bed rest don't really help. Cessation of smoking, if done earlier on, may help a little bit. The real mainstay is to buy you time while you give steroids. The timing of delivery. Now, our goal is to maximize the fetal maturity and growth, minimize morbidity and mortality of the preterm fetus. You have a growth-restricted fetus between the 3rd and 10th centile. Normal Doppler, the ACOG suggests delivery between 38 to 39 weeks. You have an absent end diastolic flow in the umbilical artery more than 34 weeks. Go ahead, deliver these babies. Less than 34 weeks provides a challenge to us because we need to administer steroids. If the fetus is less than 32 weeks, magnesium sulfate should be administered for neuroprotection. However, if you see an umbilical artery reverse diastolic flow at greater than or equal to 32 weeks, you will deliver this baby immediately. A persistent A-babe reversal on the DV Doppler more than 30 weeks, deliver these fetuses. Before 30 weeks, you may individualize the decision depending on your setup, depending on your NICU. There was a study, which was the growth restriction intervention study, which studied 588 fetuses between 24 and 36 weeks. They compared the results of immediate delivery to expectant management. That means there was an interval of about 4 days difference between these two groups. They found that there was no difference in deaths prior to discharge or the overall deaths. However, fetuses more than 500 grams, greater than 24 weeks, if the abnormal flows were seen, these fetuses were delivered. The Truffle group did a study, which was a prospective randomized multi-center trial. They studied fetuses between 26 to 32 weeks. They used a CTG only criteria to deliver in the first group. They used the early DV changes in the second group, and they used the late DV changes in the third group. They found that the proportion of infants who lived without neurodevelopment impairment at 2 years were 85% in the CTG group, 91% in the DV group, 95% in the late DV group. This was, however, accompanied by a non-significant increase in the perinatal and infant mortality. However, the suggestion goes that using both the Doppler and the CTG is a wiser way to go forward. You have a small for gestation age fetus with an absent or a reversed end diastolic flow. Delivery by cesarean section is recommended. For small for gestation age fetuses with abnormal umbilical artery PI and end diastolic velocity present, induction may be offered, but remember the rates of cesarean section at this point is high. Women who come in spontaneous labor should be admitted immediately, and continuous fetal monitoring should be carried out. The MCA Doppler is used to monitor fetal anemia. Prior to the use of this MCA PSV, we used to do an amniocentesis and try to find out the optical density of the amniotic fluid. The MCA PSV was introduced by Mari et al. Based on the principle that fetal anemia leads to decreased blood velocity, viscosity, and the PSV of the blood increases. This is a quick overview of the mom values of the MCA. When do we intervene? When the MCA PSV is more than 1.5 moms, you do a cordocentesis. You ensure that you check the fetal hematocrit, the acidotic state of the fetus. When the hematocrit falls to less than 30%, go ahead and transfuse. Our aim is to maintain the fetal hemoglobin at 9 grams %. We do a serial Doppler evaluation every 1 to 2 weeks. The sensitivity of this PSV for prediction of moderate and severe anemia without high drops was 100% with a false positive rate of 12%. It had a great detection rate post-transfusion in the first and second one, but not so in the third one. I must say one thing, that it's very easy to perform these Doppler indices, but interpretation of these Dopplers must be done very carefully. I think it would leave my talk incomplete if I didn't thank my mentor, Dr. Rajesh Desai, who left us last year in August 2020 as he succumbed to COVID. He's left a huge void in our hearts, and I will forever be indebted to him for all that he's taught me. Thank you all for a very patient hearing.
Thank you very much, Kavita, for a wonderful talk. You are absolutely wonderful as usual. So here we come to the end of this session, and I thank all of you for joining us, and I congratulate Navsari Obstetric and Gynec Society for this wonderful academic feast. So thank you.
Thank you very much. Thank you.
Thank you. Thank you.
Thank you, Dr. Kavita, Dr. Jignesh, and Dr. Mukul Bhai.
So nice of you. Thank you.
Conclude this session.
Thank you.
Thank you. Thank you so much, sir.
Thank you.
Now we will move to next session, that is valedictory session. Quiz session, sorry, quiz session. 1 second. And,
hello.
And I welcome Dr. Nilesh Balkode, Dr. Akash Gajjar, and Dr. Vaibhav Kapadia. Hello.
Hello. Hello. For the quiz session, I invite Dr. Nilesh Balkavde, sir. Hello. Hello, Dr. Nilesh Balkavde.
Dr. Akash? Hello?
Hello,
Dr.
Dr.
Akash?
Yes, yes.
Jalak here. We have a different link for a quiz. I have sent it to you in organizer group. Please check it and join in that link.
Okay, okay. Okay.
Yeah. For quiz, we have a different link. And we do the quiz on that link only.
Okay. Yeah.
Hi, can someone please post the link for the quiz? Many delegates are looking for the link for the quiz.
Kindly give us 2 minutes to check everything and get back to you.
We are here with the Hall A link, but it's showing a waiting of 56 minutes. So what does that mean? Shall we stay here for the quiz?
Stay there. Just stay there. Just give us a couple of minutes to get at the technical end. We'll check and get back to you, please.
Hello.
Dr. Archana.
Oh. Hi.
Hello.
Yes.
The valedictory function will take 10 to 15 minutes more.
What percentage of reduction in the incidence of preeclampsia in patients starting with prophylactic use of aspirin in the
Ma'am, I think the quiz is still going on. I've asked someone from Viva Events to get in touch with you. Zalak is going to call you.
Okay.
Kavita? You're muted. Hey, I just wanted to.
Yes, sir. Sorry.
Hi.
Yes, so I'm right here.
15-20 minutes?
Yes, sir. The quiz is going on. Another 15
I was just watching the Friends reunion, so I'll keep on doing
you
that.
can
Will you
continue
message me when it's ready?
You can continue watching that.
Huh? Yeah. Okay.
Okay, sir.
भूख लगी है।
Dr. Gajjar? Hello. Dr. Kavita?
Are you able to hear? Please respond.
We can start valedictory here.
Yes, ma'am.
Okay.
Just give me a minute.
All right.
The team A is -5. Yeah, team A -5.
કેમ મનુભાઈ તમે દેખાવ છો?
કેમ મહેન્દ્રભાઈ દેખાય મનુભાઈ ના દેખાય?
ના પણ મારા વાલી દીકરીઓ વાળા દેખાતા નથી.
અમે
આવી ગયા ભાઈ.
અમે આમાં મતલબ થોડાક
વગર કેવી રીતે કામ ચાલશે આગળ?
વિપુલભાઈ કોંગ્રેચ્યુલેશન.
કેમ છો?
બસ બસ એકદમ ફાઇન.
ભલે આમ લાડુ ઉપર ખસખસ જેટલો ભાગ હોય, સેતુબંધમાં ખિસકોલી જેટલો ભાગ હોય, પણ નવસારી સોસાયટી જોડે આઈ એમ પાર્ટ ઓફ ધીસ ઇવેન્ટ.
पटेल सर, गुड इवनिंग सर.
गुड इवनिंग प्रियंक.
तो बहुत अच्छा रहा सर.
यस बहुत अच्छा रहा.
આજનું તમારી ડિબેટ પણ બહુ સરસ હતી ખરેખર.
એમ ને?
મજા આવી ગઈ.
એટલે ફાવટ આવી ગઈ છે ને.
વિપુલભાઈ, નરેન્દ્ર, ગુડ ઇવનિંગ. હાય એમસી.
યસ ગુડ ઇવનિંગ દીપક.
શું કરે છે? બસ
ઓલ વેલ ઓલ વેલ.
હાય દીપકભાઈ, હાઉ આર યુ?
હાય ગુડ ઇવનિંગ. કેમ છો વિપુલભાઈ? બરાબર. મહેન્દ્ર સુતો છો કે શું કરે છે?
ના ના આરામથી બેઠો છું. ન્યુ મોડ ઓફ
હાય પરાગ.
ન્યુ વે ઓફ કોન્ફરન્સ.
I know.
Hi Deepak, good to see you. Hi Manu bhai.
Yes, welcome Parag.
Yeah, conference without food to food packet તો મોકલાવો જામનગરમાં.
ભાઈ અમે આ વિચાર્યું હતું પણ એ મટીરીયલાઇઝ ના થયું.
તો કઈ વિચાર કરો.
પૂછો ગજ્જર ને મારે વાત થઈ હતી. મેં કીધું જો કોઈ કંપની તૈયાર થાય ને તો ફેકલ્ટી લિસ્ટ એને આપી દેવાનું. માનો કે જામનગરમાંથી 5 જણા. તો 5 જણાને 1 વાગે એને જે જોઈતું હોય ને એને ઘેર ફૂડ પેકેટ ડિલિવરીમાં મળી જાય. ટાઈમ બહુ ઓછો હતો. હા
વાપી દમણવાળા કઈ બીજું પણ માંગે છે.
Are all the members for the valedictory function logged in? Are all the members there for the valedictory?
પણ પછી મટીરીયલાઇઝ ના થયું કારણ કે ટાઈમ બહુ ઓછો હતો ને સમય જો મળ્યો હોત ને તો એ પણ વિચાર્યું
કરો કઈ પેલા અમારા જવાનો વિચાર કરો ફૂડ માટેનો.
ના ના એટલે એમ જ કે દાખલા તરીકે પીઝા હટ વાળો માનો કે જામનગરમાં તૈયાર હોય તો તમે જેટલા પણ જામનગરની ફેકલ્ટી હોય ને બધાને ઘેર 1 વાગે એ ડિલિવર થઈ જાય પીઝા હટ.
કઈ ને હવે નેક્સ્ટ ટાઈમ ડેલિગેટ ફી લઈને કરજો ને પણ કરો ખાવાનું ખવડાવો.
ચાલો બધાને બોલાવી લો. બોલાવી લો ચાલુ કરી દઈએ.
Dr. Gajjar, can we start?
Yeah, you can start. Ask Dr. Gajjar. Where is
Dr. Gajjar?
He is muted still.
Gajjar uncle, can you please unmute?
No, he is unmuted, but I think Yeah. Now he is muted.
Let me phone him.
ચાલુ છે નરેન્દ્ર બોલ.
Gajjar uncle, we're going to begin. Is it all right?
Hi, Alpesh.
Hi. Good evening.
Good evening, sir.
Good evening, everyone. We have now come to the end of what ended up becoming a lovely academic feast, thanks to the contribution of all the members of the Fogsi, the ICOG, the wonderful efforts by the Navsari Obstetrics and Gynac Society. Moving ahead with the valedictory function, I would like to invite Dr. Vipul Kapadia to give us the welcome address.
Good evening, all Foxians. Valedictory ceremony is at the fag end of an event. Welcoming to the fag end of an event is ironic. But still, a function is a function is a function, and I have to invite you for this end of the event ceremony. I particularly invite Dr. Alpesh Gandhi, Dr. Archana Basir, Dr. Jaideep Tank, Dr. Meg, all ICOG office bearers, all members of SAFOG, all the chairpersons, co-chairpersons, and all persons who took part in all the sessions. Well, Navsari Society is a small society consisting of only 48 members. It was established in early 70s with late Dr. Maltiben Rana as a founder president and my mother, Dr. Ramabin Kapadia, as one of the founder members. It was inaugurated then by late Dr. R.D. Pandit. But it began to grow gradually, and it encompassed the towns, the neighboring towns of Vapi, Valsad, Chikli, Billimora, Maroli, and in 1979, we staged the first state-level Congress, SOGOG. We also then matured into staging 4 more state-level congresses over a period of time. We also staged 1 more mid-term SOGOG. It's a moment of great pride for us today that Navsari Obstetric Gynac Society has moved a step further from the level of the state conferences to the national zonal conferences. It's my earnest wish that very soon our young brigade will take it to the national level. Well, the West Zone Yuva Congress Conference has been very satisfying event so far for all of us, the organizers, and I would like all of you to be a part of our joy. With these few words, I welcome you all to this last session, the session of wishing you goodbye and Thanksgiving. All the very best, and welcome to the valedictory ceremony. Please, I hand over to Dr. Narendra Gajjar for further elaboration.
I would now like to invite Dr. Narendra Gajjar to guide us to the roadmap. Dr. Gajjar, who is the president of the Navsari Obstetrics Gynac Society and the organizing chairperson of the West Zone Yuva Fogsi 2021. Dr. Gajjar, over to you.
Thank you, Kavita. And roadmap, a road is not that smooth and straightforward, which appeared while we thought of hosting this conference. There were many factors. The dates which were given to us were 4th, 5th, and 6th September 2020. But there were lots of uncertainty. Hopes were coming and hopes were vanishing. And that was the reason we had a very short time for planning due to unfortunate, unexpected, ravaging effects of COVID-19. At the last, everybody had lost the hopes, but thanks to Dr. Alpesh Gandhi, thanks to Dr. Vipul Kapadia, And thanks to Dr. M.C. Patel, who motivated me, and then we decided to host this conference. Finally, maybe a virtual, maybe bypassing the advantages of Daman, hospitality, but ultimately we finalized it in April. So we thought to postpone the date in June, but dates were not available. But there are certain good things on our side also. The foremost thing that there was exorbitant response from faculties because there was no mega event since last 1 year in the form of some physical conference. And let me say that people were really waiting. They were eager for a 3 days conference. Maybe because of the change in lifestyles, maybe because of no travel, maybe because of we do not have to make some arrangements for the lunch and dinner, which Dr. M.C. Patel said that Zomato and all, but these are all in the virtual form. What we say, that is a virtual thing. Maybe we are losing entertainment, but ultimately the last thing that attracts delegates is nothing but scientific. We leave all these apart and we have tried our level best to provide scientific feast to all participants. And the result is 1,623 registrations plus 130 faculties, 50 esteemed chairpersons, and 9 honorable judges. So that includes 1,812, which I think in physical form also we have been able to attract. PICSEP workshop, 263, 40 papers out of 24 were presented and 58 posters. Our 9 judges, even they had to plan out the whole schedule because they thought at one stage that it would be difficult to give us this. So this is the result before you, and at one time maximum attendance in this was more than 1,200. So we tried to follow all the protocols which we got from Fogsi, but the whole credit goes to Fogsi office bearers, President Fogsi Dr. Alpesh Gandhi, Vice President Dr. Archana Baser, Secretary General Dr. Jaideep Tank, organizers of PICSEP workshop, ICOG chairpersons, faculties, and delegates. Last not the least, delegates, because we got tremendous response from you all. So when a mega event is organized in short time, in adverse situation, for a smaller society, it is possible that there might be some lapses. As far as scientific is concerned, we have left no stone unturned. Regarding rest other, I acknowledge and respect your patience, and please bear with us. Our focus of attention is young youth talents, involvement and encouragement. So in the end, I request you all to analyze this conference, not in terms of result, but in respect of our efforts. Thank you all.
Thank you, Dr. Gajjar, and 3 cheers to your team for conducting this conference flawlessly. It went away beautifully. It gives me immense pride as I invite our enterprising and dynamic president of the Fogsi, Dr. Alpesh Gandhi, to share a few words. Dr. Alpesh Gandhi, over to you, sir.
Thank you, Dr. Kavita. Very good evening to all of you. What a wonderful end of a very successful conference based on Yuva Fogsi. I'm happy to see one more feather in the cap of Navsari Society. I'm proud of Navsari Society for keeping their promise and to organize the conference successfully in a short time in this difficult time of COVID-19 pandemic. As Dr. Vipul Bhai has mentioned, I know Navsari has organized 4 state level conference, SOGO, and today one more feather, you have organized one national conference. and you deserve it. You deserve a big applause for this. Very successful conference, wonderfully organized, and it was an example of vision, meticulous planning, proper execution, and a great teamwork. You have a very vibrant, enthusiastic team, and it was a great teamwork. Interesting scientific program, good combination of young faculties and senior experienced faculties, good take-home message, and we can say it finishes in time. All credit goes to the organizing team and my friends of Navsari Society, Dr. Narendra Gajjar, Dr. Vipul Bhai, Dr. Kamlesh Bhai, Dr. Beena Ben, Dr. Satyen, and all the team members, organizing team members of Navsari Society. I would like to congratulate Dr. Archana Bassar, Vice President Fogsi, in charge for this successful Based on Yuva Fogsi conference. Under her able leadership and guidance, Navsari Society could organize this conference with success. And she was always there. There was continuous guidance and constant inspiration from Dr. Archana Bassar. I'm also thankful to Dr. Jaideep Tank. Whenever I received a call from Narendra Gajjar for any protocol, I was telling only one thing: please contact Dr. Jaideep. And I am sure he will definitely guide you better and you will have the proper protocols and everything. So my job was very simple. If I received a call, I was telling, please contact Archana Bassar. Otherwise, for protocol, I was telling, please contact Dr. Jaideep. So my job was very simple. And I'm happy that we had declared that Based on Yuva Fogsi conference will be organized by Navsari Society during our installation at on 31st January 2020 at Lucknow. And today I can see the dream of organizing Based on Yuva Fogsi conference at Navsari completed with great success. You have only 48 members in your society, but believe me, you have not only 48 members are there, but you have won the hearts of all the Foxians. So it's a very, very important that in spite of so many hurdles, as you have mentioned, roadmap was not smooth. There were hurdles, but in spite of so many hurdles, in spite of so difficult time, and in spite of a new initiative of digital platform, you all could successfully organize this Based on Yuva Fogsi conference with a marvelous success. More than 1,800 delegates, more than 100 paper poster itself speaks about the success of the conference. And yes, we are the part of the joy of Navsari Society. We all are one family. And because of this, we have right to say that our Daman hospitality is remaining and we will come to you for Daman hospitality. So please remember that once everything will be normal, we will be there for Daman hospitality. Thank you very much for giving me this opportunity. Thank you all the organizers for once again, congratulations to all the organizers for this wonderful, successful and conference with a great scientific deliberation. Thank you.
Thank you, Dr. Alpesh Bhai. Thank you very much.
Thank you so much, sir. We couldn't have done it without your support is all that I'd like to say. As we move on, and I'd like to invite our very zestful and spirited Vice President of the West Zone, who is in charge of conducting this conference, Dr. Archana Bassar. Dr. Archana Bassar, over to you.
Thank you, Kavita, for kind invitation. I can say when I was listening to Dr. Alpesh Gandhi, that is society of 48 members, I think they have done an amazing, fabulous job. And I must say Vipul Bhai and Narendra Bhai are like Shankar Jaikishan. I mean, they are so much in synchrony. I mean, if you tell Dr. Gajjar that, yeah, we have to do this, let me check with Vipul Bhai. I have not seen such a great, bond and a, cohesive work. They really did work together. So my all the congratulations to Navsari Society. And I really made good friends, Dr. Gajjar, Dr. Kapadia, Dr. Satyen, and I came to know this young brigade, Kavita, Akash. I think it was a really, really dream come true. Though we couldn't come to Daman, but as Dr. Gandhi has said, you will be inviting the whole office bearers of 2020 to Daman. You promised to us, Dr. Gajjar and Dr. Kapadia today, that we will be there with you, and you have to, we will enjoy together. So congratulations. It was a mammoth job, mammoth task, done meticulously, executed very well. And we had 1800 delegates. It itself is telling the amount of work you people have done. So congratulations and thank you very much for, giving me this responsibility, Dr. Alpesh Gandhi, to work with Navsari Society. So all the best for the future.
Why not we, madam? With you. Only officers.
Yeah, everyone from the Navsari Society and all those who were part of the team, really congratulations. And we would love to meet all of you.
Mahendra Bhai, it means this is the formal valedictory session, but real valedictory session with all of us will be again organized by Navsari Society at Daman.
Yes, certainly organized in Daman.
Yes.
We have got lots of contacts and we have got, we can create a very good environment in Daman.
Yes.
The last two conferences people have witnessed, and while, they were meeting each other, they were repeating the last 5 conferences and saying that the best was Daman. Last Sogok 5 they were enumerating, and the last remark was passed that the best was Daman. So our invitation is pending, and once COVID goes, we all will meet again.
Thank you,
I just have one more addition, a little addition to make, that in all thanksgiving to organizers, cannot forget Dr. Manubhai Patel. Dr. M.C. Patel has guided us in every possible way, and without him and without his guidance, we could not have proceeded further. Thank you, Dr. M.C. Patel.
Thank you. Welcome.
He is our chief advisor, Dr. M.C. Patel.
Yes.
Thank you so much. Thank you so much, Archana ma'am. It was wonderful to hear those words coming from you. Moving on, I would now like to call upon our very charismatic organizing secretary of the Fogsi, Dr. Jaideep Tank. Dr. Jaideep?
Thank you. Thank you, Kavita. I hope I'm audible.
Yes, sir.
Yeah. So, we come to the end of a magnificently successful conference. And I cannot help but recall what Timothy Findley said. He wrote this book called The Wars. And he wrote that the spaces between the perceivers and the thing perceived can be closed with a shout of recognition. And in effect, this valedictory really is our shout of recognition to all those who have made this event possible. The entire team of the Navsari Society, all the advisors, you all have done a magnificent job. Really, I mean, many, many congratulations to you. Sometimes as Fogsi Secretary General, I sometimes wonder, why do societies do conferences? It's so much work, and you are not really getting anything personally out of it. And I can only conclude that you do it for the love of Fogsi. You do it for your want to help women's health, and you do it for your love of education. So thank you very much, really, from all of us at Fogsi. You are, of course, a part of Fogsi for organizing this absolutely wonderful conference. I would particularly like to acknowledge our dynamic president, Dr. Alpesh Gandhi, the vice president in charge of the conference, Dr. Archana Baser, and of course, the president and also the chairperson of the conference, Dr. Gajjar. the secretary, Dr. Satyen Kasabwala, Dr. Vipul Kapadia, the chairperson, and also I think Vipul Bhai Yuva had put together an absolutely superb scientific program. Many congratulations for that. Dr. Beena Nayak and Dr. Kamlesh Mehta, the co-chairs. Dr. MC Patel, of course. I know, everybody calls MC Patel sir evergreen, but I think he's actually wearing white clothes all the time. So he's, ever white. And of course, Dr. Vaibhav Kapadia and Dr. Akash Gajar, the joint secretaries. Thank you very much. Let me, at the end, remind you that hosting this virtual conference does not absolve you of hosting a physical conference. We are all looking forward to coming and enjoying your wonderful hospitality. At the end, I was just watching the Friends reunion special before this, and I cannot resist but say this: we'll be there for you. And end by quoting from the bard William Shakespeare, who said, "I can no other answer make but thanks and thanks." Thank you very much.
Dr. Jaideep, MC Patel is not only ever white, he is ever white or evergreen, he is ever young.
Absolutely, sir.
Thank you.
Thank you, sir.
Thank you so much, Dr. Jaideep, and I apologize for calling you the organizing secretary. I meant Secretary General. I truly apologize for that mistake. I'm so sorry.
Dr. Kavita, it's
That's
an
okay,
honor.
Kavita.
It's an honor, Dr. Kavita. Don't worry.
It's so like, sorry. It's like, what they say, rose by any other name, secretary, doesn't matter.
I think it's a lot of work. It takes a lot of work. So I don't think.
Dr. Kavita, it shows Navsari Society consider Jaideep as a part of Navsari Society. So you are considering organizing secretary. It's honor.
Always. Thank you so much. Thank you so much. I will now give away my responsibilities, and I would like to call Dr. Dhwani Gajjar to take over the responsibilities for the valedictory from here. It was wonderful to be able to be amongst you all. Thank you so much for this patience. Thank you. Dr. Dhwani, over to you.
Yes. Thank you, Dr. Kavita. Good evening, everyone. Everyone, I has indeed been a pleasure to have all of you be here. We are finally going to the ending of this conference with an exciting part. That is give the prize distribution. So for that, we will anchoring our new Yuva talents. So first of all, I thank to all the judges. They have they're doing best in this paper and poster presentation. They are Dr. Rajan Thakur, Dr. Yamini Trivedi ma'am, Dr. Aarti Patel ma'am, Dr. Aswini Machani sir, Dr. Deepa Pitre sir, Dr. Priti Punatakar, Dr. Shilpa Sapre, Dr. Sunutiben, Dr. Maitri Shah. Thank you all of these judges for giving their valuable time and your valuable information. And also thank to all the participant students. So now we are moving to our next session for prize distribution. Which poster presentation prize distribution which is conducted on the 28th May, and their judges are Dr. Vashchani sir, Dr. Aarti ma'am, Dr. Deepa Pitre ma'am, Dr. Yamini ma'am, Dr. Priti Nagar, Dr. Smriti Vaibhav. So category for the conference theme, the consolation prize on the 6th position is Dr. Ketul Barot, PSM Ramsar, and at the 5th position, Dr. Dhaval Patel, Smear Hospital, Surat. On the 4th prize, Nidhi Ramani, doctor. His topic was laparoscopic ovarian transposition to save the ovarian function before the pelvic radiation from the Smear Hospital, Surat. On the 3rd prize position, Dr. Mrinalini Agrawal. The role of the prophylactic balloon occlusion of the internal iliac artery in a case of the placenta previa from the Surat Smear Hospital. And on the 2nd position, Dr. Aishwarya Nayak, obstetric hysterectomy with the 24 weeks fetus in situ in a case of the placenta previa from the Smear Hospital, Surat. In a 1st prize position, Dr. Jaga Jayadas, twisted ovarian tumor complicating pregnancy from the MGM Aurangabad. Congratulations of all of the contestants. The other category of the miscellaneous, the consolation prize on the 6th position, Dr. Kush Thakur from the Ahmedabad, On 5th position, Dr. Palak Patel, PSMC Karamsar. On the 4th prize goes to Dr. Rutvi Thakur. The case report of the successful management of the acute myeloid leukemia in the pregnancy from the GMCS Surat. On the 3rd position, Dr. Urvangi Thakur. On the decision dilemma in the young patient with the ruptured hemorrhagic cyst of the ovaries and the von Willebrand's deficiency, the PSMC Karamsar. On the 2nd position, Dr. Sujita Modi. From the successful outcome of the COVID positive mother with the pulmonary embolism, and this is from PSMC Karamsar. On the 1st prize, Dr. Rajat Sharma, the fever, tachypnea and the falling SpO2 in the ANC patient in the COVID pandemic, not always COVID, from the GMC Akola. So again, I am congratulating them all, and now announcing the another postal presentation result.
Paper.
So, sorry. For paper presentation result, the category miscellaneous, the consolation prize on the 6th position, Dr. Pooja Doifode, MGM Aurangabad. On the 5th position, Hetri Kalathia, Spemer Hospital. On 4th position, Dr. Sonali Chauhan from Varda. And on the 3rd, Dr. Sejal Patel. Our topic is evaluation of the fetal-maternal outcome in the PROM from the Spemer Hospital, Surat. Second prize to the Regia. Our topic is clinical outnatal patient affected with COVID virus retrospective study, the PSMC Karamsar. And the first prize to Dr. Sweta Kumari. Our topic is use of the clinical situation to enhance the basic obstetric skill in the final year MBBS student. And the PSMC from the PSMC Karamsar. Now the result of the category conference theme. The consolation prize on the 4th position, Dr. Tanvi Chaurasya from the Varda. And on the 3rd position, Dr. Nidhi Patel from the Smemer. And the 2nd prize goes to Dr. Sapna Sharma. Our topic is treatment of thin endometrium with the intrauterine installation of autologous RPRP from the Varda. And on the 1st position, Dr. Rajat Sharma. Our topic was postpartum cough and novel way to estimate the obstetric blood loss accurately and save the maternal life from the Government Medical College, Akola. So congratulate all the students and thank you all the judges. We will give prizes and certificates from at your place. Thank you all. Now,
our participants to express their views and opinion about this conference, because suppose we are saying we don't give neutral opinion for us, but you are the real judges for us, and you are the people who will say what we have done and what we should have done. Thank you. Dr. M.C. Patel is the chief advisor of this conference, and I request him to express his views. Dr. M.C. Patel.
Thank you, Dr. Narendra Gajjar. It was very pleasant experience to work with Team Navsari under able leadership of Dr. Narendra Gajjar and Vipulbhai Kapadia. As rightly said by Narendra Gajjar previously also, Navsari society was in dilemma whether to do conference or not to do, because dates were not getting fixed in which month they are able to do it, because the original conference which was scheduled in September 2020, it was not possible due to this COVID era, and ultimately this was the situation. but I was just behind Dr. Narendra Gajjar. Though you are a small society of 48, you have much potential and you have already done SOGO 4 times. You can do this one more conference at very success level. And we had a small video meeting, Narendra Gajjar, Vipul Kapadia, and Satyan and myself. And I insisted, Navsari Society practically, you have to do it. No way. And still they were in dilemma, which way we should do. Physical conference, virtual, or hybrid. And ultimately, as time was very short, it was decided to go virtual. And result is before you. Because though it is smaller society, but each one is university in their capacity. As far as any ability to deal with a function given to them is concerned, whether Narendra Gajjar is there, whether Vipul Kapadia is there, or young brigade like Akash Gajjar or Satyen or Kavita, and of course with seniors participation like Kamlesh Mehta and Bina Ben. So they all were behind this conference at last, and ultimately they could do it. Because I was telling every time, we will find the way. So let us begin. And once you begin, then there is end to it, and it is there. And just Dr. Narendra Gajjar also said, so it is up to all the delegates, all the participants to analyze what was this conference. And when you do analysis of this conference, and he also said, not in a way of result right, but efforts. And for that, I usually give very good example. So I will share that. एक बिटिया की शादी थी, बारिश का मौसम था, और इसके पिता ने ऐसे सोचा कि बारिश का मौसम है, बारात आएगी, ये लोग परेशान ना हो, इसलिए अच्छी तरह से इसकी तैयारी की जाए. तो जो जगह थी जहां मैरिज होनी थी, इसका टेंट बन रहा था, तो पिता ने पर्सनली ध्यान रखते हुए पूरा टेंट वाटरप्रूफ बनाया, ताकि बारिश आए तो भी बारातियों को भी कोई तकलीफ ना हो और दे कैन एंजॉय ऑल द मैरिज. बहुत अच्छी बात हुई, बारात आई, मैरिज अच्छी तरह से संपन्न हुआ, और भोज चल रहा था तब बारिश तो नहीं आई, लेकिन जोरों की आंधी आई और पूरा टेंट तहस नहस हो गया. अगर इसका मूल्यांकन परिणाम के रूप से करेंगे तो बाराती कुछ परेशान तो हुए, लेकिन अगर ये बिटिया के पिता ने जो प्रयास किए थे, ये प्रयास का मूल्यांकन किया जाए कि उन्होंने बाराती परेशान ना हो, अच्छी तरह से पूरा समारोह संपन्न हो, इसलिए व्यक्तिगत रूप से उसने ध्यान देते हुए जो जो प्रयास किए थे, इसका अगर मूल्यांकन किया जाए तो हम नाराज नहीं होंगे. और ऐसे ही मैं कहूंगा कि नवसारी सोसाइटी का जो प्रयास था, ये प्रयास की जो अगर हम प्रयास का मूल्यांकन करेंगे तो मैं मानता हूं कि नाराज होने की कोई संभावना इसमें मुझे नहीं दिखती. मेरा रोल सिर्फ 2 ही बात में था, दो आई वॉज चीफ एडवाइजर. हनुमान जी को जाम्बुवन जी ने ये बताया था कि तुम में कैपेसिटी है, तुम चाहो तो पूरा समुद्र लंघन कर सकते हो, श्रीलंका में पहुंच सकते हो. मेरा रोल यही था. नवसारी सोसाइटी को मैं बार बार कहता था कि आप में ये कैपेसिटी है एंड यू कैन डू इट, एंड दे हैव डन इट. सो माय जॉब वाज दैट. एंड सेकंड जॉब, गिलहरी जैसा राम सेतु जब बन रहा था तो गिलहरी का जो छोटा सा प्रयास था, तो मेरा प्रयास एक कॉन्फ्रेंस में एक और जाम्बुवन जी जैसा और दूसरी ओर एक गिलहरी जैसा था. लेकिन आई was very happy to work with team Navsari under leadership of Narendra Gajjar and Vipul Bhai. So thank you very much team Navsari and Narendra Bhai and Vipul Bhai for giving me opportunity, and thank you very much again, and over to you.
I fully agree with Dr. MC Patel. I have also received so many calls from Dr. Narendra Gajjar, and I was always telling that, don't worry, you had done in the past, you are capable, and you will definitely do. Please go ahead. and we can see the result, how much marvelous, how much successful, wonderfully you all have done this conference.
Agreed, Dr. Alpesh Bhai and Dr. MC Patel. The most important asset for us is your faith in us. And
Is your hello?
Your faith in Nalsari society, we are really thankful to you.
You are muted, Dr. Narendra Bhai.
Thank you, MC Patel sir. Thank you, Alpesh sir.
Hello, am I audible?
Yes. Now you are audible.
So, we are thankful to you for your trust and confidence in Nalsari society, and that brought this result. Thank you very much.
Now I would like to invite Dr. Deepak Bakre sir to share their view and opinions.
Okay. There is lots of noise coming in. Okay, it's fine now. Am I audible now?
Yes.
Okay. You know, for most of the people who are here in the valedictory function, they know how Fogsi designates a center for a West Zone conference. It is not easy. Let me tell you, for a society, it started from there. You know, what confidence Navsari got from the President Alpesh Bhai, Archana, Jaideep, and all the Fogsi members to get a chance to host a West Zone conference. It's not a joke. There are only 4 zones, and you get a zonal conference from Fogsi. So you had a bag from accepting the conference. You took the challenge, and I think, as most of us will feel, that you've been successful. The best part, what I feel here is, you know, if I was there personally in Navsari, I'm sure there would be a standing ovation. Here, I'm sure at least we can clap. At least for my personal side, I will give a standing ovation. It is such a wonderful conference, especially when young brigades were involved. See, basically, being a Gujarati and being a Sogok member, my heart is also in Sogok first. When you organize 4, you trained the young brigade. And I'm sure the young brigade of Satyan, Vaibhav, Munjal, Akash, Kavita, Dhwani, and the rest know how to organize a conference. As Jaideep said earlier, why people take conference? Lose of sleep, lose of practice, you lose everything. But still, Dr. Vipul Bhai, Dr. Narendra, Dr. Archana's support, Dr. Alpesh support, everyone has done a marvelous thing. And I'm sure the delegates who are listening to me, they would echo me and say, this has been a wonderful, wonderful conference. And the registration of 1800 itself says. But as rightly said, you know, we have to have one conference in Daman. And I'm sure there is going to be a West Zone part 2. Anyway, congratulations to all the organizing team from all of us delegates and the participants for having this wonderful scientific program. Yes, there were youths, the idea of Fogsi was to get youths involved, and you have done it well. 60% to 65% of the faculties were from the youth side. Yes, you require some of the seniors, but still, the youths really took over. And look at their scientific content. I wouldn't say it was anything less than any senior faculty's material. I would say some of them were really good, and I'm sure they're going to be great orators. Thanks for giving a chance to a youth for coming up in Fogsi. Thank you, Fogsi. Thank you, Navsari. On behalf of all of us delegates, I mean, there's been a really wonderful knowing Knox again. And not forgetting, we are having a Sogog also one other time. Thank you very much.
Thank you.
Thank you
Thank
so
you,
much.
Dr. Deepak Bhai.
I would now like to invite Dr. Priyankur Roy, who is the East Zone Coordinator, for the Fogsi team. He's a consultant infertility and gynec endoscopic specialist in Siliguri. Dr. Priyanku Roy.
Yeah, thank you, Dr. Kavita. It gives me immense pleasure to get an opportunity to speak in this valedictory function. My interaction with this Navsari team started through Dr. MC Patel sir, who first gave me a call and said, I have told Dr. Narendra Gajjar sir to involve you in the program, as I wanted someone from the East to get involved in the program. I must indeed say the involvement that Dr. Narendra Gajjar sir showed for this program was awesome. I mean, every morning there used to be a couple of messages from sir, some instructions from sir of how to take this conference forward in a better way. And of course, as I could see, I mean, the East Zone Yuva Fox is also coming up. I'm the organizing secretary of that. And we see the difficulty that we have in hand because we were totally undecided about whether we are doing physical or whether we are doing virtual. It was physical. We were thinking of doing it physically. Again, the COVID wave increased, and again we had to think of virtually. Again, it's decreasing in between, and you're thinking whether you can do a hybrid. So that was the scenario, and in that scenario, the way this conference has taken shape and has been executed was really awesome. Really worth the applause that they're getting already from the seniors. So congratulations, sir. And my role today as the MOC in the first half, then I had a talk in the afternoon, and now in the valedictory gives me a feeling that I'm part of the Navsari society, and it's an immense, great feeling when the team has done so well and when you're getting applause from everyone, sir. So congratulations, Narendra sir, congratulations, Vipul sir and Satyan sir, and also of course all the young brigade that everyone is applauding of. So congratulations, very well done. And the registration you're talking of 1,800 with very nice attendance is again an awesome thing. And of course the subjects chosen, the topics chosen was again another thing of like interest for everyone. So that's how the registration stayed, and that's how the delegates stayed on. Thank you so much for giving me the opportunity. And of course, if you are doing another physical meeting in Daman, I would love to be a part of it. Thank you so much, and take care.
Dr. Priyankur, it was an opportunity for you to learn how to organize Yuva Foxy conference.
Absolutely,
and next
sir.
Yuva Foxy conference you are going to organize. So I am sure you are benefited a lot.
Absolutely,
you will
sir.
have everything now ready with you, all the protocols, everything now ready with you, and the team West Zone Yuva Foxy is with you for East Zone Yuva Foxy at any time. If you need any help, any support, any guidance.
Of course, sir, I will need help, support, and guidance from you definitely, and plus from the West Zone team because I've already done it, and I've already told Narendra sir about the same. Like any guidance I require, I'll be taking it from him. Thank you so much, and I invite the whole team of West Zone Yuva Foxy to the East Zone Yuva Foxy, which we are doing on 18th, 19th, and 20th June.
And one more thing, there should be a vice versa. You will be invited for Daman, and you will invite all of us at Siliguri.
But
Definitely,
at the same time,
sir. The invite is always there.
Priyankur, at the same time, based on your Foxy, Navsari team has put a conference at such a level that any society to do any kind of this Yuva Foxy conference to
will be difficult.
that level, you will have to work hard.
Absolutely.
Navsari has put that level very high.
No, MC, you know, the way the things are going on, I'm sure he is going to level it, if not take one step ahead. Priyankur, all the best, I'm sure.
But
you will do good. But definitely the West Zone team has set the level very, very high. And to emulate that is going to be very difficult. Even the technical team has done a great job. It was an excellent overall organization that has happened.
But I am advisor there at East Zone Yuva Foxy also. So,
come on. Now, Priyanka, where are you working? With Alpesh and MC with you. Why are you worried?
So I am preparing Priyankur to set his goal much higher to Navsari. So he will work accordingly, and he will.
At least MC, at least in valedictory today, don't say that you said high. This is the best today. Priyankur will say it was better.
Absolutely. Absolutely, this is the best conference, and definitely. And one more thing I would say, sir. Actually, at least in Siliguri, I'm getting some time for the conference to happen, and the way Navsari Society has taken it up in such a short time and done it is fantabulous, sir. Excellent work done, and congratulations, Narendra sir, Vipul sir, and Satyan sir. Thank you so much.
Thank you so much, Priyankur. It was indeed a great amalgamation of the East and West, and I'm sure Navsari will leave no stone unturned to help you if you do need us at any point of time. Last but not the least, Moving ahead, I would like to invite the Secretary of the Navsari Obstetrics and Gynec Society, Dr. Satyan, to give his vote of thanks. Dr. Satyan Kasabwala.
Good evening, ladies and gentlemen, esteemed dignitaries, especially Principal Secretary and Commissioner Health and Family Welfare, our own Dr. Jayanti Ravi, our beloved faculties all over India, and my dear friends and colleagues, also who have braved this year in the worst pandemic of century and whose success we celebrate today. It gives me immense pleasure to stand before you, and you can say virtually, on behalf of Navsari Obstetrics and Gynec Society, which is one of the smallest society of Fogsi. It's been a momentous year for all of us, an attempt to sum it all up at the end of our conference. I would actually like to start taking us to the beginning, actually to the very beginning, from where the idea to organize the Wisdom Yuva Fogsi at our center. We all know powerhouse, or you can say the most enthusiastic DO chairpersons and heart of Navsari Society, Dr. Narendra Gajjar and Dr. Vipul Kapadia, immediately agreed for the proposal. First of all, I would like to thank our Principal Secretary, Jayanti Ravi Madam, and for sparing his valuable time in a most busy schedule in this pandemic. Out of all Wisdom societies, our society took the challenge from our beloved President, Dr. Alpesh Gandhi. And I would like to thank our beloved Foxy President, Dr. Alpesh Gandhi. He immediately agreed for the proposal, and we accept the proposal that time. And everything was finalized basically at to held conference in Daman 2020 in September. All the preparation was started laboriously, and suddenly, as we know, first wave of COVID-19 pandemic has been started everywhere, and there was a lockdown implemented. Lastly, we have to cancel the mega event by downcast and with heavy hearted. Again, just 1 month prior, we got opportunity from Alpesh Gandhi sir and Dr. Archana Base madam to arrange the mega event virtually. As always, we are ready to grab the opportunity, and we are with you with this event. I would really like to thank Dr. Archana Base madam, who always stood with us at any particular time with her wholehearted and sincere support to make this event mega success. I want to thank from the bottom of my heart to all the Foxy bearers who in unfeigned support to our society, in the Secretary General Dr. Jaideep Tank, all the Vice President, Deputy Secretary Generals, Treasurer Dr. Suvarna Khadilkar, and Joint Treasurer Dr. Parikshit Tank. I would like to thank JOGI and ICOG office bearers to the timely support and cooperation to our society. I also thank all the speakers, committee chairperson, master of ceremonies of giving their genuine and sincere support. For us, not the easy task to organize and arrange and assemble this event in very short time. But I already mentioned powerhouse DO of our society, Dr. Gajjar and Dr. Vipul Kapadia, are simply stupendous and astonished. Association of marvelous and wonder job done by Dr. Vaibhav and Akash beside me made this event so pleasant and relaxing. I would like to thank my registered delegates who genuine presence in this virtual conference till end made us proud. Yeah, in this virtual event, whose web portal we are using right now, who we can sharing the thoughts, and the marvelous platform is given by Mr. Kevan. I would like to really thank him for this extraordinary and extravaganza. And I would like to thank Ms. Jalak and Mr. Rohan, who left in between for this family issue to provide this spectacular event. I would like to sincerely thank Pharma Associate, whose financial and mental support throughout this event, Mr. Ratandeep from Tablet India, and Unison 3D Pharma. Without his name, this event was not possible. Mr. MC Patel, sir, Chief Advisor, whose involvement and sincere support for making this event mega success. I would genuinely like to thank him for his wholehearted support. Least but not the least, I would like to thank our own Navsari Society Foxy members who always stood behind us for every event and their trust. I also would like to thank our neighbor society, Surat, Valsad, Vapi, Bharuch, Baroda, Ahmedabad Society, also with all other Gujarat societies with their kind support, and neighbor state Maharashtra, Rajasthan, MP, Goa, and Chhattisgarh. I would like to thank all faculties, judges, moderators, speakers, apart from our Gynec friends, our PSM colleagues, Dr. Madhu Moitra and Dr. Vaibhav Garat, for their sincere support. Lastly, I would like to thank Dr. Neha Patel and my junior colleagues from Navsari Civil Hospital for their full support from backstage, starting from Dushyant, Jaimini, Charmi, Sandhya, Krishna, Anita, Urja, Dhaval, Meenakshi, Jinal, Pooja, and Dhara. If anyone remain in this list, please beg me pardon. Thank you once again to everyone.
Dr. Satyen, congratulations to you also. And if you remember, once we were at Mumbai airport and we had a discussion, and we had a discussion that you will have to play a significant role, a big role. And that was, I think, our team took over at Lucknow. Before that, I think around in September month, we had a discussion at Mumbai airport. And I am happy to see you had played a big role very successfully.
Thank you, sir. I told you I can hold your bag also, sir, during 1 year.
Yes.
Satyen,
like to
Satyen, just one more thing, Dr. Satyen. I think our conference would not have been successful without a very efficient support by the event manager. Please enumerate them.
I would like to appreciate efforts of Jhalak, who at the last moment picked up the responsibility where we are really desperate and almost on the verge of living hopes, because we were in the midst of the COVID, where the mortality and morbidity from COVID was very high. And that was the depressing point for us. And our event manager, Rohan, he also left the host. But when I talked with Jhalak, she said, "Arre Sahib, hame karisu, don't worry." She was so much confident, and that phone call with her reassured me that yes, we'll be able to do. I would like to express sincere thanks to our judges. Let me tell you, they have worked very hard, because they have left no stone unturned in assessing, not only doing their sincere and dedicated work, but they have inspired our juniors. They have taught them. While they were presenting papers, they really participated very nicely, and they were asking questions, and they were really encouraging these juniors, and really they did a very nice work. And I would like to say thanks to Dr. Rajal Thakur, Dr. Yamini Trivedi, Dr. Dipti Pitre, Dr. Aarti, Dr. Preeti, Dr. Sapre, and all the Dr. Ashwin Vachani. They have really done very hard work. Let me tell you, they have done very, very hard work. And I am really thankful to all judges. My salute to them. And really, I am thankful to all of you.
Thank you, sir, for opportunity. Thank you, sir.
And of course, all the master of ceremonies.
Yeah. And
all
last,
the master of ceremonies.
Yeah. Master of ceremonies, really sitting in front of the computer for hours together, and with their mind being occupied, Dr. Priyanku, Dr. Dhwani, Dr. Kavita, Dr. Aditi,
Dr. Narendra Gajjar.
Thank you, thank you.
I might have missed, but forgive me for that. But I really appreciate Dr. Ajal Mangukia. Really, they have worked very well, and they are the key factor.
Dr. Narendra Gajjar, thanks to ICOG for the credit points.
Yeah, and I really express my thanks to ICOG persons, Dr. Mandakini Meg, Dr. Parag Viniwale, really very helpful person. Anytime, no formality. Anytime you just ask him, he will give you solution within 1 minute. And Dr. Parul Kotrawala, I would like to express my thanks to journal people, chief editor of journal Jogi, Dr. Geeta Balsarkar, Dr. Ashwini Rao Gandhi, Ashwini Balarao Gandhi, and all other speakers who really did a wonderful job, and they successfully done this PICSEP workshop. Really thanks to Fogsi, thanks to office bearers of the Fogsi, thanks to Aarti Jabade, thanks to Maria, and thanks to all who have directly or indirectly helped us in organizing this function. We might have missed the names because of this, busy schedule, but really I express thanks from my heart. Thank you all.
I think Dr. Binaben wants to tell something.
Binaben, you are muted. Please unmute.
Alpesh sir, before Beena ma'am unmutes, I just wanted to add on one point, sir, because you just mentioned about Dr. Satyan and you had a discussion with him regarding the conference in the Mumbai airport itself. So, sir, this last year that we have worked with you, we know this much for sure. If you set your mind on something, sir, we know that you will motivate us to get it done. And the way this last whole year you have made us work, though you're coming to the end of your term, but then we will remember this forever, sir, because it's been your phone calls in the anytime in the day 12 घंटा में ये चाहिए, and you know that okay fine वो करके देना है because that is the work that's there for us. So your motivation also really drives us through this whole thing, and of course Jaideep sir as well, the way he also coordinates, so it's very nice. And Alpesh sir, it's been awesome working with you for this last whole year, plus of course this last month that's coming ahead for us. Looking forward to your presidential conference as well, sir, when you are planning to do it. Thank you, sir.
Dr. Panag Biniwale, Dr. Panag Biniwale, please.
Thank you. Good evening, all, and it's been a pleasurable 2 days listening to all the Yuvas. In fact, Alpesh, just for your information, my bond with Navsari Society started 10 years ago when Dr. Gajjar's son came to Pune to be my student, and he did his DNB with me. So my visit to Navsari was due for last 10 years, and thanks to you, at least I could visit Navsari virtually. I must compliment Dr. Gajjar, Dr. Kapadia, and the entire Young Brigade for a fantastic conference. Also refer to the ICOG session that we had, where we had 3 very young speakers speaking in depth on different subjects like viral hepatitis and heart disease, etc. And they also did a marvelous job. The attendance, the quality of presentations also matters, and it's indeed a pleasure to listen to all the Yuvas. So thank you for associating with ICOG, and I'm happy that ICOG, led by President Dr. Alpesh and Chairperson Dr. Mandakini, has granted 12 credit points. And I'm sure all the youngsters, once they complete 10 years of post-graduation, will join ICOG as fellows. Thank you for the opportunity.
Thank you, Parag sir, for providing this valuable support in our conference, sir. Hope to see you soon at Navsari, Chikhli, sir.
Sure.
Dr. Gajjar, if we're done,
Yes.
should we end the day?
Yes.
Dr. Jal.
Are we closing the session of valedictory function?
Sir, if anyone has anything to say, they're more than welcome. But if not, we'll wind up.
Jalakben, kasu kehu છે?
Binaben wanted to say something.
Bas, thank you so much for believing me. Bas, આટલું જ કહેવું છે.
Binaben wanted to say something. Binaben, you are still muted. Please unmute yourself. So there is some connectivity problem.
I think so.
There is some connectivity problem with Binaben.
Yes. So anyway.
No.
So, should we call it a day? Should we wrap it up? Does anyone have anything they'd like to say?
Okay, bye.
Bye-bye. Thank you.
Thank you. Bye-bye.
नवसारी सोसाइटी तो अभी भी ऐसे कहेंगे अभी ना जाओ छोड़ के दिल अभी भरा नहीं, लेकिन
I think
every good thing has its own end and it should be ended.
Thank you so much, everyone. With this, we conclude the West Zone Yuva Fogsi 2021 on an excellent note. Thank you all for your support. We couldn't have got here this far with all the Fogsi, the ICOG, the NOGS, all the backstage staff, all the attendees. We couldn't have done this without you. Thank you, and 3 cheers, Team Navsari. We did it. Thank Thank you all.
Thank you.
Thank
Congratulations.
you.
Thank you.
Thank you so much.
Thanks.
Thank you.